She supports you 100%.
Yeah.
She just keeps
Thank you.
There he is again.
Hey, man.
Exclusive schools in the city of Chicago, so Chicago area. Also,
We have a jam-packed agenda, so I want to start in the next minute. So if everyone could take their seats. And can you bring the slides up? There we go. My name is Dan Cole, the president of the Anesthesia Patient Safety Foundation, and it's indeed a pleasure to welcome you to this consensus conference that we do every September, the Stoelting Consensus Conference. Here you see on the first slide our vision, which we take very seriously, that no one shall be, is this my slides? Yeah, that no one shall be harmed by anesthesia care. And we've picked a very relevant topic today for the consensus conference, emerging medical technologies. And really, I would consider these to be disruptive in the sense, in very positive sense, the same way that ether was disrupted 150, 200 years ago, led to a lot of positive change. But we have to do it right. We have to do it in a safe manner. And so Dr. Feldman, who I will present a little bit later, has put together a great program for you on this issue. Just a couple, 3 slides about our foundation. That's the foundation of the American Society of Anesthesiologists. This is what we basically do. And I'm not going to belabor this too much, but we fund research grants. We provide education. We do this every September. Last November, we held a consensus conference on perioperative hemodynamic stability. And we started to publish some of these in peer-reviewed journals as far as our recommendations. We have a newsletter that conservatively goes out to about 650,000 people in the world. It's translated, I believe, into 8 languages and is read by somebody in every country in the world throughout the year. We're very collaborative, realizing that there is a mountain of work to do in patient safety, and that one organization working in a silo accomplishes less than when we all work together to achieve our mission. We have communication platforms. Please go to our website, apsf.org. We also have a social media presence where we spread information on patient safety. And finally, we've gotten a little bit into advocacy. We're not a big advocacy organization, but we have sponsored bills in Congress. We have written to regulatory agencies about measures that are out there. And so we're very, very active. We make a very good use of our resources. Just to highlight for next year's program, it'll be in Boston, and it will be the 40th anniversary of actually the meeting that occurred that led to the formation of APSF the year later. So we're going to celebrate, but we're also going to learn. Elizabeth Rebello, who is here, I think right there, there she is. She will be the program chair, and it's a timely topic that we've addressed before, but the issue has not gone away. Transforming anesthetic care, a deep dive into medication errors and opiate safety. We also have 10 priorities that we work on. We don't have the resources necessary to solve all these problems, but we do a deeper dive into some, and then some were very collaborative. And I won't read them off here, but you can see emerging technologies down there, not the 10th one, but this is not a prioritized list, but a very important one. We depend solely on donations. Everything that we do is free. This conference is free. Our newsletter is free. And so we depend upon your donations, corporate support. We're very grateful. Somehow I went backwards. Yeah. We're very grateful to our corporate supporters for this meeting. Here you can see them listed. They'll be listed intermittently throughout the meeting during the intermission. And if you feel so inclined, you can make a personal donation. There's a dip jar back there at that back table. Again, every dollar that you contribute goes to a very worthwhile cause. And let me just take a moment. I'll introduce Dr. Feldman, Jeff Feldman, who's a professor of clinical anesthesiology at Penn and works at Children's Hospital of Philadelphia. But I want to, let's make sure I get the pointer here. This is the Gartner Hype Cycle, which a lot of you are familiar with, and it talks about how technology evolves over time. And this is the curve that you usually see about hype. And you can see, I think, it may be debatable, but we're somewhere near the apex of what this can do. And you can see that typically we start to learn about some of the limitations, and clearly there will be limitations, and we have to implement this technology in a safe manner. But what we're really interested in is this performance curve and the extent to which this meeting can help accelerate that performance curve and improve quality and safety of the patients we care for is the purpose of this meeting. And finally, let me leave you with a quote from Pablo Picasso. Learn the rules like a pro so you can break them like an artist. And this is like what I say, disruptive technology that we're here to break the mold. And if I was able to paraphrase it, master the conventional. We've done a pretty good job of that, but we need to innovate and get better so you can create a new vision and a better tomorrow. And with that, I'll turn over the program to Jeff Feldman.
Thank you, Dan. Good morning, everybody. So nice to see everybody here. Very excited that we're finally at this conference this morning. I do want to make just a couple of thank yous to some folks who played a pretty big role in helping to bring this together. So the planning committee, J.W. Beard, Maxime, Cannesson, Jonathan Tan, were really instrumental, and you'll meet them later as panel moderators. Dan Cole was really useful in conversations about how to pull this meeting together. Some other folks helped with speakers, Megan Lane Fall, Julian Goldman. Wouldn't have come together without all those folks. We have to recognize Stacy Maxwell, who's our prime organizer extraordinaire. Thank you, please. Yeah. We definitely wouldn't have been here without Stacy. Want to thank Jason Slagle and Arnie Abseo on their work on the polling and the technology. And most importantly, want to thank the speakers who are going to make this just an incredibly vibrant program, and the audience. Without this heterogeneous group of passionate people interested in patient safety and technology, we wouldn't have a meeting. So thank you all for taking the time to come. There is a poll ongoing. Let's see. Oh, I'm behind on the slides, aren't I? Okay, now I got it. So there's a poll ongoing. Hopefully some of you have gotten to respond to that. Results are accumulating, and I'll show you some of those. And we're going to try to use that poll throughout the meeting to some advantage. So we'll see how that comes together to find out about what you're thinking. As I was preparing for this meeting, I did a little background work, and I stumbled on the Center for Humane Technology. I don't know, for those of you who haven't found that website, I would recommend it. But this is a group of very accomplished tech people who have a mission now to mitigate the harm to society from AI and related technologies. And the website's loaded with information. They have a great podcast. But at the top of their website is this quote from E.O. Wilson, the noted biologist. And it says, "The real problem of humanity is the following. We have Paleolithic emotions, medieval institutions, and godlike technology." And I like that because it emphasizes that as humans, we seem to have the ability to create technology that outstrips our ability to understand the harm that it can cause and the risks of technology. And so we're in the healthcare sector. I want to bring this to a few challenges to keep in mind as we explore technology in this meeting. And the first one is the value problem. And I'm sure many of you are familiar with this. This is data from the Kaiser Foundation. 50 years in the United States, we have continuously increased our per capita spending orders of magnitude above similar countries. And at the same time, we have failed to really reach outcomes that approach the successes of those places. So we're spending a lot of money and we're not really getting great outcomes. The slide is survival times, and almost any metric you look at looks the same when you start to collect the data. So we spend a ton of money, we don't get great outcomes. Not to say that there hasn't been fabulous technology successes during that time, many lives saved by technology, but it really gets at the next notion of access to care. So some people are benefiting from these advances, many are not. This is data for over the last 20 years. You can see that consistently more than 25% of the US population has either delayed or not taken advantage of healthcare because of cost considerations. And that's been unchanged, if not increasing at different times during that period. So we have a value problem that's been persistent. We have an access to care problem that's been persistent. And now we're reaching a perfect storm because now we have a caregiver problem. So those of you who practice in healthcare settings, very aware of the burnout issue. And it's something that's really festered for many years, probably brought to light more by the pandemic, but our inability to address that in a meaningful way has now led to not only problems with our existing workforce, but a major shortage. So people choosing to leave healthcare, people choosing not to enter healthcare, and the magnitude of this is really stunning. I won't go through the whole slide. I'm sure many of you are familiar with this, but one line in particular, and this is from American Heart Association data, they estimate we need 200,000 new nurses a year to meet the demands over the next 2 years. 200,000 a year, stunning. So we have these really major challenges in healthcare, and we've purposely orchestrated this program to underpin those challenges. So we have keynote speakers that are going to address value, access, and the caregiver issue, as well as panelists that are going to address that as well. So let me just bring that down to home a little bit for what we're talking about here at this meeting. So the basic role of technology is you have a patient, they have a problem, there's some technology. I've pictured a patient monitor here. This could be a pathology slide, it could be a radiology image. It generates some data to a clinician, the clinician makes a decision, and hopefully improves the patient's outcome. Of course, sometimes we get it wrong. And when the root of that wrong decision or poor outcome is related to the technology, then we have to think really carefully about how we're using that technology. Now we're in this age of really expanding the role of technology in healthcare. And so I've pictured patients in beds. This could be patients at home, large populations of patients now. Technology, wearables, for example, one of the big movements that's growing, using the wearables to mine data or extract data from these information from these patients. That then gets passed on to servers, big data, AI algorithms, fed back to clinicians who make decisions that affect patient outcomes. And hopefully we get it right, but we really need to understand how often we get it wrong. And it becomes harder and harder the larger population. And so this is really the arc of the program, taking us from wearables to big data to outcomes and the caregiver experience. That's what we really want to explore over the next day and a half. This quote I also really liked, and I stumbled upon it last week in a podcast. It was an interview with Saeed Obermeyer, who I hadn't heard of before, but he's a pretty accomplished physician and informatician and has done some really interesting work looking at big algorithms and some of the inherent biases. This is a paper he published in Science a few years ago, but the quote, and I'm paraphrasing it from the podcast, is that technology in itself is neither good or bad. It does whatever it's designed to do. It's how we use the technology that determines the impact on patients and on caregivers. And that's what we're seeing play out in the world every day. So our job over the next week and a day and a half and then going forward, really think about how we're going to use these technologies effectively and understand their impact. So I want to finish up just quickly and get to Lee, but I just wanted to share with you some of your responses from the poll. So we got mostly beach goers here, a lot of mountain goers, but mostly beach goers. A lot of dog people versus cat people. I don't know what that means exactly, but we're a little on the old side. We need to recruit some young people for sure. And social media, we've got varying engagement in social media, and I can relate to that. I'm not a social media guy. This word cloud is kind of interesting, and this, I want to give Arnie credit for this, but it really gets at some of the safety challenges, that encompasses a lot of aspects of safety challenges that obviously everyone's interested and concerned about. We have a lot of people who have tried the chatbots and found it to be mildly interesting, mostly, but some people are finding it even useful in their lives. The impact of AI on society requires careful legislation, so we have some common thinking around that. And big data tools. So I think we all recognize that there are some potential negative consequences. But interestingly, a lot of people agree that this is going to be essential to solving the challenges of modern healthcare. So we have these challenges that we're going to focus on, and I can't think of a better person to kick things off than Lee Fleisher to help us really talk about the value equation. Many of you may know Lee, but Lee's spent his biography is in the program, so I won't read it all to you. But Lee has spent his career on outcomes research and is an emeritus professor of anesthesiology at the University of Pennsylvania. Most recently was the director at CMS, and I don't remember the whole title. Lee can maybe fill us in on all the details, but very interesting role right at the nexus of how patients are cared for and how the dollar is spent. So Lee, please join us and share your wisdom.
Thanks so much. And most importantly, I was a student under Jeff. So I think I was a CA3.
CA3 when I was a junior attending.
Yes. So I did learn some of my anesthesia from Jeff, and it really is a privilege to be here and talk about it. And I'm going to use my slides, but I will tell you, as I was listening to Jeff and as I was listening and talking last night, I'll probably go on and off script to talk more about the ways I'm thinking and some of the things that are changing. I'm very fortunate. The last 3 years, I was the chief medical officer and the director of the Center for Clinical Standards and Quality. In that role, I oversaw the care of what it said was 160 million Americans. To make it simple, the Joint Commission reported to this position, and I was responsible for the conditions of participation, the quality measurement program, as well as all coverage decisions at CMS. And in this role, particularly as the chief medical officer, I interfaced very closely with my FDA colleagues, my CDC colleagues, the White House, and others in how we're thinking about, and I will go in and out of remembering that it's only been 4 weeks since I left the agency, and I still get to talk to them because I was the only career staff at the center level, that how I believe CMS, I don't reflect the opinion of CMS anymore, but I also sit on the Bipartisan Policy Center, advising Congress right now with Sheila Burke and Chris Jennings, as well as I just got appointed to the Duke Margolis Center, which is Mark McClellan's center, as well as others, and how I think technology and others would go forward. One of the things that was interesting, both in Dan's brilliant sort of discussions and this racial bias that I'll talk more about later in the program, is it is probably the most exciting and the scariest time possible. So a dear friend of mine, Daniel Kahneman, many of you may know him from Thinking Fast and Thinking Slow. We recently had lunch, and I said, where do you think things will go? And he actually is totally fearful because the questions are, can people use the information correctly? Are we smart enough? Will we be hijacked by system one versus really use our system two, our ability to think through, are these algorithms applied safely? Is the technology applied safely? Let's be honest, I was in the world of pre-op evaluation. We still do testing that makes no sense, right? So how are we going to get it right when an algorithm is going to tell us this is what you should do? And just for my disclosures, besides those two I just mentioned, I'm co-chair of the safety work group and on the steering committee of the Coalition for Health AI, which is advising the FDA and working with the National Academy on AI. And these are some of the questions we're dealing with. In fact, on my trip home, we'll be dealing with. I apologize. I'm glad you're all beach lovers. I actually, for the first time in 3 years, I'm going to take some time off with my wife. So I'll be leaving after this. I'm also on the board for health services and the Digital Health Advisory Committee of the NAM. So there's a lot of groups trying to think about this. The NAM is really focused on the National Academy of Medicine on sort of the ethics. The question of, are we violating the first law of robotics? What about patient autonomy? I'm enrolled in a Master's of Law right now, and in our IP class, one of the students brought in the fact that we're creating robots now to provide comfort to elderly individuals, potentially in nursing homes, so an area I regulated. And you have to ask the question, if the robot is there to protect the patient, but blocks the patient from leaving the room, is that a good thing or a bad thing? What's the ethics of what we're creating, and are we ready to answer those questions? And I will tell you, I don't think I am, but these are some of the things that I think we as a society have to grapple with, and given we're techies in anesthesia, what will we think about? We're all familiar with this whole idea of the value equation, value equals quality over cost, total expenditures. But what I like to ask a lot is, from whose perspective? Is this from the patient's perspective? Is this from the who wants better health, the health system's perspective, which I'll be honest, wants less cost. I hope they still want better health. And as we get back to more financial health in our system, what will they be spending on? What will they be focusing on? And we as clinical leaders, at least the clinical leaders in the room, need to really focus on that. And what does the payers and the employers think about? And this is going to be incredibly important. So a little bit of how CMS is thinking about it, at least my perspective today. This has actually been published. Where are they going, at least this administration? And it's to get that equitable outcomes, high quality, affordable, person-centered care. And it's really about driving accountable care. And it's really about, by 2030, 100% of all Medicare fee-for-service patients will be in an accountable relationship. So part of the question is, as we move out of the hospital, and I'll talk at the end about a program I had the privilege of standing up at CMS, Hospital at Home. As we move out of the hospital and you're thinking about that total accountability, what's the right approach we should take to, if we're responsible for their total cost of care, what's the best for the patient? If they're home, they may not need to go to a SNF, but is it safe enough? And what are the right patients we put into? And are we actually going to have some inequities at some point by actually saying, well, you don't have the same level of home as Lee Fleisher has, where his wife is there and everything's safe, so we're not going to do it. Could this actually increase inequalities? Advancing health equity, a goal of supporting innovation. And at the end, I'm going to talk about the FDA, CMS, and Wear technology. I know there's a lot of companies in the room. Some of you may have heard about a rule that I dropped before I left CMS called the Transitional Coverage of Emerging Technologies, address affordability and the staff. Defining value, and this is something we put out formally, is highest quality. I'll talk more about this. Being safe with the best outcomes, and we really need to recommit to safety in this country. patient-centered and equitable, as well as affordable. What I was really proud of doing with my fellow CMS center directors was saying we're going to align around a set of measures. Now, it essentially started with the HEDIS measures, which are really the Medicare Advantage measures, the NCQA measures, but this idea that the health system is having a trouble because if you go to any hospital or health system, you're going to find a list of quality measures that is super long, that it depends on the provider. And what CMS and my fellow center directors and I committed to was getting to a line set, and that CMMI, the Innovation Center, would really get to the innovation set. So as you're thinking about looking at technology, my hope, at least for what I left behind and what others are focusing on, is you will know the outcomes to really anchor on. Because there's two reasons that's important. One is to just know them. But number two, and I'll talk about FHIR APIs and USCDI, that the ability to actually do real-world evidence and get to an answer faster will be linked. And for anybody who's familiar with the decision regarding the Alzheimer's drug and standing up the Alzheimer's registry, which was stood up by CMS, what we did was essentially do an enhanced claims registry. We took 10 clinical items, we got the beneficiary number, and we're gonna link them and put it into what's called the ResDeck for researchers to actually look at. So there's really this acceleration in real-world data that I think from a technology assessment, people should be anchored around. Now, with regard to value-based purchasing and value-based care, there's really three priorities that CMS is set on. One is growth, and second is alignment, and the third is equity. And in the growth area, I mentioned this accountable relationship, and the growth of accountable care will really improve and promote innovation. Because the idea is not that people, and I'll talk later, what's driving innovation is as you come up with new wearables, the question is not getting paid per widget. And in fact, I have an analog watch. I do not have a digital watch. But not being paid for those widgets, but putting them in a total cost of care environment, putting them in and bundling them to either the physician or the hospital services. So that really the goal is to demonstrate value, not to say, find a reimbursement code. To align around what matters, measures that matter, and because we know if they're not aligned, we won't get there, and making sure there's true equity. Now, and I recognize our colleagues from AHA will go crazy over this, and we tried. These are the number of programs. Now, part of the issue that people need to understand is the way Congress legislates, and I heard the way our legislate, I'm not sure all this needs to be legislated, it could just be regulated from putting out rules, is they put out rules, but they don't always harmonize them. And that's why we have so many different programs. And what I think would be really very helpful, Michelle Schreiber and I, the colleague, is to try to harmonize that. You know that there's a lot of work around rethinking the MIPS program. That's some of the work I'm doing at the Bipartisan Policy Center. And how should that look like? But one of the key things for the anesthesia community, for those who are in group practices in which they're measured on whether or not the family practitioner, the general internist gives a flu shot, that's supposed to disappear by 2028. That we're really getting to, CMS is getting to MIPS value pathways and getting to the subtax ID. Because it's important to measure what people do, but it's also important to let us work together with our colleagues. So one of the goals of that is to say, if you're a pediatric department or if you're a cardiovascular center, you can actually share in the cardiovascular surgical outcomes. It doesn't have to be the anesthesia outcomes. So what are those national quality goals? We talked about value-based, getting to less cost, getting to accountable care. What are those? And these are the 8 that we anchored on. You can see them here, that there's a lot about equity and person-centered care. There's a lot of work that as we look at a lot of what we do, particularly Monty's here or the prehab, it's about patient activation to see whether or not we can get them to actually do things. So this is an area that actually algorithms scare the crap out of me, to be honest. Because if you asked who's going to make a difference and you use the past to predict the future, the inequities are going to be huge. Because there will be so many biases built into who we can activate that we constantly need to really evaluate and have that human algorithm interaction to make sure that we don't institutionalize inequities. Safety and resiliency, I'll talk about that in a minute. Outcomes and alignment, I think I've talked about. And I want to talk about those last 2 for a little bit. So I've heard, for anybody who knows Eric Horowitz, he's from Microsoft. He's the co-chair of the PCAST. They just are releasing, I've seen the report, a patient safety initiative out of the President's Commission for the Advancement of Science and Technology. And he thinks AI is going to solve safety. I will be honest, I think AI will both help and actually create more and newer problems in the safety arena. And we, as the scientific community and the clinical community, need to figure out what's the checklist as we implement any of these programs as they come into our facilities. Since all of us work in facilities, it's rare that any of us work alone. And we need to create that resilient system, and that's a lot about the workforce. So one of the things that I believe is really important to recognize is when I'm giving anesthesia on a Friday, and I have the nurses, and I work in the same rooms with the surgeons, and I'm having a difficult airway, they'll just they'll pick up the bougie, they'll hand it to me, and 2 seconds later, we're intubated. But if their staff that has never worked with me, who is brand new, first of all, they're not watching whether or not I'm able to intubate or not. They're actually looking at the computer, looking at their phone. And I'm talking about all the staff. The patient could fall off the bed and the surgical residents, would be doing something else. But this is actually true from last week. I still give, but we need to understand that we are in a different environment. Checklists alone, let me ask a question. I didn't put it on the poll. For those who are anesthesiologists, CRNAs, et cetera, how many think that above 50% of the time, the timeout is real? Everyone stops, everyone is paying attention, and no one is doing anything else? How many think above 50%? I got 1, because it's Dr. Tremper, of course. How many think it's 25 to 50%? Okay. How many think it's less than 25%? Yeah, that's Penn Medicine. Sorry, because I saw Patty. And that's with me there. And I keep saying, I can't get in trouble. When I was giving anesthesia and the Joint Commission reported to me, if they come, you're not going to get me into trouble. That's the problem. Checklists in this environment are even less useful than when they were before because we have such instability and people, it's really, if you look at the Michigan experiment and you actually look at the sociology, it was all about team building and creating a culture. And that's what we need to do. My soapbox. So innovation is something CMS wants, it's what FDA wants, but they have very different missions. And I'll talk more about reasonable, necessary, and safe and effective. But one of the things that CMS, I hope, will continue doing, and that the Office of the National Coordinator and others are really focused on, is the idea of FHIR. And the real excitement about FHIR, which is really this fast healthcare interoperability programs, the ability to actually, it's amazing. You gotta love Judy Faulkner. Nobody uses the same basic definitions in any of their EHRs until the ONC said you have to. And the ONC now says that you have to really work on US CDI. And of course, Epic, and I'm sure Cerner, charges you to upgrade your EMR to US CDI version 3. We're on 4. We're actually on US CDI Plus. But the ability to pull directly out, to keep all that data in the cloud at your own center and use FHIR apps, just like on your smartphone, to pull it all centrally and answer important questions is the future, is what we're talking about the national academies. So this is where CMS is going. This is where the ONC is going. This is where I'd actually think people should anchor on. USCDI Plus is actually going to underlie the quality measures and the public health measures. There's a lot of ideas of this idea of standardization of definitions. It's amazing it's taken till, 2023 to get to that standardization. It will actually create this learning health system that everybody wants, because the idea would be you could actually benchmark. And I see Jerry Hickson here, who, the best part about that program was the "you are here," Jerry, right? It's saying to somebody, you are here and everybody else is better than you. You're the outlier. That motivates people even more, except for the C-suite, even more than the money. That's what's going to change providers, because they don't want to be outliers. And I saw it every time I took somebody the report that Jerry gave me. So where do I think technology is going? Where are the wearables and what are we doing? And we talk about health technology assessments. There's a lot of definitions. I used to teach technology assessment when I was at Hopkins. And it's an exciting area. And it's an area that I think we need to do more of. It can't just be, no offense to those in the room who have worked with from the companies, that somebody comes in and says, we created this brilliant idea. All you need to apply to the FDA for a breakthrough device is an idea. Not at the very end, it's a breakthrough. It's an idea at the beginning that may improve patient outcomes or address an unmet need. Even if other devices come in before, it's still a breakthrough. And who should pay for that? Should you as taxpayers, if we don't know if it works, be footing the bill through your Medicare tax? Think about that question as you think about, as we come up with new ideas, what should we require to prove that our ideas are good? So you need to do clinical efficacy, you need to do safety, and I think you need to do cost effectiveness, although I will attest that CMS, when we looked at technologies, cost never entered into it. It didn't enter into it with the decision on the monoclonal antibodies. We don't do assessments on low cost to the country items because it's not worth the time given the resources, but the final decision was based upon the evidence. Patients and clinicians, one of the things that, if you read an editorial that I wrote just 2 weeks ago in JAMA Health Forum on the new rule, what do we need to decide whether or not we should apply a technology, which I include drugs in that, to a given patient? Is this the right thing? Should we put the PA catheter in this patient? We were both there when Paul Barish, everyone got him. Now we don't have very few patients get him, but it's constantly evolving. How do practice guidelines fit into it? How do we use drug formularies, the level of coverage and the acquisition in hospital formularies? So I've been thinking about who incentivizes technology and who should pay for it. And I think there really are 3 different things. And as you think about how you're looking at all this, recognizing this, there's CMS directly or any of the payers that we say you come up with a new technology and hey, you gotta love it. that when when they came up with the esophageal Doppler, the goal was to get a code so that they could be paid more to place it. It's a good strategy. If it was worth it, I mean, what's the right balance? Do you need to pay more if it's a very cost-effective and useful technology? But that's the conundrum we're in. That's the actual ecosystem we're in. Should it be part of the DRG? And in fact, if you have a new technology that raises the cost, then perhaps, and there is something called the new technology add-on payment, you get paid more. So if there's a new stent and it costs more than the old stent and it's proven to be good, there's an add-on payment. Many of you in the anesthesia community may know that the facility gets paid more if we use non-opiate narcotics, and a lot of them are actually long-acting local anesthetics. Now, we know what anesthesiology and all those meta-analysis, so should we be paid more to use that? But we as taxpayers are, because the federal government's paying more. And lastly, what happens when patients get involved? You know, CMS can't directly pay patients. Many of us, through our health savings account, can get reimbursed, but it was Herculean to get COVID tests at home to actually be paid for. You can get it in the direct medical equipment. And how do you actually integrate that idea if you're going to send somebody home and it's an algorithm? How does it get paid for? It's actually not clear yet. They're still trying to think about this. So you've got the FDA for all these new devices, who's responsible for protecting the public health by ensuring safety, efficacy, and security of drugs, biologic, and medical devices. And you've got CMS, who by statute has the authority to determine whether a particular medical item or service is reasonable and necessary for the treatment of an illness or injury in the Medicare population. So if you looked at the decision on monoclonals that I had made, that was a lot about in the Medicare population and in a diverse Medicare population, did we have enough evidence, given we know it acts with patients who have different genetic compositions? Is 2,000 patients enough to say that it's reasonable and necessary for all patients, which is why we said in the end that we cover it, but we collect data. Now, you may have seen a lot of pushback. What's wrong with collecting data? Well, we may find it's not that useful in all patients. So as APSF thinks about the future, the more you can collect data so patients and providers can make informed decisions, isn't that a good thing? And say, this technology, let's lean in, and this technology may be great for 10% of the population. And really, that's one of the good things about the unique structure. Looking at devices, the question is, what's the class of devices? Is it risky? And therefore, what's the extent of regulatory controls? So the lowest risk, minimal harm, 510K. It's a lot of devices that are 510K. Some of them are really low risk, like a toothbrush, regulated by the FDA. Pretty low harm. But some of these 510K devices may be a little more, and because they don't need to prove that it improves outcome, they just need to prove that it does what it says it does, and there's a predicate device that is shown to be safe that's already on the market. That's 510K. You have, high-risk devices and moderately high. So the higher risk are all the stents. For the Edwards crowd, this is a lot of stuff you guys did. And the moderate devices are a lot of what we put in the OR. And the goal of CDRH and Jeff Shuren, who's the director, is really to sort of get the balance right. What's the amount of evidence we need versus what's the amount of post-market evidence? So what do you need to approve it? Because we want to get innovative stuff to the public. But we want to make sure if we get it there faster, we're going to do the studies to prove it actually does what it says it does. That's what's going on in the federal government. That's this balance between FDA and CMS. CMS has the authority to do coverage with evidence development. FDA was given some more authorities to mandate that post-approval studies are actually completed. But as you know, it takes a lot to take something off the market. I'll skip over this. I talked about this. At CMS, just to think about technology, there are national coverage determinations. There's about 4 to 5 a year. I'll talk about the new rule. Since I thought that would be helpful to this group, this is what I had overseen. The benefit category, CMS is a defined benefit. What does that mean? That Congress said they can only pay for certain things, different than Medicare Advantage, different statute. So if you have any relatives or if you're on Medicare, you know that Medicare alone can't pay for hearing devices. Medicare can't pay for weight loss drugs. They can pay for a drug that has an indication to reduce heart disease. So all the GLP-1s, if it reduces heart disease, they can pay for it. If it just reduces weight loss, can't pay for it. So it's a very defined benefit category, and they look at the evidence of benefit and the risk of harm. A lot of things, the way Medicare pays, for those who don't realize, is most things are paid, actually everything is paid by the Medicare administrative contractors. It's all paid at the local level. Most things are actually decided on whether or not to pay at the local level. They put out their own decisions, and the only time CMS gets involved, national, is if there's a national coverage decision which trumps local decisions. But if you have a novel technology and you want to get it approved at CMS, this is the process. It is 9 months long. It is, they have to actually accept the proposal. They have, this is in, I think, an editorial I wrote, maybe in this that I'll show you here, in this editorial. But you then have to have a 30-day comment period where people say this new technology should be approved. Then CMS goes into hibernation for 5 months, writes a coverage decision, proposes it. People comment for 30 days, and 3 months later, a decision comes out. And I thought it would be useful, given the timing, just came out with a new pathway to try to make CMS and FDA more aligned. And really the goal is for breakthrough devices. So I just talked about the definition of breakthrough, that for manufacturers, and I know Medtronic's in the room and Edwards is in the room, they were very positive in our new approach, that the idea is you can start talking to CMS a year before you'll get approval. You'll try to get studies to approve for both. And it's still okay if FDA says, we want to get this out because there's enough safety evidence writ large, but there may not be enough evidence for clinicians for the Medicare population to decide what to do. So that the goal is to really align those two. This is the pathway. We shortened it from the 9 months to hopefully, and it can be up to, on average, 2 years, to really think through this idea of much quicker and really say we'll stop collecting evidence when the questions are answered. CMS will stop. So I wanted to go for a few out-of-the-box topics, but clearly they're not as out of the box as I think, given some of the discussions this morning. One is in November, I think it was about 13th of 2020, Seema Verma, the administrator, said to me, Lee, we have nothing else, and the hospitals are still bursting at the seams. Any ideas? And I just heard this idea from Doug Clark from CMMI about the hospital at home. For those of you who actually have this, I know MGH has a program, that we stood it up in 9 days. And Congress has just extended it with a request for an evaluation. But the question will be, will patients after surgery who still need 2 midnight So they have to meet inpatient rules. And they have the right environment, and the facility has the right people who they can send out, nurses that they can send out, EMTs, they're monitoring them appropriately, they're bringing them back to the hospital appropriately. Will they care for them at home? And of course, what will they be paid? So aren't anesthesiologists great people to think about how to take care of people at home in a remote way? So I really think this is potentially one of the futures. The question is, will people do it safely? Will they just try to get paid to do this without all the safeguards? I personally approved every single hospital that got a waiver to be in the program, which meant my team had multiple discussions and mandated things in place and required on a weekly basis reporting to CMS if they had any bad events. There's no other program like that. Where will we go? And where do we jointly, the Anesthesia Patient Safety Foundation, because there's not many other groups who can think through this, what safeguards could they put into place as they think about surgical care at home? You can try to do medical care, but I think surgical is really a simple place that APSF could make a statement about. And what about digital health? How are all these sensors going to be integrated? What is software as a medical device? So the FDA is out there saying we're going to approve lots of software. I will tell you, CMS has yet to figure out how they're actually going to pay for it. And it's complicated because the question is, what's it for? If you said we've got a scale that has an algorithm that's going to be, and you're a heart failure patient, and we're going to pay for you to buy the smart scale from Amazon, $99.95. Can it be reimbursed by the federal government? Probably MA, yes. But if other people can use that scale, then it doesn't fall under that statutory limitations. So it's not as simple as you think. So as you send things home, are you going to collect them back? Is it part of the DRG, the total payment? You know, if hospitals create predictive algorithms for sepsis, nobody's going to pay separately for that. That's my opinion. Nor should they. That's my opinion. It should be part of the DRG because you should have an incentive. So as we think about these algorithms, the first place is some questions about reimbursement. Is this really part of something else we do? If it's in a doctor's office, can it be part of the payment for some service, which will drive that innovation that we're looking for? You know, we want to really think about leveraging those real world data, but who owns that data? So I actually was at a meeting with Judy Faulkner, who's the CEO of Epic, and she started telling me how excited she was because during the pandemic, they have a database called Cosmos. How many people know what Cosmos is? Like 2. Okay, Cosmos is a database that Epic has created that takes all the data, de-identifies it, sort of, and provides it to academic medical centers to analyze. But Epic decided that they would start analyzing this data themselves. And if they put 2 data scientists on a question and got the same answer, then they publish it on epicresearch.org. And that's their peer review. So they published a paper, and literally she said this to me, in which they showed that not intubating patients who had COVID was really productive. And the minute that was published on epicresearch.org, the country changed their approach to COVID. Now, Michael, where are you? Mike Scott. You think that was the end? You think that's why people stopped intubating patients? No, right? It's like the anesthesia community and a lot of really smart people. So we have to ask the question, who's getting our data? do our HIPAA rules really protect us in 2023? Sorry, another editorial. But we should, as part of anesthesia patient safety, I'm going to give you a challenge, think about as we collect all this data, who owns it? The patient. I didn't know that my data was going into Cosmos and she had access to it. Because she actually published a paper that said that women who take antidepressants during their pregnancy have a higher rate of children with ADHD. Now, to me, that's a really dangerous publication that's out on epicresearch.org. Do you want your data to be part of that database? And when I called Bill Hansen, an anesthesiologist who's CMMIO at Penn, and said, can I take my data out? And he said, I don't know. It may be part of our contract. You either opt in for all research or no research. Really interesting. Because I think we needed this code of conduct. Really proud of the NAM working on this, the NAM Leadership Consortium. And I think we're going to be seeing a lot more in this space. And there's really going to be phased research. And the way the Coalition for Health AI is thinking about this, and then I'll open up for questions, is as we put things out, we need oversight from people. We need to ask the question about health equity in these algorithms. We need to ask the question of if we're applying this to the individual as opposed to populations, are we sure that we have all the safeguards in place? So let me give you an example, because I don't think the federal government can regulate this because it's going too fast, right? By the time they do anything, ChatGPT will be on like version 7. So the question is, if somebody deploys a bed rail, my implementation scientist back there, and they don't implement it correctly, and the Joint Commission comes in because you've had a sentinel event, the question is, did you follow your own policies and procedures? Right? That's the way. Many of you may know, they just came out. One of my prouder moments is I actually released, after 13 years, the guidelines on quality assurance and performance improvement programs, and said the boards need to be responsible. It's a new condition, and it's just being surveyed to now by the Joint Commission. But that idea of the boards need to take responsibility, we as the medical leadership need to take responsibility. And what I think responsible equipment manufacturers and guideline writers need to do is really look at what would the checklists of, and will we deploy them correctly to actually make sure that as these new technologies are utilized, is the information we get going to be integrated with human thought such that we'll actually get to better outcome for those we serve, because that's all that counts. And with that, thank you for the opportunity.
So we'll take some time for a few minutes for questions, because unfortunately, Lee, appropriately so, is going to have to leave and take care of his family. But please, anybody have questions for Lee, comments? Great insights. To have an anesthesiologist in that role the last few years has just been great for us. But yeah, please, I'm going to give up the microphone. We have a roving mic.
And one on the stand there.
Thanks, Lee. Can you hear me now?
Yep.
Okay, great talk. You triggered several thoughts in my brain, and one was when you were talking about cause and effect research, that the case you gave with pregnant mothers who take antidepressants have blah, blah, blah. And that's a classic example of this confusion in research between cause and effect versus associations. Was it the Prozac that caused the baby to have ADHD, or was it the fact that the mother had chronic depression and was taking Prozac,
Mhm.
association versus cause and effect. And you see that like every day. I've gotten to where I look at it like through the paranoid microscope. What do you do about that in planning research?
So I think it's more about how do you implement, how do people interpret it, and how do we make sure that as the machine algorithms become more prevalent in everything we do, how do we, the clinical world, make sure we ask the right questions? And I do think the fact that there's not peer review in the classic sense hurts this, but I think that's the key question. And how do we make sure that, we have that appropriate interface? It's great that there are people like Sachin Ketterpal and others who have both insights. We need more of that. But I think we're not going to get away with, there's going to be more and more large data, crunching and saying this is the answer. And there's huge concerns from the community like the Doris Duke Foundation about how that will institutionalize inequities for the future. Okay. Yeah, Joe.
First of all, Lee, thank you. That was a superb presentation. You put together so many pieces of such a complex puzzle that it's a mystery for most of us most of the time to see how the things truly interrelate. So thank you. And I wonder from your perspective, which federal agencies are willing to fund these assessment and solutions for technology use in this complex system? Of course, we know the kind of the verticals or the silos within NIH, and they really prefer disease-focused research. NSF prefers research that in which one proposes something that can't be solved, and then that gets 2 thumbs up. But these really practical, complex system issues that relate to changing our healthcare system seem very difficult to fund. So what are your perspectives on that?
Yeah, from a funding mechanism, that's very difficult. ARC doesn't have much money. Their budget was a third of my budget for my center, and that's their total budget. NIH, unfortunately, the proposed director, Monica Bertolini from the Brigham, would be a brilliant addition. She's a clinical researcher. So my hope is she will get confirmed. There's some issues with your senator, Elizabeth. But ARPA H we talked about. I think they're still searching but I actually think it's the venture capital world. But that, it's been very interesting to talk to some of the venture firms. And what's been funded a lot is apps, and they're looking at clicks as the outcome, as opposed to true improvement, reduction in costs, reduction in readmissions. And I think, I don't know, but at your place, but I've had enough Wharton MD MBAs who have either never practiced or just finished their residency, who are advising people. And, they may be really smart, but there's a difference between really smart and practicing for 30 or 40 years. And I think we need to, I think there's money there if we can help these companies and these innovators in defining good outcomes that will actually improve health. That's my goal.
So your short answer is industry, not government, is probably going to see the value,
but
the business value.
But we have to teach them how to assess that.
Right. Thank you.
I hate
Dr.
to come
Tremper.
from the Department of Redundancy department, but no matter how big the data set and how complex the algorithm, it's still retrospective data.
Correct.
Only approves associations. And I don't think prospective trials, since they take so much time and are so difficult to carry out reasonably, will ever keep up with the ever improving generations of retrospective observational. So I think the mistake that Steve brought up, it's kind of frightening that they could come out with these proclamations. Everybody jumped to, well, I should do that now, but nobody ever looked at the actual cause and effect relationship.
So there's a number of meetings coming up with Rob Califf and Amy Abernathy from Verily. I think there's someone here today or tomorrow from Verily. I'm in many of them, and we're really talking about this real world learning lab. And we've got to, as we apply it and try to intervene, collect the data faster than a clinical trial. So I think that's, and people really need to be able to say that doesn't make biologic sense.
Lee.
Yes,
thank you.
Warren.
So we've all been agonizing over the association causation question, but I think the bigger question for us to address here is a statement, not a question for you, Lee, is that these technologies have basically lowered the barrier to entry at the front end, so Judy Faulkner can do science by just torturing a data set until she sees an association and concluding that that's causation. And then at the other end, there's no barrier to going direct to consumer with the result. So she doesn't actually have to publish. She just has to actually get it out there for unsuspecting and lazy physicians and other people to consume. So we've got basically complete democratization of information, but now the requirement to screen the data or the information being presented is passed down to the consumer. So that's our challenge as the APSF, is to figure out how do we get people to realize that all of the controls that made a decent scientific process are gone. And so that you should assume that anything you read is suspect.
So when I was trying to convince the nursing home residents to take the vaccine, it was a very interesting time. And how you frame it matters a lot. Lots of people came up with the idea, we call them healthcare heroes. And my behavioral scientists on this committee that was formed to help advise me said that's crazy because they're still going to work. They're still taking care of the nursing home. So we actually called them community champions. So we actually have to use words more carefully. When Kathleen Hall Jameson, and if you want to bring somebody up who's amazing, she was the former dean of the Annenberg School at Penn, but she runs a little organization called factchecker.org. And she said every time Fauci spoke, if you actually put somebody who was, let's say, on the right or a little had a different opinion, because he was so dogmatic in the way he spoke, not the way we as scientists heard everything he said. He didn't say anything wrong, but we have all the caveats in the brain. We know the association that the public can find one counterfactual and discount everything else he's saying. So I think as APSF starts to disseminate, they need to learn from the experts of how to disseminate in a way to the public that they can hear it, particularly in 2023 and beyond. Thanks for the opportunity.
Lee, thank
Sad
you.
I have to leave.
Thank you so much. Really appreciate your time and your insights. So without further ado, we are going to go right into the next session. Actually, there is one short ado. I'm sorry. I forgot to mention something earlier. So we actually are trying for the first time a live stream for this event. So there is a live stream audience. Arnie Abseo is monitoring the chat, and I want to give credit to Mike Edens and Katie Meghan for their work in making that happen for us. They've been our great webmasters and tech gurus to turn this stuff on. But anyway, I want to introduce J.W. Beard, who's your moderator for the next panel.
Thank you, Jeff. Good morning, everybody. Welcome to this session titled Wearable Devices and Remote Monitoring. My name is J.W. Beard. I'm the Chief Medical Officer of GE Healthcare Patient Care Solutions. It's an absolute pleasure to be here talking about this subject with you all. If you remember from one of Jeff's earlier slides, some of the overarching themes of our conference include patient data being acquired by devices. In this case, wireless wearable devices. That data being collected, visualized, analyzed, driving clinical decisions, leading to clinical outcomes. We're going to be focusing in this session on those devices. Dr. Fleisher, I think, also emphasized the importance that these devices are going to play as our health system evolves over time. He mentioned home health care. In many cases, that's going to involve patients wearing devices at home. We have a great panel assembled to discuss the subject of devices. Those devices are connected to a network. We're going to have Anura Fernando talking about the Internet of Medical Things. The greatest amount of experience with wireless wearable devices comes in the med-surg environment currently. We're going to have Ashish Khanna reviewing that. Dr. Fleisher also mentioned that the questions, the importance of payment for new technologies and innovation. We're going to have Dr. Jim Grant representing a commercial payer and their approach to innovation. And finally, all devices are not created equally. We're going to have Dheerendra Kommala from the ECRI organization talking about consumer versus medical grade technology. To get started, we have a couple quick poll questions. If you all could, you can either scan that QR code, you can go directly to the app. There's some cards on your tables that are also guides to get into the polling software. First question, the clinician community is sufficiently educated on medical technology to critically evaluate wireless wearable monitoring systems for patient care. I didn't expect that. I thought we'd be a little more balanced. I know there's a lot to learn on these subjects, but we clearly have some work to do here. Next question, and this is a really important one. This is a question that's facing many companies that are trying to develop technologies to deploy into hospitals, and these are the same questions that are being asked by those clinicians who are considering adopting the technologies. What's the most important factor to drive hospital investments in wireless wearable technologies in the med-surg environment? Reduction of adverse events, favorable economics, or clinician demands? Can clinicians shape the adoption through their advocacy? So it looks like it's going to be evidence. It'll be evidence through improved clinical outcomes. It's going to be evidence of the economics that are important for hospitals with constrained capital to make these investment decisions. Thank you all for participating. I'd now like to introduce our first speaker. This is Anura Fernando, who will discuss what is the Internet of Medical Things. Mr. Fernando is the global head of medical device security at UL Solutions with 25 years of experience with safety critical software and control systems certification and safety research across multiple application domains. He's contributed to research and industry publications in predictive modeling and risk analysis, cybersecurity, systems of systems, health IT, and medical device safety and security. He's participated in collaboration with numerous Fortune 500 companies and has contributed to the development of several domestic and international consensus standards for software security and functional safety. His current focus looks at the intersection of cybersecurity and safe medical device interoperability. Please join me in welcoming Mr. Fernando to the stage.
Morning, everyone. So we'll start off dealing with a very timely issue. How many of you knew that next month the FDA is going to be under statutory obligation to define what a cyber device is? We've all heard, the cybersecurity requirements and so forth. Were you aware of that? So some significant changes are going to be coming very soon in terms of defining things. So let's start off looking at what the term cyber means in the world today. We all use it, cyber attack, cyber secure, etc. So when we break down all these terms and look at the root, we see that cybersecurity comes from the Greeks. It comes from the word Kubernetes. And that has to do with the steersman and it led to a discipline called cybernetics, which has to do with communication across many different domains of science and technology. So when we think about a steersman today, there's something very different that we see. We see things like telemedicine and telesurgery, even transatlantic telesurgery, as we've seen with telerobotics and so forth. And so what it means to steer is kind of a different thing in today's technology domain. And when we, so when we look at the domain of the internet and communication of data, we see that there are a lot of interconnected things. We see that we have industrial products connected to things. When we look at a hospital, it's not just medical devices, as we all know, right? We have backup generators and all kinds of different building management systems that may be on common networks with our clinical systems as well. And when we look at those technologies, we see that they fall into a domain of communication that in many ways is like real estate. And if you take a plot of land and you try to decide how to utilize that, as a business, let's say, you can choose to put a house on that land. You can choose to put an apartment building on that land. And these different choices that you make have many implications in terms of how that property is utilized. Computational technology is really not a lot different. We talk about the cloud a lot today. We talk about the edge a lot today. We have things like wearables that sit out on the edge or the periphery of centralized cloud-based data repositories and so forth. But we also have this kind of nebulous area that some people call the fog. And so when we see that, we start to understand that there are a lot of buzzwords and marketing terms and things like that that are thrown out to help us define the different economic models of how this technology is used. Some people want to use servers that they pay for, from a service provider, a cloud service provider, for example. Some people want to use platforms that they can just put their data into. And so there are a lot of different models where you use or rent or purchase different portions of this technology to attain different goals. But ultimately, you want to have different parts of the healthcare ecosystem being able to communicate with each other. That healthcare ecosystem is not just the medical device. It's not just what's in the hospital. It's everything, all the way to the home, all the way to what you're wearing on your wrist or around your neck in terms of wearables. So we can see that these technologies are now designed in a way to allow us to put almost anything on this thing we call the internet. We can start to acquire data from it. We can hook up little chips to things and little sensors that allow us to monitor everything that's going on in electromechanical devices that we may be familiar with, mechanical devices that we may be familiar with, and even biological systems that all of you, with the many MDs that are out here, are very, very familiar with. But the technology stack that supports it is not simple. It's complex in and of itself. Much like the system that you're monitoring, the system that is conveying this information has its own levels of complexity associated with it. And so we have to understand how that technology stack works to support the objectives that you want to reach from a clinical utility perspective. And this starts to build what we call the medical Internet of Things or Internet of Medical Things. There isn't strong consensus yet, but it really is the amalgam of a lot of different technologies that enable communication and enable the steersmanship, getting the data from point A to point B in a way that's trustworthy, that's reliable, that's useful. And there are many different pros and cons that come up when you decide how to use that plot of real estate that computational technology that you have to think about. You have to think about, do I need reliability? Do I need to make sure that data gets from point A to point B? Or do I need speed? Do I need to be able to respond to changes in situations really quickly? So let's take a look at a specific example to see how some of this works. Many of you work with devices. Just curious, how many people have actually taken devices apart and looked at the internals and how things work? So good, a good number of you. And that's why I thought it'd be really fun to speak at an anesthesiology conference, because you guys are the tinkerers of the medical world, I think. So anyway, we'll take a look at a software-enabled ventilator, which most are these days. And let's think about, why would we need an IoT ventilator? Why do we need this as part of the Internet of Things? I think COVID taught us that very well recently. You may want to be able to make changes to critical parameters and things like that without necessarily getting too close to the patient in some cases in order to protect healthcare worker safety. So let's take a look at what it is that we need to build to make this IoT ventilator. Well, first of all, we have to understand the control structure that we're working with, because engineering is largely about controlling things and building ways to control things in a human intervened manner. And so when we look at breathing, we have inspiration, expiration, and oxygenation. That's the basic finite state machine at the bottom. And then we have a whole bunch of things like chemoreceptors, proprioceptors, the brain, et cetera, that drive all of this. And in order to get us there, we need to convert that human physiological anatomical system into an engineered electromechanical system. And we need to be able to control that inspiration, expiration, and oxygenation in very much the same way. But we have to be able to do that in a way that's compensatory for deficiencies of the human body. And that's what this remote controlled ventilator is all about. And so what are our targets? We have some critical parameters we have to look at. We have things like flow, pressure, and volume that we have to replicate very, very closely to what the human body normally does. And these are things that maybe you guys do every day, but maybe you don't think about the fact that that's really what you're doing when you're hooking somebody up to the ventilator. And so in order to accomplish this, you have to have a plan. You have to have a methodology to follow to get you there. And to follow a methodology, you have to have good process. That saying, if you fail to plan, you're planning to fail, right? And so having a good systems engineering process up front that includes what was mentioned earlier, both system 1 and system 2, not only the machines, but the humans as well, can be very critical. And so you start choosing technology, you start selecting appropriate technologies, like what kind of microprocessor do you want to put your software in that's going to try to create this waveform. And as you do that, you start to really dissect and understand the pros and cons of your technology selection. Am I going to get the right kind of feedback when my motor is moving? Am I going to have some way of monitoring the movement of that motor to make sure that I'm creating the right amount of pressure, the right change in volume, the right flow rate, et cetera? And so you start putting these things together and you start to create an engineered product or system that starts to replicate those critical parametric changes you need in the human body. And to get to this, you start to think about, well, how do I use this in my day-to-day practice of medicine? How do I use this in a way that allows me to remotely control the things I need to control? And so you start tacking on more technologies on there. You start to add in things like a front end, something that allows you to have local control, something that allows you to also have remote control. You have to figure out which should override which. Should my local override my remote, or should my remote override my local? You have to think about, how do I use available technologies out there? Do I use cloud service providers? Do I use on-premise services? Do I use my own server in my facility that I'm providing service through as an independent vendor, for example? So a lot of different decisions to make and a lot of different ways to compartmentalize this effort. So when we start to look at this now from a technology perspective, in the application, we say, okay, well, I know I have to inspire, I have to expire, I have to oxygenate. I've picked some technologies to do that. But what can go wrong? Where could disturbances come into this control structure that could cause problems for me? Well, that gets back to understanding causation versus association, like we just talked about, and so forth. And we need to start doing some analysis. There are various levels of sophistication of this kind of analysis, but there are some very, very simple tools and models that anybody can use. It doesn't matter if you're a clinician with no engineering background or an engineer with no clinical background. Some of these tools are pretty straightforward and easy to understand. One is what you see here called hazard-based safety engineering, where what you do is you understand what is the potentially hazardous source. It could be a chemical, it could be some type of energy source like electricity, etc. What is the part of the body, or what's a susceptible part that may be harmed? And then what is the transfer mechanism? How does that hazardous source impinge upon negatively the susceptible part, and how do you stop that? Do you change the design? Do you make the susceptible part less susceptible? Can you maybe do none of those things, and then you have to rely on warning and labeling and letting people know, this could be a problem, be careful when you're using this technology. So these are all the kinds of considerations you have to go through when figuring out how to make this technology safe and secure. And there are tools out there that even help with the data piece of it. So it's not just building the physical stuff, it's looking at the data flows. Now, where's my data going? Well, it's starting out in my ventilator, or maybe it's ending up in my ventilator, where I have to control those critical parameters like pressure, flow, and volume. Then it's going through some kind of front end, like a PLC that has maybe a human-machine interface on it that somebody's changing parameters on. It may then be going out to a server. And in all these places where I'm sending this data, it's also getting stored there. So it's getting stored at the edge or at the device. It's getting stored maybe on a mobile device like your phone or an app that's in your phone. It's getting stored in your cloud service provider's environment, so somewhere out in this nebulous thing we call the cloud. Or maybe it's getting stored in this thing we call the fog these days, which is something in between the edge and the cloud. It's more computational infrastructure. Again, it's taking that plot of real estate and dividing it up in yet another different way. So when we think about what could go wrong, we end up in places like villi, ventilator-induced lung injury, right? Because we know if we deviate from that pressure, flow, and volume, bad things could happen. We could get inflammation and edema, restriction of space for movement of those anatomical structures that need to move. We could get cell disruption and cell death, or we could go as far as multi-system organ failure and patient death, which is a place we absolutely don't want to end up. And so as we start to understand this technology, it's really important for us to understand what are all the different kinds of impacts that could happen from it. You don't think a lot about motor-operated medical devices necessarily catching on fire, but they can. We have a long 100+ year history of protecting devices from catching on fire. But now with cyber devices, you could actually get into a device and you could allow it to try to move the motor, but without turning that electrical energy fully into mechanical energy to cause rotation of the motor. by disabling some of the motor windings through software. Well, if you do that, you end up with a coil, a motor winding that you're sending energy to. That energy is not getting dissipated as mechanical movement. Instead, you're creating an inductive heater. That heater starts heating up, your ventilator starts heating up, you exceed the plastic for flame ratings and things like that. Next thing you know, your device is on fire. So threat actors, hackers, can do this kind of thing. It's not common, but it is possible. Something a little more common is exfiltrating data. So when you design your device, you just spent a whole lot of time tweaking the motor movement and so forth to get your pressure, flow, and volume working just the right way to replicate what the human body normally does. Well, you might have spent easily a decade doing that. Well, now what? You put your device on the market, you don't secure the data inside, somebody steals those algorithms, knockoff products get on the market, maybe they're less expensive, less safe, etc. And so depending on the regulatory environment it's being sold in, again, patient safety could be at risk. And so we see that these kinds of things can be addressed. Technology keeps advancing. We're going from external ventilators to now research is being done on implantable ventilators and things like that. So things are always moving. Luckily, there are standards that are emerging. Unfortunately, they're always a little bit behind that try to address these kinds of risks. They try to detect what these risks are that we need to think about. This is where, right now we have a lot of engineers usually sitting in these rooms working on these standards. It would be great to get folks like you, the members of APSF, for instance, more involved in this so that we can get more of that clinical input. This will enable us then to get to aspirational goals like we see through some of this research that was done at MGH through some of Dr. Goldman's research efforts, who's in the room here, where we can get to closed loop healthcare that ranges from the home with wearable technologies and monitoring technologies through the hospital where care is provided back into the home where care can continue to be provided through activities like hospital in the home, for instance, that's happening now. So thank you very much. And we'll be doing questions in a panel format, I believe.
Thank you, Anura. I'd now like to introduce, one housekeeping item. I forgot to mention all the speakers will be available for Q&A at the end of this session, with the exception of Dr. Khanna, who has some travel changes. After Ashish's presentation, we're going to do Q&A immediately afterwards. We'll then continue the next two talks and do a panel at the end. I'd now like to introduce Dr. Ashish Khanna, who will be reviewing acute care and wearable technology. Dr. Khanna is an associate professor of anesthesiology and vice chair of research with the Department of Anesthesiology, section on critical care medicine at the Wake Forest University School of Medicine. Dr. Khanna is a member of the Wake Center for Biomedical Informatics, a core faculty for the Center for Healthcare Innovation, and the Wake Forest Hypertension and Vascular Research Cardiovascular Science Center. He's a director for the Perioperative Outcomes and Informatics Collaborative, a center of excellence for clinical trials across subspecialties. He's incoming chair for the ASA Committee on Critical Care Medicine, past chair of the research section of FCCM, and board of directors for the Society of Critical Care Anesthesiologists. His research interests include prediction of postoperative respiratory and cardiac events on the regular nursing floor and the use of large data sets for perioperative outcomes research. Please join me in welcoming Dr. Khanna to the stage.
Well, thank you, JW, and the organizing committee of the Stoelting Conference. Is actually my first time here, and this hasn't failed to disappoint. So thank you all for having me. I'm going to talk about acute care and wearable technology after that, excellent start to the morning, talking more about the regulatory aspect of things. And and then the nitty-gritties of what goes behind the technology. I'm going to try and talk about the research, or in my words, sort of the lack of research or the need for more research in the area. These are some of my affiliations and relevant disclosures. None of this is a academic conflict of interest on the material I'm going to present to you today. Now, I'm going to start with a very basic slide, and for my colleagues in anesthesia who've sort of seen this data before, this is not new. You know, we do a great job taking care of our patients in the operating room. People do not die in the operating room during elective surgical procedures. That mortality rate is next to negligible. But time and again, you know, data has come up in the post-operative period that really asks us the question of, you know, post-operative patient safety. So here, for example, this publication in the Lancet labels post-operative deaths as still the third most common cause of worldwide mortality, not just in the developing world, but in middle and high-income countries as well. So if these are the patients we're taking great care of in the operating room, then what is happening as they're stepping out of the operating room and before they're going home, they're having such a high mortality rate? Well, even though I am an intensivist, I say the problem really lies beyond the ICU. And again, you know, this is just some of the published data. There's tons of published data like this that really shows that, again, for example, you know, most of patients who die in a hospital are never admitted to an ICU at any stage. More than half of all adverse events that happen in hospitalized patients occur on the general care ward. And then when they occur, they're responsible for a large chunk of all of post-operative mortality. So clearly, you know, not the operating room, not the intensive care unit, but outside of the walls of the operating room or the ICU. And here is my favorite analogy to the world we live in. It's the flight data recorder. And I was thinking about this as I boarded my flight to Vegas yesterday. You know, get on your flight, you know, and the captain or the first officer comes on and says, you know, we're flying a brand new aircraft today. Everything is great, except I don't have a functional flight data recorder. How many of you would deplane? How many of you would deplane? Just Dr. Tremper or a few others? Okay. So the rest of you would stay on an airplane that's brand new, but without a flight data recorder. And I love this because that's exactly what we're doing to the patients on the hospital floor. We are making assumptions for patient safety and saying, okay, it's fine. Our patients on the hospital floor are on the floor because they are okay, so we won't monitor them. And when they crash, it's okay. They come to the ICU. I wake up at 4 o'clock in the morning. I admit them. I order 20,000 tests on them, and that's all good. And I still don't know what happened to them because unlike aviation, we don't want to learn from our mistakes. We don't want to detect pattern changes that led to that catastrophic event that led to that unplanned ICU admission. So I'm glad that all of you do not want flight data recorders on your airplanes. Well, think about it as you're going back home. Code blues do not occur out of the blue. They're named code blues, and they happen. You hear the overhead alarm sound. Data suggests that a lot of these patients actually have at least one abnormal vital sign up to 4 hours before an actual cardiorespiratory arrest event. And data also suggests that as the number of abnormal preceding vital signs increase, so does the outcome after the code blue event worsens. So the common sense solution seems to be early intervention when these abnormal vital signs first start accumulating, because clearly as more abnormal vital signs accumulate before a code blue event, the outcome proportionately worsens. And, you know, I put this in a infographic in critical care a few years ago. Seems to be a very simple solution right here. This is sort of what we're doing, not just in the United States, but all over the world. Patients are intermittently monitored on the general hospital floor. A nurse on the general hospital floor usually takes care of anywhere from 6 to 10 patients. He or she is monitoring these patients maybe once a shift, once in 4 hours, once in 6 hours. Here's a patient who's resting comfortably at 4 o'clock in the morning, but then is having probably some obstructive or desaturation events. Someone comes and checks in on this patient 6 o'clock in the morning, and here's a code blue ready to be called, right? But in the perfect world, this patient would have a wireless wearable that would transmit data in a closed loop environment, and someone would get alerted and would intervene immediately and probably save this from happening. Now, it seems to be really simple. It seems to be a no-brainer. Why don't we just do it on everyone? There is lots and lots of problems, and you know, I'll bring forth those problems as I go on. But I want to also tell you the falling off the monitoring cliff situation, and thoughts here are courtesy my good friend and collaborator, Dr. Turan from the Cleveland Clinic. He and I were talking about this one day, and he said, what is the average surgical time where we provide anesthesia? It's about 130 minutes. We monitor with an NIBP blood pressure every 5 minutes, mostly, right? So we monitor a patient in the operating room when we're standing at the patient's bedside or standing by the anesthesia machine, someone is, 26 times over a period of about 2 hours, right? The same patient then has an average hospital length stay of about 3 days. During that period, we monitor blood pressure every once in 4 hours at best. So we've gone from 26 times in 2 hours while we're actually there to 18 times over 3 days when we're not present at the bedside. And then the same patient just goes home. We say, okay, good luck, you know, monitor yourself, and hopefully you stay at home and you make a peaceful recovery. This is truly, truly not just having a flight data recorder, but maybe having a flight data recorder, taking it off and throwing it away, which really is not doing justice to our patients. Now, we did some initial work, again, with Turan and colleagues, where we put continuous blinded post-operative blood pressure monitoring with a wireless wearable device on a general hospital floor. And we saw that post-operative hypotension was common and undetected. This was in an environment where routinely continuous monitoring is not done. So what we saw, for example, here was that a fifth of our patients had 30 continuous minutes of MAPS less than 65. And again, in the red font, we also saw that spot check, traditional monitoring, missed about half of all episodes of MAPS less than 65 that were detected by continuous monitoring. So keep that thought, keep this slide in your heads, and I'm going to come back to it later on. On the other side is the respiratory side of things on the general hospital floor. I had the pleasure of leading the Prodigy study a few years ago. We put continuous capnography and oximetry on all patients who were receiving parenteral opioids on a general hospital floor. And this was an international study. It was done across 3 continents. There were 1,400 patients in our final cohort. And even though the monitoring itself was tethered, the data was really interesting in that about half of all of our patients had at least one monitor-detected opioid-induced respiratory depression episode that was adjudicated by an independent committee, and we had strict criteria on what we labeled as an OIRD. So clearly, there is a lot of things that are ongoing on the general hospital floor, both with hemodynamics and with respiratory depression, that we don't pick up in the absence of continuous monitoring. Matt Sherpick published this a few years ago, and this is really interesting. So he wanted to examine what vital signs trends on the hospital ward are predictive of poor outcomes, clinically relevant poor events, and respiratory rate appeared to be the one that led this pattern here. And this is an AUC ROC on the other side. So both respiratory rate and heart rate were the 2 vital signs trends that appeared to be most predictive of clinically relevant patient outcomes. This is what is happening with respiratory rate, and I'm sure some of you have probably seen this slide before. So the big yellow dots is our documentation of respiratory rates in the EMR. Usually that number is between 12 and 16, maybe 18 at some places. This is what a continuous monitoring device is picking up. It's picking up a general trend, an upward trend in the respiratory rate. Here is an ICU transfer right here, right? And you can clearly see that there was a problem. We kept on documenting the respiratory rate as normal, but then the patient crashed at some point. So clearly, respiratory rate is an enigma, and we need to work on it. Now, here's some unpublished data. So with some colleagues, I thought through this, and we said, okay, let's see what the evidence has shown us over the years. So we did a systematic review and meta-analysis looking at the role of continuous pulse oximetry and or capnography in combination or by itself on the general hospital floor compared to regular intermittent vital signs monitoring in the prevention of postoperative respiratory failure and the detection of hypoxemia and clinically relevant events like ICU transfer and the use of non-invasive ventilation and mortality and reintubation and so on and so forth. Now, a slightly crowded slide here, but what I want to point out is that the only thing we saw in this systematic review and meta-analysis, which is unpublished as yet, was that the only thing that these devices are doing is detecting a lot of desaturation. So the odds of picking up desaturation was way in the favor of continuous monitoring. Everything else, including ICU transfers, reintubation, and in our analysis, non-invasive ventilation as well, did not make a difference whether you were using continuous capnography, oximetry, or not. Now, the problem, though, is that the studies, the quality of these studies, there's not enough data, there's not enough evidence. And I'll tell you very soon why there's not enough evidence. There's also a wearable or a smart monitoring patch for nearly, like they come in all shapes and sizes. They're available all over the place. I can order them off Amazon, and they are flooding the market. Now, the problem, though, is, and again, in this slide, I'm not trying to advocate for any particular device. The problem, though, is we must put wireless wearables through real-world testing. This is actually at a ACER meeting. ACER is coming up next week, and I'm on the board of directors for ACER, so please come over to Nashville. This is at an ACER meeting where I was on a continuous monitoring workshop. I put some of these devices on myself as I was talking, and I can tell you that my own blood pressure was being read all over the place half an hour later of me waving my hands all around and resting my hands on the table. So clearly, we need to put devices through real-world testing. This is not about putting the device, testing it in a research environment, and saying, oh, look, the data looks great. These are patients who are going to move around, walk the hallways, and their blood pressures and vital signs are going to don't look normal at all when these devices are put through that kind of test. Now, the other problem is the validation of these devices. So with Burnsogel and colleagues, we published this editorial in Anesthesiology where we looked at the challenges of automated continuous non-invasive ward monitoring. And we sort of said this is a three-step process. When a device, and I've got industry in the room here, I understand, but when we come together, when a device technology comes to me, number one, I ask for validation data. I must know validation data for that sticker, that patch against the gold standard, and I must know the exact tests that were performed statistically to determine the quality of that validation data. Number two, and that's what we lack today, is interventional outcome studies. Few and far between, I would say negligible in the world of continuous monitoring. And number three, the implementation science, which is the real challenge. The hospital nurses at Wake Forest do not like me because I keep talking about continuous monitoring, and it adds a layer or several layers of work for them, at least what they perceive as work. And honestly, if I tell you, most evidence these days is stuck between 1 and 2. We haven't even come at 2 or beyond from 2 to 3 when you talk about the evidence for wireless wearable monitoring on the general hospital floor. So some of you in this room were involved in this survey, and some of you were actually respondents on this survey, so I thank you for this. We did a survey for wireless wearable for anesthesiologists in Western Europe and in the USA, and I won't go through all of the data on the survey, but some of the results were really interesting on what you all think should be done for wireless wearable monitoring. A large chunk of you think that wireless wearables should be put at least on all high-risk patients, although about 25%, I'm happy, 25% think that they should be put on all patients, irrespective of underlying risk. Again, that's up for debate. So we need more risk stratification tools. What kind of wearables would you like to monitor? What things would you like to monitor? Well, looks like oxygen saturation. I think we find it easy to deal with oxygen saturation, heart rate or pulse rate, and then blood pressure and respiratory rate, despite the fact that such a predictor of poor outcomes, only about 50% wanted to continuously monitor respiratory rate on the general hospital ward. What sensor would be ideal? Most of us said wrist devices. I think we're very comfortable with wrist devices. Some said adhesive patches, others said finger sensors or rings, and then there was a whole plethora of things like necklaces and videos and belts and so on and so forth. But what are the main implementation challenges? And this is really important because we are here to talk about implementation challenges threefold: return on investment, so the economic part of things, and again, we talked about that a little bit. Connectivity or IT issues, as Anura highlighted, I think we're really struggling with that part. And then we labeled it nurse pushback in the survey. I think it's not just nurse pushback, it's pushback from the providers who have to deal with the consequences of me trying to continuously monitor every patient on the hospital ward. And that are currently that first line of defense is our floor hospital ward nurses. So I'm going to then spend a little bit of time just talking about our experiences at Wake Forest. We have a unique ecosystem in this institution where about 80% of our hospital ward patients are continuously monitored with this completely wireless technology, and I have no affiliations with this technology. It was in place before I came to Wake Forest, in full disclosure. We are continuously monitoring every 15 seconds of EKG, heart rate, oxygen saturation, blood pressure, respiratory rate, skin temperature, patient mobility, and atrial fibrillation as well. This is how our data is currently flowing. About 80% of our hospital wards are hardwired with this monitoring device that goes on the patient. There is an internal patient data server, and then all of the data is being transmitted to the device cloud storage system. Anytime I need the data for research or analytics, I have to request the device company and get the data from them. This is what our monitoring system looks like. So if you walk through our hospital ward, every hospital ward hallway has these large RVDs or video displays where every single patient room has continuous vital signs come up every 15 seconds, also shows if the patient is in bed, what position the bed in, is the patient rotated one way or the other, or is the patient standing, et cetera, et cetera. And then we have an internal dashboard that I have access to where I can do some basic analytics on how much time patient spent under a certain blood pressure, respiratory rate, other vital signs, and so on and so forth. The vision going forward, at least from my perspective, if I was in charge, I would try and make this a system where the wearable devices, the management server, the EMR, and the analytics is all internal to us, and we don't have to send the data onto the devices, remote cloud, and request data back every time, because that is an additional layer where we lose data and there's missingness and so on and so forth. And the vision also, and we've talked a little bit about this, is that all of these vital signs should then develop themselves into a predictive analytic model that helps us estimate ahead of time what patients are likely to get into trouble. Not just the fact that my patient has a low blood pressure. Well, even though low blood pressure is important, some patients have low blood pressure and they're sitting and watching TV. I want to know what is a pattern of a collection of vital signs that is predictive of a clinically relevant patient event. Now, this is, again, unpublished data. This is just my internal data. And we've seen that we are looking at, for example, hypoxemia here, and I'll show you other examples as well. We are able to see the effect of continuous monitoring and the use of real-time alarms and alerts that are enabled in our system. So our SpO2 alarm is set at 85% for our hospital ward patients. As you all can see here, the x-axis is a threshold SpO2, y-axis is a percentage of patients. Different colored lines are the different the cumulative minutes spent under various thresholds, there is a significant amount of hypoxemia here. So significant amounts of time spent between oxygen sats of 85 to 90. But as you drop below 85, because we have real world alarms enabled and people intervening, there is very little hypoxemia below 85. Similarly, for respiratory rate right here, again, our threshold alarms are set at somewhere between 6 and 8, and it falls off pretty quickly, at least below a respiratory rate of 6, but there's ample number of patients who are sitting between a respiratory rate of 8 and 10. So what are we looking at? Let me just take you back to the postoperative hypotension data that I showed you a little bit ago. This was done at another institution. Lots of postoperative hypotension with a wireless wearable device in an environment where continuous monitoring was not the standard of care. I recently repeated the same experiment at Wake Forest in 15,000 patients, this time in an environment where continuous monitoring is a standard of care and we have alarms and alerts to low blood pressure. This is retrospective data in 15,000 patients. Our postoperative hypotension incidence was way less than the other published study in anesthesiology. So our postoperative hypotension, only about 10% of our patients had MAP less than 70 for 30 cumulative minutes. So even though it's not a head-to-head direct comparison, I will say that this helps me validate that alarms and interventions, and if you implement a continuous monitoring system, there's hopefully less perturbations in vital signs on the general hospital floor. And again, lots of numbers on this slide. We also built some models where we wanted to see, well, if we did not have continuous monitoring and we did have only intermittent monitoring, how much hypotension, hypertension, bradycardia, or tachycardia our patients would face. And the short answer here, without going into the numbers, is that there will be a significant amount of undetected vital signs changes in the absence of continuous monitoring had we not had continuous monitoring. And all of this is available in this just published paper with an editorial written with lots of supplementary tables. So feel free to look at it, and I'm happy to take questions if you end up reading this paper and have questions about it. So as I sort of come to the back end of this presentation, looks like continuous wireless monitoring is an obvious answer, but I say it's not. And it's probably not because there is, like I said, a fourfold challenge: lack of implementation, actually lack of appropriate evidence, lack of implementation, alarm fatigue, huge problem, and then return on investment that we have no answer to as of today. Let's look at the evidence. Frederick Michaud published this nice little table in a review, talks about sort of the published evidence around continuous monitoring on the general hospital floor. There is lots and lots of before and after type study designs. Historical cohort, implement continuous monitoring, and see that it makes a difference in a lot of hard outcomes that I've actually highlighted here. The one with the red arrowhead here is actually from our own institution. Again, a before and after study design that did show that there was a significant decrease in rapid response team events. Now, we are all aware of the problems of before and after study designs. So let me highlight one such study, great study, actually using the same devices that we use at Wake Forest. This comes from a hospital system in the United Kingdom, before and after type study, and they saw a very statistically significant decrease in ICU admissions and rapid response calls after they implemented continuous wireless vital sign monitoring on the general hospital floor. Now, what are we doing? Again, I'm sorry, this is still unpublished, but I'm sharing this with you. We looked at a propensity matched cohort at Wake Forest. So when we implemented continuous monitoring, a lot of our patients did not have continuous monitoring. So it came on in a stepwise manner. So in nearly 36,000 patients, there were very extensively propensity matched on all of the things that could affect outcomes. We did see that continuous monitoring did lead to very, very favorable impact on the risk of myocardial infarction, risk of ICU admission, and other organ system failure as well. And again, I'm happy to discuss these unpublished data offline. I am excited about this one. This was, I just completed last year, a cluster randomized pragmatic trial where 2 hospital wards at Wake Forest were every 4 weeks alternated between continuous monitoring that was available to providers with alarms on versus continuous monitoring that was blinded and silenced and was recording in the background where providers had to go back to traditional monitoring. And interestingly, the biggest difference we saw was, again, desaturation. So the risk ratios were significant for desaturation, which means that if you had continuous monitoring, you had a significantly less risk of having desaturation events. Blood pressure, again, non-significant differences. Tachycardia, non-significant differences. The composites, and I've not mentioned what the composites are. The composite outcomes are a combination of desaturation, hypotension, and tachycardia. The composites were in favor of continuous monitoring, but again, the composites were driven by oxygen saturation. Importantly, we did troponin surveillance on all of these patients. There were 900 patients randomized in this cohort. Daily troponin on all of these patients, because I did want to see that if we're not detecting enough hypotension, is it going to make a difference in myocardial injury and possibly downstream poor outcomes? No difference in myocardial injury whatsoever, because we did not see that there was prolonged sustained hypotension in the absence of continuous monitoring. Again, unpublished, hopefully soon to be published. I'm happy to share that with you. Very quickly, the issue is that there's problems with perceptions around vital signs monitoring on the general hospital floor. This is our internal data that just validates what I've been talking about. When we look at the response to alarms, oxygen saturation is the one alarm that is responded to all the time. In that pie chart, 50% of it is oxygen desaturation. Folks respond to it and correct it. But things like respiratory rate and heart rate, people struggle with what to do with a slightly higher respiratory rate, or what to do with a slightly lower respiratory rate, right? So they will call a code when someone's respiratory rate is 4, but they don't know what to do with a respiratory rate of 8 or a respiratory rate of 18 for that matter, right? So that's a problem. And we did a nursing survey at an institution that exactly showed the same thing. Low respiratory rate was the one thing that nurses were most concerned about, but also didn't know what to do with. So again, a problem, right? So we know it's a problem. We don't know what to do with it. I will also tell you that as we talk about building evidence and improving patient safety with wireless wearable monitoring, we are leaving patients out of this discussion, which is really, really unfair. I gave you the example of the flight data recorder, and I said at least the captain or the first officer came on and told me that the plane did not have a flight data recorder. In our case, we are putting patients in our hospitals after complex surgery. We're leaving them outside the ICU because ICUs don't have enough beds. And then we're not asking them, do they want to be continuously monitored or not? And if they do want to be continuously monitored, what are their perceptions around continuous vital signs monitoring? So think about it. Of all the good things we talk to our patients about, we don't talk to them about patient safety, and we don't talk to them about the fact that we actually take away their iWatches when they come into the hospital. Say, give that to your nurse. Don't wear your wearable. So unfortunate. I wish they'd at least be allowed to wear their digital watches. That will at least save them from something. Finally, it's not all about hypotension and hypoxemia. Our group has looked very carefully at mobility data. With our vital signs monitoring system, we're able to validate whether a patient is supine, semi-recumbent in bed, or is standing by the side of the bed. And also, we've gotten more than 10 million posture readings in our data set that we published validation data on. And very recently collaborated with Dan Sessler and Alparslan to publish this in JAMA Surgery, nearly 9,000 patients at Wake Forest with continuous mobility data. And in a retrospective study, and I know you all will say, huge amounts of confounding here, we had a nearly 30% risk reduction in hard outcomes, including mortality, for every 4 minutes per hour of mobility units. So the answer to this is we need a prospective interventional study that someone will fund at some stage. But right now, people will look at this and say, wow, that's a great signal. You publish this in the JAMA Surgery. But clearly, patients who are more likely to have a pneumonia or a DVT or a complication are likely to stay in bed. So what are you telling me, right? Again, all I'm saying is the signal seems really strong. Encourage you to read the paper. So the future, ladies and gentlemen, is pattern detection. This is from our Prodigy data set. In the interest of time, I probably will skip over this today. But the future is that all of our patients should have continuous monitoring that shows patterns of vital signs changes, whether it's oxygen saturation, ventilation, heart rate, and so on and so forth, and correlates it with a clinically relevant event. I also call it the EKG, or the continuous EKG of vital signs on the general hospital floor. This was the Prodigy study. I'd like to acknowledge all of those who participated in it. We built the Prodigy risk prediction score that actually looked at what patients are at the highest risk of opioid-induced respiratory depression on the general hospital floor. Frederick Michard talks about the future as well, and he talks about machine learning and AI being sort of a natural progression to all of this continuous monitoring on the floor, because all of this is, in the end, just a pattern of changes with heart rate, respiratory rate, oxygen saturation, and so on and so forth. So all of the AI enthusiasts in this audience hopefully are encouraged when they see all of this. And you all have seen this as well. You know, there's been a number of editorials written on a hospital system of the future, where patients, either every patient will have continuous wireless wearable technology on them, and then we'll have some sort of a command center that filters out the noise and artifact, and then an AI engine in the back that also incorporates labs and patient values. And then most importantly, I hope there will be an actual efferent response arm, because that is the one thing we're really lacking and struggling with today. We're okay putting devices on people, but we really don't know how to respond. That efferent arm is missing. And really, I don't need to say it again and again, but Frederick Michard does a great job with this. And I love this infographic. He talks about, what do we really need more reasons for continuous monitoring on hospital wards in the setting of, you know, opioid-induced respiratory depression, nursing shortages, ICU bed shortages, more complicated high-risk surgeries, and increased frailty and the geriatric population landing themselves in the hospital. We really need to do all of this. So my final slide is really looking at next steps. And next steps, I will say in short, I've talked about all of this, including having the right trial design to examine patient-centric outcomes, having a rich repository of vital signs data and doing the analytics on it, looking at alarm fatigue. I didn't have enough time to talk about that, really analysis of alarm fatigue with modeling of alarm thresholds, patient safety guidelines, of hopefully a national patient safety consortium that looks at continuous monitoring in and of itself. And really, the help I'm asking for here is that we, as anesthesiologists and perioperative physicians, really take ownership of the space. We've for long been sort of guilty of saying, well, you know, not really my problem. It is really our problem, one way or the other. So I hope that we're going to take ownership of the space. This is my research team at Wake Forest. It's growing leaps and bounds. I want to thank them. They're more than 30 now in number, and they're doing all of this great work that we do for vital signs monitoring within and outside the ICU. Thank you so much for your very kind listening today.
Thank you, Ashish. So as I mentioned, we are going to pause here just for a few minutes for questions for Dr. Khanna due to his flight arrangements, and we'll get on to the next speakers. Just to get started, we showed at the beginning of this session a couple poll questions. One of those was, what factor was most likely to drive investments in these continuous monitoring technologies in the med-surg ward? How did you respond to that? Was it oversimplified? Does it need to be all three of those things or more?
Yeah, I thought your options were slightly oversimplified, but I responded by saying the evidence for clinically relevant adverse outcomes. And I think if you see the theme of my talk today, I think we still haven't published enough or published robust evidence that shows that monitoring in and of itself decreases clinically relevant adverse outcomes. Even though I'm a huge proponent of monitoring, I'll be the first to admit that we need to do all of that.
Thank you. Questions in the back?
Yes, thank you very much. Matt Weinger from Vanderbilt. My colleagues in health services research have been pretty aggressive and successful at developing pragmatic clinical trial networks like BCORINet. Can you comment on the feasibility, and maybe that's already happened and I don't know about it, of creating a perioperative or say post-operative pragmatic trial network of national multiple hospitals that would have the infrastructure and have standardized outcomes, standardized approaches, et cetera, to collect pragmatic data focused, as you said, on important end outcomes with a lot of emphasis, as Meghan Lane-Fall, for example, is doing in handovers, on the implementation phase of it, which is what BCORINet has been doing.
Sure. So the question is whether we can set up something like BCORINet for continuous monitoring. And the answer, if you ask me, would be a resounding yes, but that would need a significant number of hospital systems in this country to adopt continuous monitoring and start using it as standard of care. I think, as I know right now, there's only a handful of large hospital systems that have implemented continuous ward monitoring. So I'm hoping that day will come.
Ashish, excellent talk. Question, and one thing you alluded to at the back half of your talk was, how do we respond and who's going to respond? And that answer is different across the United States and across the world based on the resources, the experience of the providers that are responding. How do you sort of answer the question, whether it's at home, PACU, ICU, or on the floor, who should respond and how should they respond? And how can we look at that from a more of a global delivery of care? Because we can have all these fancy technologies, and at the end of the day, if we're not responding in the appropriate manner, and we don't have the necessary education on how to respond, it doesn't matter what the monitor is showing.
Sure. So, Steve, what you've asked is complicated, and probably I'll spend an entire day trying to figure that out. But I will say that my short answer is the implementation science piece is really critical. We are guilty of either just throwing these monitors on our patients, or, in my case, publish the data and say, oh, look, there's a risk reduction, and then walk away and say everyone should be monitored. I think I will say that the first part of things should actually be the other way. You should first go to your floors and ask your floor nurses and nurse managers and the CNAs what they see as the perceived challenges to continuous monitoring, then develop the devices that will help mitigate those challenges, and then work backwards. We're not doing this the right way, so we need to work backwards, start from there, work backwards, design the right devices, the right technology, and then come up and do the trials with those devices.
Jim Suchik, University of Michigan. Great talk, and great for highlighting the difference between spot checks and any form of continuous monitoring. So my personal protocol that I've had to use some of my personal capital with the holding room nurses is to get them to pop the pulse ox on and leave it on the patient while I'm doing my interview and for a while after. And then I detect a lot of desaturations at that point, and I've gotten some positive feedback from the nurses on the rare occasions where the guy drops down to 88, and it's like, you're going to take care of this guy after the surgery. This is his normal. This is where he lives. But how can we because this is the organization that crosses those silos, get buy-in from the nursing? Because a lot of the nursing is very, very reluctant they perceive it as an increased workload. Hey, this guy's got AFib. I want you to put the ECG on him. And I've got personal relationships with most of these holding room nurses because I've been there forever. But how do we institutionalize that?
Well, you guys are asking me real hard questions today. I think that is the real challenge. I will say that our nurses and our frontline providers need to see some real world examples of how this will actually be a helpful tool. This should not be perceived as extra work. Now, we also need the Epics of the world, the healthcare IT systems of the world to make it easier for our floor nurses. I was just telling someone yesterday, I see in my ICU nurses end up staying on an average 2 hours after their 12-hour shift is over just to validate all of the vital signs that all of the monitors have put out, right? That is painful. I don't blame them for leaving their jobs and looking elsewhere, right? And look at, like, if I put continuous monitoring on the floor, an average nurse is carrying 10 patients, how late would that nurse have to stay to finish validating all those vital signs, right? And the artifact and so on and so forth. So we need to make it easier for our nurses. We need to make them believe that this is helping patients and not adding to validation workload. That's probably my simple answer right now.
All right. Hi. First of all, thank you. This is Julian Goldman from Mass General Hospital. That was a fantastic talk. I'm trying to think about what it is that you've been measuring and studying and what the community is looking at, and if that's really the right thing, in a sense that if we're looking at conventional threshold alarms and seeing if they're useful, is that what we should be doing, or should we be enabling the development of somewhat smarter alarms? Now, perhaps that's what you're doing. So, for example, clinically, if there's a drop in blood pressure that's trending down slowly, but there's a concurrent increase in heart rate or pulse rate, we would treat that differently, for example. The same thing, say, with a small decrease in oxygen saturation, but an increase in respiratory rate. We know that that means something else. So my first question is, does your current platform allow you to do that and to deliver a real-time alarm using information like that? And then my second question is, should that be the direction that we go to assess the value and the potential for continuous monitoring, assuming that the old way of doing it with threshold alarms, bringing someone to the bedside, really is the old way, and it's not the way that we actually practice when we're at the bedside.
So my continuous monitoring system right now allows me a level of personalization where we can put in delays at the level of the monitoring device, which means, for example, if a patient's been desaturating, the alarm won't go off till a sat is less than 85 for at least 3 continuous minutes, right? Now, that's one way to mitigate artifact. The other thing the device does allow us to do is totally personalize it, right? So if you have a young trauma patient, 20 years old, who's tachycardic because of pain, who can take heart rates of 120, you can set that alarm at 120 or 140. If you have a person who's 80 years old with triple vessel disease, you won't, you set a lower heart rate threshold, right? So we have individual patient level personalization. I will tell you, in the real world, that's really difficult. We try and personalize entire floor units rather than individual patients, because if a nurse is carrying 10 patients with 10 different thresholds of each of the vital signs, that's not fair to that nurse, right? What you're saying is, you've hit the nail on the head. If I had, everyone listen to me, if I had the funding and the technology and the know-how around me, I would love to actually bring together a combination of vital signs that predict for organ system failure. Even things like myocardial injury after non-cardiac surgery that PJ Devereaux and Dan Sessler had done all the work on, they say, oh, it's a map of 65. I don't think it's a map of 65 on the general hospital floor. Patients are not hypotensive after surgery, not as much as we think they are, right? So I think if we really have to look at organ system injury, we have to find that change in combination of vital signs that predicts for organ system failure, which might be different for you, might be different for me, might be different for JW here. So that's where the AI and machine learning will come in.
Well, and some of what we're talking about does not require that level of sophistication research, because these are the patterns that we use clinically.
Sure.
Under NIH funding several years ago, we addressed that documentation burden by auto-validating vital signs. So if the pulse oximeter pulse rate is the same as the ECG heart rate, it's the same as the rate coming from your NIBP or invasive blood pressure, that's probably the correct rate, and you might as well do that. And that's a demonstration that we presented at meetings, and it's just published research that if one wanted to download that code and play with it, it's on openice.info. Again, the work of some NIH work from several years back. Thank you.
All right, we're going to wrap up the questions here. Ashish, thank you very much for the presentation. Safe travels to you, and we'll get on with our next speaker.
Thank you, guys.
We have the slides back up on the. There we go. I'd now like to introduce Dr. James Grant, who will be discussing a healthcare payers approach to value-based care and innovation. Dr. Grant is the Senior Vice President and Chief Medical Officer of Blue Cross Blue Shield of Michigan. Dr. Grant previously served as chair of the Departments of Anesthesiology at Cedars-Sinai, Oakland University William Beaumont School of Medicine, and the Beaumont Health Royal Oak Campus. In 2018, Dr. Grant was elected president of the ASA. He currently serves as board director for the ASA, the Anesthesia Foundation, and the Foundation for Anesthesia Education and Research. In addition, Dr. Grant currently serves as chair of the Anesthesiology Section Council to the American Medical Association and is a senior examiner for the American Board of Anesthesiology. Please welcome Dr. Grant.
Oh, you got this? Okay. Well, good. Thanks for everyone, and thanks for having me here today. It's a really unusual venue, and actually the first time in my 3 years in this position that I've actually been able to come to a clinical group to talk about really technology issues, which are very different. And if anyone doesn't like what I have to say, I think you can find, Patty Riley's over there, because Patty called me a few months ago and said, would you please talk about, what the payers do with technology? And if anyone knows Patty, you can't say no to her. And I said, I don't know. I have to start this from scratch. She goes, please. So I said, okay. I said, so I'll wing it here. But no, thank you here. And I too, and I'm going to share something with this group because it sort of came out when I was hearing some of the other talks. I too have to leave early, and I have a 4 o'clock flight today because I have to be back in Michigan. 4 o'clock flight today gets me back in Michigan like 11 o'clock because of the time change. Because I have a 8 o'clock meeting in the morning. Does anyone know what the Keystone project is? Keystone Center for Patient Safety? You've heard of it? Kevin's heard of it, I'm sure. Keystone Center for Patient Safety is actually sponsored by the Michigan Health and Hospital Association, and that's where some of the things like checklists actually came out many years ago, and a lot of Peter Pronovost's work actually came through there originally. And we've actually shown, and Blue Cross Blue Shield of Michigan actually donates up to about $5 million a year to support Keystone. So because we actually at Blue Cross, really, we're a nonprofit, and I'm going to talk a little bit about the industry throughout the talk. We're a nonprofit that's really committed to the people of Michigan, and we really believe if we can invest in safe care, actually safe care will turn out to be actually greater value care and less expensive care. Good care is, bad care costs money. Good care is what's actually the greatest value. So what am I going to talk about? I'm going to talk about we're going to talk about the initiatives and how Blue Cross Blue Shield is actually a national leader in value-based care. And I don't know if anyone saw an article, I think it was in Becker's or something like that, just last week, that shows most Americans, and I don't like it either. When I first joined the plan, which was it was a 180-degree turn for me to actually join the plan. It was not something that was in my career plan. It came out of nowhere, and it came out of a very visionary CEO who said, I really want somebody in the C-suite who's been a physician and patient advocate and who understands and can be a voice of the clinician in the boardroom. And that's actually how I got to this position. I had never worked in a plan before. He actually thought he wanted a clinician's voice at the table. And that's really how I ended up there. And to this day, that's what I do. I don't sit there and, I told him, I said, if you think you're going to have a guy that's in there slicing dice and, hemoglobin A1Cs and county 22 and figuring out, I said, and they're figuring out payment plans, that's not me. And he goes, no, that's not what I want. We're going to talk a little bit about the what we call the Blue Cross Blue Shield. And actually, we were talking about it, and we're going to talk a little bit of our support of what we call Aspire. And that's one of our 17, what we call up to 19 now, collaborative quality initiatives. And that's actually helps, again, to take better care. And I'm going to talk a little bit about those. I felt really funny, we were talking about it. Is Nirav here? There he is. So I get all the slides ready, and I'm going to talk a little bit about Aspire. Then the other day I found Nirav's going to be here. So he actually runs Aspire. It's like, well, why am I talking about it if he's there? So I'll talk a little bit about what our relationship is with Aspire, and Nirav will probably talk about the rest. And we're going to talk about new technologies. And one of the things that I really want to get down is, if you've seen one payer, you've seen one payer. As a matter of fact, if you look at anything that comes out of us, it will say, Blue Cross Blue Shield of Michigan, always at the tagline at the bottom, an independent licensee of the Blue Cross Blue Shield Association. So if you say, well, if you're doing this at Blue Cross Blue Shield of Michigan, how come my Anthem plan's not doing it? You're all Blue Cross. Blue Cross is actually 43 independent associations under the same, Blue Cross Blue Shield brand and banner. That they're collaborative efforts, but they're independent. And then, anyone here from California? Okay, California is a great example. California is the only state that really has Blue Cross and Blue Shield as two separate companies. Blue Shield of California is a not-for-profit. Blue Cross is Anthem in California. So there's actually a lot of variations, and we're seeing a lot of consolidation amongst the Blues. As a matter of fact, if you're from Louisiana, you know that Blue Cross Blue Shield of Louisiana they're in the process of getting purchased by Anthem. Our company, Blue Cross Blue Shield of Michigan, is in the process of having a strong affiliation with Blue Cross Blue Shield of Vermont. So we're seeing a lot of consolidation. And there's a big difference between the not-for-profits, which we are, and we're actually, our dollars go back into the community, and the for-profits. I'm not, you know who the for-profits are, the Uniteds, the Humanas, and the Blue Crosses, all except for Anthem, pretty much are not-for-profits. So it's a lot to understand in the industry. So if you say, why are you doing this, but my Blue Cross is doing it, don't you have, your same company? We're not really the same company. We coordinate, we collaborate, we look for better ways of delivering care, but we're actually totally financially independent organizations. So one of the things that actually I'll talk about is we're an 83-year, company's been in existence for 83 years. We have, and actually that number of 5.3, we actually have just shy of 6 million members. We're the 9th largest insurance plan in the country. We're the 3rd largest Blue Cross plan by membership. That number there is wrong. It's not 32 billion in gross revenue. It's 40 billion in gross revenue now. And if we weren't a nonprofit and we were on Forbes rating, we'd be about number 283. And we have over 10,000 employees. So we're a pretty big company. We're just not a health plan that's in Michigan. And we do that. We pride ourselves by actually wanting to take better care of people, because we've proven over the years, you take better care of people, you actually become a more successful company. So we're going to talk a little bit about value-based care. Again, a term I really don't use. I'd like to actually change the term to maybe quality-based care or quality-focused care. This is an article that I wrote with my DIAD administrative partner that was published both in Cranes and in Modern Healthcare. And it really shows what is the difference in value-based healthcare. And what it is, we're really focusing on taking better care of people, taking the incentives and making them focus on quality. Drive reliable incomes for providers. One of the things that we learned during the pandemic was if you're in a true fee-for-service environment, it was going to be a struggle to get paid. Now, we advanced billions of dollars in payments so that our providers and our hospitals could keep the lights on. But who knows if we can always do that? And it's becoming, we're now in a catch-up phase. We promote population health. All of our initiatives that you see are going to promote taking better care of our population, getting blood pressures under control, getting obesity under control, getting diabetes under control. And we know as a company, and we have actually strong relationships with our physician community, and that's actually my job. And what we want to do is we want to lower physician stress, and we want to lower physician burnout. Is when you talk about utilization management and quote prior auth, we are doing everything we can, and we have some initiatives we're going to be rolling out shortly to even further decrease the number of prior auths so that we, doctors and nurses and their staff can actually spend more time taking care of people and not computers and not being on the phone. We trust the judgment. We want to do more gold carding. I always like to use an example. My wife's a physical medicine and rehab doc. She is in a practice of 16 physicians, 16 private practice physicians. They have three people that do nothing but prior auths all day. And this is what we want to get away from. So what do we want to do in a value-based environment? We want to optimize outcomes. We want to pay for outcomes. We don't want to pay for just, procedures. We want to pay to show that everyone's doing a better job. And we're going to pay more. We may pay more to do for better outcomes. And as we look at environments where we're looking at risk, and we may pay less when outcomes aren't that good. We're totally focused on patient experience because patient experience and provider experience will deliver better patient care. And that's crucially important to us. It's crucially important because one of the things we talked about is Medicare star ratings. A huge chunk of Medicare star ratings are based on experience. What are the Medicare recipients saying about their plan? If a company loses a star, when Medicare Advantage recipients go onto the website every year to pick their plan, they're looking at the number of stars. And the number of stars is crucial. And actually, Medicare pays the plans that administer Medicare Advantage products based on their number of stars, and there's thresholds. You lose a star, companies like us could lose up to $250, $300 million by just losing half a star. So you want to keep your star numbers up because the recipients are looking at stars and CMS is looking at the stars. And affordability. At the end of the day, we've got employers out there saying we can't afford these kind of premiums anymore. We can't afford to pay these kind of healthcare costs. So we've got to figure out, we're sort of caught in the middle. We got to figure out how to work with the providers to make it to have greater value, to make it affordable, so that our employers can actually do what they got to do. We have a defined population. We need a whole person approach. We are spending millions of dollars right now investing in behavioral health programs. And why are we doing that? Because we have learned that behavioral health affects physical health. So the pandemic taught us that, and we're totally revamping all of our BH, or our behavioral health programs. Psychiatrists, we don't have enough psychiatrists in Michigan. We don't have enough psychologists in Michigan. We don't have enough social workers in Michigan. And we've got to figure out a way to get the community better care. The one beauty that came out of the pandemic, obviously, is greater telemedicine. And that's sort of what's saving the day a little bit for us. As we're developing programs, we're actually being able to take a look at getting people the care they need on a screen, not necessarily having to wait to get into a psychiatrist's office. And we're driving results by focusing on getting patients the right care at the right time. And that's what our focus is as far as prior auth goes. It's not prior auth to check the box to say no. I mean, 99% of our prior auths are actually approved, but we want to make sure the patient's getting the right care at the right time. We want to make sure there's no contraindication. It's actually another part of the safety checklist. So where are we? Where are we now? So where's Blue Cross been? Blue Cross is really, really different. And I apologize because the one thing I've always tell everyone to do is not look at the screen, but for some reason, the way it's split up, I can't really see it right there. In 2005, we launched what's called the Physician Group Incentive Program. And what that is, it was more primary care focused, and it was a holdback. It was a holdback of X number of dollars per doctor in the state of claims that they received. This money, and it was matched by us, went into a big pool, and then at the end of the year, it was sort of divvied out by who had better outcomes. And it was sort of focused on what we have in Michigan is called physician organizations. At the same time, the CQI initiative portfolio was launched to address areas of hospital care. Now, the CQI initiatives pretty much are procedure focused until this year. And we have two new ones. Actually, we've gone from 17 to 19. We cut one back. From 17 to 19, one of them is back pain. I mean, this country spends billions, if not trillions of dollars in back pain issues, and the other is actually diabetes management. So it's our first venture into non-procedural based outcomes. Our physician group incentive program has actually shown we're able to take better care of people. And we take better care of people. There's 4 meetings mandatory that everyone's at CinePedia program needs to come to, where we talk about outcomes, and we talk about metrics, and we talk about who's taking care of better care of people, where the obesity rates are up, where the diabetes rates are down, and how can we learn from each other. The one thing about the CQIs, and Nirav may talk about later about his, is in the other specialties. It's, competition, your competitive hats are left at the front door. When we get in there, one of our most successful CQIs is actually the urology one. And they all have these very gimmicky names, and I don't know how we found them. If you want an acronym, come to Blue Cross Blue Shield of Michigan. We will get you an acronym before we even decide what it's going to be called. We'll figure out the acronym first. As a matter of fact, we have 2 Aspires. There's a different project called Aspire, and then there's the anesthesia project called Aspire. But we can acronymize anything. But music, which is our urology acronym, all the hats are left at the front door, all the competitive hats, the academicians, the University of Michigan folks, the Henry Ford Health System folks, the private people in, northern Michigan and rural Michigan, they all leave this aside and they all get together 4 times a year. And they take a look at the data and they say, who's doing things better? And, we've shown actually incredible outcome changes of care in Michigan by getting the teams together, regardless of their focus, regardless who's paying them. They come together as docs, wanting to do better work for Michigan. Blueprint for affordability products, we're getting out there. Again, that's value-based. That we're getting in there, and actually at some point there was upscale, that if you did a better job, we paid you more. And as we're working into what we call a full risk environment now, we're going to pay you, we're all taking risks, and we're going to pay you more, a lot more, if you take really good care of people. But now we're actually going to take money back if you're not taking that good care of people. Our goal, we'd love it if you took great care of everybody. That would be our ultimate goal. But I don't think we're there quite yet. So as time goes on, as a matter of fact, in Michigan in January 1st, 2023, 33% of our Medicare Advantage recipients that are part of a Blue Cross product were in some kind of what we call a full risk model. Not partial risk, which is a little bit of upside, but full risk, that if you take great care, you get a lot more. If you take poor care, you get a lot less. So it's a new paradigm, especially for our PCPs. So here is the slide that I'm not going to talk much about because the experts are here about it. I couldn't be more proud of it as an anesthesiologist. I mean, it's actually, I shouldn't even say it, but it's, Nirav will tell you it. There's 19 of them. I don't go to all of them, but I try not to miss my own specialties. And get together 4 times a year. The team is amazing. The team does great work. The team brings everyone together. I couldn't be more proud of the work that the Aspire team is doing in Michigan. There are, when we talk about one of our great CQIs, Aspire is always one of them that comes up. So give them some credit. Aspire is, what we do is, Aspire is really a division of MPOG, and I'm sure most of you have heard of MPOG. And what Blue Cross Blue Shield of Michigan does is we actually pay for our Michigan practices to be in Aspire. So almost every Michigan practice, and the ones that aren't in, that's their choice, because we pay for them to be there. It costs us about $100 million a year, $100 million a year to actually fund all these collaborative quality initiatives. And you say, well, why do you do that? You're a health plan. Why are you spending all that money on this? Because we truly believe, and we believe that the $100 million we spend a year has saved us billions of dollars in better care. And that's why we're so proud of the CQIs. There's a great article that was in New England Journal of Medicine Catalyst about 6 months ago, where we actually talked about the work that's being done. It's 25-year anniversary of the CQIs. High quality measures, review best practices, exchange ideas, and talk about what's working well here and what's working well there, and see if we can come together to do, like I said, take better care. What can we say? 16% of, Nirav, you probably can talk even a little more about this. 16% improvement in perioperative glucose, all came from Aspire. 4 times as many patients received smoking cessation counseling compared to 2021. And Nirav will probably correct me if these numbers are wrong. And a 25% reduction in the carbon footprint by some of the work that they're doing to reduce gases in the OR. So as technology advances, healthcare, we're taking a look at how can we do better. So we have partnerships. The one thing I will tell you that any health plan is looking at, we are doing anything we can to keep patients out of hospitals. Hospitals are incredibly expensive places. We are actually in a venture of more and more hospital at home projects to see if we can get patients to stay in a home, stay in their environment, and we will bring hospital care to them. We've got multiple programs, and actually a lot of them are private equity based. Landmark, in-home care. Actually, Landmark's owned by Optum now. That was just sort of flipped about a year ago. In-home assessments, Livongo, which does A1C management. And I can't even tell you, this is just a small partial list of the vendors that we have. And that it's all, we need technology, and we're willing to invest in technology if it actually can keep people at home, in their environments, and out of the expensive hospitals. So how do we determine this? So at Blue Cross Blue Shield, there's really two splits. There's actually commercial, which is those that aren't Medicare or aren't a government-funded program, and that's those that are under 65, or actually those over 65, and then there's those under 65, which we call commercial. I don't sit in the back of the room and say, oh, I like this policy, just, let's pay for this. I don't really deal much with payment policy at all, except for advocating for what's good care. But what we do is we have what we call the JUMP committee. And that's a Joint Uniform Medical Policy Committee. It's not made up of a bunch of insurance executives. It's actually made up by clinicians. It's made up of really a mixture of academic clinicians. There's an incredible number of clinicians from Ann Arbor on the committee. It's made up of a collection of private physicians who are actually in the fields, actually, taking care of patients, taking academicians who are taking care of patients, academicians who are also researchers, and they all get together to find out what's the best way, what should we be paying for? It's physician-led, it's multidisciplinary. It actually takes a look at clinical evidence, and sometimes it looks at clinical evidence and actually makes a decision based on that. And then we'll create a medical policy that informs the benefit and reimbursement decisions that we make every day. And that's really, really the core of it. It's independent. They're at an arm's length. I don't appoint people to them. We get people who are actively engaged and wanting to take great care of people. And that's what the JUMP committee is all about. And the JUMP committee makes it it's evidence-based, and they will actually make the decisions on what they think we should be paying for. One of the greatest misconceptions of healthcare, the JUMP committee can make a decision. One of the greatest misconceptions of healthcare is there's always this, everyone thinks that, we get a call in October after open enrollment to, hello, this is, I'm just using them as an example. Obviously, they're probably one of our biggest, if not our biggest client. Hello, this is, the CEO of General Motors. I want to buy 500,000 plans this year. That's not really how it works. Sort of your big organizations like that, they're what we call our self-funded customers. We administer it for them. They're actually paying the bill. So we can have a benefit and says, everyone should have watches that tell if you're an AFib, and we can call it a benefit. They can say, that's a great benefit, we're not paying for it. And the other way around, we can say, well, something's sort of questionable. They're saying we want to pay for it. And then, we administer it then. It's our, the ones that actually buy insurance, the insurance that you think about, that actually is what our benefits plans actually come up with. So what's the JUMP committee do? They look at the safety and effectiveness. They look at the margin of improvement. They actually take a look at reproducibility and the quality of the evidence. And then they make a really sound clinical judgment. There's no bean counters in the room. There's no economists in the room. There's no actuaries in the room. And at Blue Cross, it's pretty tough to keep an actuary out of the room because they love being there. They're everywhere. As a matter of fact, I'll tell you something. If you ever get in this business, and you just want to delay a discussion. I do it all the time. It's like, just call actuary. Because they can go in and by the time they slice and dice and they come up all the data 6 months later and, they come up with something that, you're just like, okay, whatever. So that's something that, we do this independently. And that's what we decide. If a product comes through, if a device comes through, it goes to the JUMP committee. Now, the JUMP committee can only deal with commercial because we have all these separate rules for our Medicare Advantage patients that actually come from CMS. And that's a whole different team that works on those policies because those policies have to be very consistent with what CMS advocates. So after they evaluate it, they determine it. We ensure that the technical requirements are all set. It's really hard. You say to yourself, I can't tell you how many times this happens. We process billions of claims a year. Think about it. If one member gets a CBC and then a blood draw and then an EKG. Think of all these claims benefits. Do you ever open up your explanation of benefits and it comes like in a binder that big? You're only in the hospital 2 days. So we just process billions of claims every year. But we have to make sure if we approve something that there's a code, that the systems are correct, that the right people will get paid for it, because not everyone gets paid, can get the same benefit for the same person. And it's an incredibly complex web. And then we have to make sure that the self-funded groups are pretty much on board. So we can approve a device. And if the self-funded groups aren't on board, we have to make sure it's programmed so that the beneficiaries in that self-funded group don't get it paid for. So it's actually a complicated web, but you actually can get it through the system that way. So what's an example? So an example of was lymphedema. So a current medical policy says that a bioimpedance device, because someone said, give us an example of getting something through the system. So a bioimpedance device for cancer-related lymphedema is currently investigational. Investigational products are not considered a covered benefit. Makes sense to you? It makes sense to me when I first got there. But all parts of the policy were reviewed, and actually the JUMP committee actually saw a lot of new evidence that came out showing there's a lot of clinical publications with really great subject matter experts in the provider network that really consider the guidelines from the National Cancer Network, and the JUMP committee determined that actually the bioimpedance device for lymphedema is established. So it was considered investigational, but we brought the key subject matter experts in the room, and they said, well, technically it's labeled investigational, but these are the great things that's happening. And we've approved it. And once we've approved it, it's now, our members have access to it, and it's actually considered a covered benefit. And the last thing I want to talk about is what's called the Blue Venture Fund. And the Blue Venture Fund, it's a sort of, they're angels. The Blue Venture Fund is all except for one of the Blue Cross plans that are together. It's a totally separate entity, totally independent, totally financially separate, that actually will take good products. If you bring a device to the Blue Venture Fund that you think is really good, that you need growth money for, you need seed money for, you need round 1 or round 2 funding for, the Blue Venture Fund will actually be there to help fund it. And the Blue Venture Fund funds millions and millions of dollars of projects every year. And again, it's independent, it's the not-for-profit blues that get together to see if we can fund better healthcare, if we can fund better ways of taking care of people. And that's what it's all about, especially at the not-for-profits. I'm not here to talk about the health plan, but what I'm here to talk about is the health plan realizes that if we can keep people out of the hospital, if we can take care of better people, we can use technology to our advantage, and actually, at the end of the day, it's going to be a better, healthier population for everyone. So on that note, thank you. And I think next is the panel, or is next? Okay.
Thank you, Jim. Thank you very much, Jim. I'd now like to introduce Dr. Dheerendra Kommala, who will be discussing wearables, consumer versus medical grade, and the regulatory perspective. Dr. Kommala is the Chief Medical Officer for ECRI. He previously served as the Chief Strategy Officer for ECRI. He brings more than 20 years of experience as an academic clinician, researcher, and Chief Medical Officer. He successfully introduced new products and services to markets throughout the world by working collaboratively with major companies, industry leaders, clinicians, and patients. Throughout his career, he's been a vocal advocate for patient safety and a visionary leader managing large teams. Prior to ECRI, he was Global Vice President of Medical Affairs for Baxter Healthcare. He was also Chief Medical Officer, Vice President of Medical Affairs for Convatec, and Associate Medical Director of Global Pharmaceutical Research for Renal Care at Abbott Laboratories. Please join me in welcoming Dr. Kommala.
Good morning, everybody. Can you hear me? JW, thank you for the invitation, and APSF, thank you. This is my first time being here. Excited to be here. Fourth of 4 presenters, not a good place to be between you and the break. So I'll try to make this as quick and painless as possible. So I'm here to talk maybe a sort of a different topic. I want to talk about wearables, more importantly, consumer grade and medical grade devices, and then the testing that we do at the ECRI lab, with the focus being on human factors and usability. That's going to be the essence of my talk. How many of you know ECRI, by the way? Just a show of hands. Thank you. This is not the response I get when I go and speak about ECRI, so I like this. Anyway, so we're a small organization, about 600 people. We are located in Pennsylvania. We're founded by Dr. Joe Noble, who's a critical care anesthesiologist. He was trying to resuscitate a baby, and 4 consecutive resuscitators failed. That's when ECRI started. He thought, why is a post-marketed device failing 3 to 4 consecutive times? So we started a lab which started testing devices. And we started sending alerts out to providers to ensure that people understand some of these equipments which are out there in the market may not function the way they're intended to. So that's how we started 50 years ago. We've evolved. We are the largest patient safety organization in the United States. We've collected over 6 million adverse events over the last 10 years. Our mission is very similar to APSF, which is we are striving to get to 0 preventable harm. That's our mission as an organization. We are also an evidence-based practice center. Just to give you some stats, we have over the last 3 years evaluated about 256 devices. I'm going to talk about a few of them today. We have also, as I said earlier, collected about 6 million adverse events, and we glean data and insights from those adverse events to inform providers. So Lee talked about the fact that care is transitioning from an acute care setting to alternate care sites and home. There's a McKinsey article which came out recently, which talks about $250 billion was spent over the last 3 years, Medicare and Medicare Advantage, in treating patients at home. Projections are that in the next 5 years, there's going to be a 10% growth in terms of patients being treated at home. The next 10 years, about 10%. So this is real, this is happening, patients are transitioning. It drives unique challenges for us, which is how do we take care of patients at home without the level of scrutiny that we have in an acute care setting? So the challenges are sicker patients are transitioning to non-acute care settings, and the length of stay is decreasing in acute care. So we have to start to think about treating patients at home. Patients have to take care of themselves through caregivers with very minimal, if any, clinical supervision. It's reality. And then there is a ton of new devices coming out in the market, and we're going to talk about a few of them. They're not necessarily tested from a human factors and a usability angle. So we need to start thinking about user-centeredness for new devices. And then there's about health technology literacy at home, which is critical. So just to touch upon what is a medical grade device versus sort of a consumer device. Typically, a medical grade device, and Lee talked about it in the morning, class 1, class 2, class 3, it's regulated by the FDA. And essentially, FDA reviews for safety and efficacy, whether you go through a 510K process or a pre-market approval process. Consumer devices do not go through that process. There's also no obligation to follow quality standards for consumer devices. And then there's no collection of adverse events with consumer devices as compared to medical grade devices. Okay, I touched on this, but why should we apply human factors to healthcare? We always forget that at the end of the day, the patient is at the center of all what we do. And they are being influenced by different personnel treating them at the hospital. Now it's at the home. Processing procedures are different. The place is different. It's an acute care setting versus home. The different accessories are different. The products are different. There are many variables which are different. And for us, we need to start thinking human factors. 3 considerations. Who are the users? Where do the users work? And what kind of user interface? That forms the basis for human factors. So I just have a list of devices that we have tested, some of which I'm going to talk about. Really 3 categories. We call it identification or notification devices, which are, in this case, I've used the example of a baby vital signs monitor. Self-care or preventative health, like Fitbit or trackers. And then disease management, which is around cholesterol tests or blood glucose monitors. Okay, so just smartwatches. We tested 6 devices from 3 vendors, the Fitbit, the Android, and the Apple Watch. And my focus in this talk is primarily around usability and human factors. So I'm going to stay away from other areas. But the core functionality was sound. But what we found was fall detection, which is advertised by some of the devices. There was a problem with that, and it didn't work reliably. And then there is what is called passive AFib detection, which could cause problems when people are detecting passively AFib correctly or wrongly, when it's not meant to. But the most important usability issue that we saw was when consumers recorded EKG, it was difficult to actually find that EKG. Go and retrieve and find that EKG. And then the other piece was around sharing of this EKG with clinicians was not thought about in the context of the patient themselves. This second piece here is a baby vital signs monitor. It's a smart sock. We tested 2 devices from 2 vendors. These are not considered medical devices, did not require FDA pre-market review. Sorry, okay. There's a human factors problem here, by the way. So the vital signs monitor, the smart device, we tested 2 devices from 2 vendors. And what we identified was, first, is there a utility of this device? It's not very clear about the unmet need. The second piece is around, there was poor correlation of blood oxygen saturation with a medical grade pulse oximeter. This testing probably was not done before the product was launched. And then setting up Wi-Fi connectivity was a problem. With smartwatches, I talked about this, sorry. Smartphone-enabled devices, this is measuring EKGs. In this case, what we found was screen resolution was a problem. So we couldn't actually read well from a device. And the small fonts actually created misreading and misinterpreting of results. And then finally, home cholesterol devices. What we detected was you could actually insert the strip in reverse fashion and still get a response, still get the answer. And the answer came out normal, by the way. So some of these consumer devices, we've tested from a human factor standpoint. We identified these issues. At the end of the day, we need to really start thinking about safety and efficacy, not just for medical grade devices, but also consumer devices, because they are being used right now. Not just for identification, but for diagnosis. Data access is important. And then technology needs to be easy to use. I'm just going to go to the summary. I've worked for product development companies for over 20 years. And human factors is really not considered a prerequisite prior to launching a product. That has to become a prerequisite. Human factors assessment, usability assessment has to be a prerequisite. You have to test for usability, not just for safety and efficacy, but also for effectiveness. And then we need to start thinking about reporting of safety events, not just for medical grade devices, but consumer grade devices. Thank you so much for your attention, and glad to take questions.
You can keep that microphone over there for you guys. So on the schedule, we are at time for break. We're going to do about 5 to 10 minutes of Q&A, still get you all a nice, healthy break before the next sessions. We have microphones in the room, so please step up at any time to ask questions. Anura, I wanted to start with you. So we talked about data in several different instances this morning. Ashish actually mentioned his preference of having data on-prem, data there at the hospital rather than going to the cloud. Concerns about latency and maybe access to that data. Could you just talk a little bit about where data storage and computation may exist and kind of the trade-offs and benefits? It's kind of like on-device, premises, or in the cloud.
Sure, yeah. So, as we talked about a little bit during the talk as well, there are always trade-offs, when you make design decisions. That includes where you have storage and processing. As technology shifts, some of the approaches are also shifting. So when you have data closer to the processing, of course, you're going to have less latency and things are going to move along faster. But then also when you look at using certain or leveraging certain technology trends, for example, like with 5G communications, a lot of the large cloud service providers are starting to co-locate their data centers with hospitals, for example. So that way you can still derive some of the economic benefits of working with a service provider in conjunction with, gaining from that technology trade-off and still having the proximity needed for that type of solution. And, as processing power increases and as we start to shift from things like, conventional CMOS technologies to quantum computing and things like that, we're going to see, I think, very significant shifts in how processing is handled and the speeds at which they're handled. For example, the stability of quantum computing technologies right now is on the order of microseconds, but you can do a lot of processing within that time. So I think, overall, as technology continues shifting, we'll look at proximity and architecture and design strategies in conjunction with those technology trends.
Thank you, Anura. You can hold on that. Steve?
Thanks, Steve Barker. And disclosure, I'm a consultant for Maxime. In that last talk on wearables, I know the technology is changing very, very fast. I just want to encourage you to take a look at Maxime's W1 watch in that area. As far as comparing it to the Apple Watch, it compares very well. Here is, oh good, you can actually see it. That display you see on my iPhone is coming from my watch. It's not only my pulse oximeter saturation, but my respiratory rate, which you don't get from most pulse oximeters, and a lot of other data that I won't bore you with right now, including hydration. So take a look at it, compare it with the others, and I encourage everybody, this is a rapidly changing field. A lot of new stuff is coming out. I find it very exciting. And the last thing I'll say is, when I always think of Overdike's data, 5,000 dead in beds, inpatients every year. How can that still be happening on wards when we have this kind of stuff? All you have to do is wear a wristwatch. What are your thoughts on that?
Thank you for the question. And definitely we have to, technology is changing and rapidly new devices are coming to the fore. We are a small not-for-profit agency, so we have limitations from funding. So absolutely we will move towards whatever new technology comes. We're going to start testing those to make sure that we're assessing those devices appropriately. And we work with vendors all the time, and we can, I will work with whoever it is to get a device back. Yeah. The second question, sorry, there's a hand raised. Oh. I think technology, please don't take my talk as problems with technology. I just identified a few of them. I think technology is a great enabler, and I think it will play a role in patient safety. We have 300 patients dying every day, and we've become immune to it. We accept it as normal, and we shouldn't. And I definitely think technology will have a role to play, but we need to be smart and careful about it. Thank you for the question. Okay.
Thanks for excellent talks today, Steve Green from Chicago. One quick question about cost and new technologies. we have guidelines through our organizations. Recent guidelines came up, neuromuscular monitoring, yet the devices that are out there are quite expensive, and hospitals don't want to invest in these technologies based on the cost, even though there are guidelines that are available. How can we leverage those guidelines and have more faster uptake of the technologies that have potentially proven to help patients through insurance companies, so on and so forth? Is there incentives already for hospitals to say, yeah, we should invest in these technologies because they're associated with improved quality of care?
Yeah, so that actually comes back to, you know, hospitals are paid very differently than outside of hospitals. And actually, like I said, Steve, companies are doing everything we can to keep patients out of hospitals. But on the same factor, if you can actually show that a patient in the hospital is actually not only in the hospital, but one, they're getting out of the hospital quicker, two, they're getting better care while they're in the hospital, and three, they're having a far better patient experience, then the whole game's over as far as hospital reimbursement. Hospital reimbursement from commercial payers and, you know, from Medicare is a totally different world than what they pay me and you to actually take care of people. The formulas are different, the metrics are different, the requirements are different. But one thing that is the same is anything that actually helps people get out of the hospital. And, you know, one of the things that we all learn is there's a fine line, there's a sweet spot between getting someone out of the hospital, because what you don't want is having them next day back in the hospital. So you got to find that sweet spot. And that's where I think some of the wearables will help. If you can avoid readmissions. Readmissions are like the worst thing, you know, any hospital leader ever wants to hear. And actually, as a payer, you know, we get dinged on our Medicare products. We will get dinged from Medicare if too many of our recipients are readmitted. So actually, we work with the hospitals to do our best to keep patients out. We'll have nurse lines. We'll have wearables. We will have all sorts of, we will pay almost anything for some kind of home care experience to keep patients out of the hospital, and for sure to keep them from being readmitted.
Okay, another question?
Yeah, thanks. A lovely panel segueing from highly technical, high-level aspects to kind of the experience of the end users. I work with a bunch of engineers who talk about cyber physical systems. That's the buzzword, and you used it. And I'm struck that the word social is left out of that. People are so important to the success of these things. And in particular, the people who most need these technologies are those who can least afford, with regard to medical versus consumer grade, nor use complex technology. And I'm wondering if you can comment on the role of social determinants of health and equity in this evolution towards a more technology-oriented care delivery system centered outside the hospital, particularly in the home.
Sure, I guess I'll start us off a little bit. So from the medical IoT perspective, a lot is being done from a human factors or usability point of view to start to integrate with like social media technologies and things like that, right from the data acquisition perspective, IoT edge devices. And so the hope is that as demographics evolve and populations change and so forth, that these become technologies that are more familiar to the primary user group. And so the trend of technology evolution moves in that direction. I would suspect that some of my colleagues here have some additional thoughts as well, both from a cost perspective and human factors perspective.
Yeah, so I just want to touch on the social determinants of health, and we've done some testing on pulse oximeters and skin tone. Medical grade, I'm just using this as an example. Medical grade pulse oxes came out well. We're now testing consumer grade pulse oxes. I think there is definitely health inequities in the context of, I work on GFRs, by the way. The equation of GFR is skewed, and we're working to correct it. The point I want to make is with devices, right in its inception. We have to consider that before we get it to the market. That correction needs to happen. Otherwise, you will have devices at a consumer level very similar to what we have right now, which doesn't take that into account. So I think that piece is important.
And Matt, you brought up a great point, to tell you the truth. And we don't have an answer for that now, but we've got to figure out how to do it, because getting technology in rural America is going to be really different than getting it in urban America, in our poorer communities, in our more wealthier communities, in our more healthcare sophisticated communities. It's going to be a challenge. But the biggest part of challenge is recognizing the challenge. And I think now with all the focus on social determinants of health, we know we've got an issue. I mean, I don't know if any of you know, I've gotten the call. Have any of you ever gotten the call from your parents? Your mother's an AFib. I've gotten that call. And it's like, well, what's her rate? Oh my God, hold on, what's your rate? And her rate's 65. It's like, okay, just chill. Well, hang up the phone, they call the cardiologist, and they actually have this, and the cardiologist told her to throw out the Apple Watch. But these are the kind of things we have to get through, because we have generational differences now too. And and we don't want to cry wolf, but we have to figure out how do we make these devices work so they work for everybody, whether you're 95 or 90 or 22, and whether you're in a very poor community that doesn't have access to great internet, or to the devices, or you're in a very wealthy area that actually has access but doesn't know what to do with it. We've got to figure out how do we get the community, and it's not going to be solved in a year, and it's not going to be solved in 2 years. But the fact that now the issue is out there and we're becoming more cognizant, maybe by the end of my lifetime, we'll have more equitable care, but we're at least on the track to making it better.
So we're going to close with that question. I want to thank our panelists for your presentations and your participation here. Thanks to the audience for your participation. We are going to take a 25-minute break, Dan, approximately. We'll come back at 11:05. Sound okay?
Yeah,
okay,
perfect.
11:05, please. Thank you.
Hello? Hello? Can you hear me? Dean? Come back to your seats. We'll get the program going and have lunch. Just waiting for you to get a little attention. Can I ask everybody to come back? We have a quick public service announcement, and then we're going to introduce our next speaker.
That was very effective, Dr. Cole. Thank you. So just a few seconds of your time. My name is Amy Pearson. I'm a physician anesthesiologist and a pain doctor, and also the director of digital strategy for the APSF. And I would just like to invite all of you guys to join us online and on social media. The hashtag for the conference is APSF 2023, APSF 2023. And our handle on pretty much every social media platform, including TikTok, is APSF.org, as in apsf.org. The video, some of you were wondering who are following along on the YouTube live stream, the video will be published to our website probably within like a week or two. Yeah, Mike? Yep. We just need to do some like post-production editing on that. And I would also like to say that the conference registration today, including all of the delicious food and snacks, is free, thanks in large part to people like you and individual donors. And if you, yes, thank you. If anyone is interested in donating, it's very easy. You just find Stacy back there with the dip jar. Dip your card in, whatever denomination you like, or you can donate online. So thank you all very much. It's wonderful to see you here.
Thanks very much, Amy. So I'm really pleased to introduce Dr. Krisda Chaiyachati to you. Dr. Chaiyachati is a practicing internal medicine physician with degrees in public health and public policy. His current role includes physician lead for value-based care and innovation, as well as medical director for Onduo, a technology-enabled whole-person care program that offers personalized precision care. He's published extensively and is a national thought leader on how to design, implement, and evaluate strategies that improve equity, efficiency, and access to care through transformative digital health initiatives. Can't think of a better person to help us connect the impact of digital technology on patient access to care. Please join me in welcoming Dr. Chaiyachati.
Well, I'm very excited to be here. And I think most of all, you let a general internist into the room. So I think that's actually the most appreciative statement. The other part is I've been really humbled by the interdisciplinary nature of the attendees here and the topics that we've covered. I think you'll see a couple of arcs of stories that'll play out here as we really talk about health equity. And I think one of them you'll probably also notice also is that I've worn a couple of different hats over my time, both in the academic sphere and now in the private sector, and really thinking about how can we carry health equity as both a desire and a goal for what systems we're designing across both of those sectors, and how they can actually interconnect to really start to go on this journey of actually producing more equitable outcomes. So hopefully you hear that narrative. I hope to actually end with some time to really invigorate a conversation around health equity, or certainly around the private sector's role in thinking about it. But most of all, just really invite a conversation. So a number of different disclosures over time, again, just kind of highlighting the journey that I've had in my own personal life over the last number of years. So I started with this image whenever I talk about health equity, because I think this is the image that I think about when I think about healthcare. And oftentimes we're on the other side of things, which is the door feels incredibly wide open. We've got a revolving door into our hallways. We say the phone lines are open, but truly the patient experience is one of running against walls. And if you've ever had a healthcare experience, which I imagine many of us have, we feel that pain when we turn into patients, or we turn into the son of a mother trying to seek care for AFib. And so that is actually this dichotomy that I think we live with when we are in the healthcare profession, is being on both sides of the aisle. And yet at the same time, we struggle to remove these brick walls. And health equity in principle is that underlying story of how do we remove walls and barriers for particular groups of people. I have long anchored on the CDC definition, and I've espoused it in my day-to-day work at Wearable, which is health equity is the state in which everyone has a fair and just opportunity to attain their highest level of health. Again, everyone has a fair and just opportunity to attain that highest level of health. And it's really important to also think about this in the imagery. We can easily design a health system that thinks about equality. And the story of equality is, it doesn't matter who it is, we just give them a bike. And we expect everybody, whether they're wheelchair bound or 7'2", or a woman or a child, that that bike will serve their purpose. Equity takes on a very different approach, which is how do we get to a state in which we help everyone get to the end of the road, giving them the bike or the vehicle that allows them to get to that end journey and end destination. And I will say that's easier said than done in being able to execute on that promise in a very complex healthcare ecosystem. The other aspects to it is that it's very multi-layered. Oftentimes in the public policy conversations or debate, we've talked about insurance. And totally a critical upstream need there, but then there's access. But just because you have that access doesn't mean there's equal utilization. Just because you have equal utilization doesn't mean everyone gets access to equal quality. And ultimately, those factors upstream relate to health care equity and also health equity. I've long been in the field of access, if there was a field here, really thinking about dimensions here. And this is a framework from the 1980s by Penchansky and Thomas, really talking about affordability, availability, accessibility, accommodation, and acceptability. And if you take it back to that bicycle image that I gave you, each of those 5 factors plays an important role in giving that person that you see in your exam room or on the surgical table the right types of ingredients that led to that moment in which they were able to access the care that they received. And we've looked at this in many different ways. I'm going to give you a number of Philadelphia examples, which is where I spent many of my years prior to transitioning over to Wearable. But we looked at this at the very micro level effects, which is even in poor, as the ACA was about to roll out, Medicaid expansion was going to happen in Pennsylvania, we evaluated where PCP access would happen. And lo and behold, where there were poor neighborhoods, they had very limited PCP access. And then after Medicaid expansion, we still found that those individuals that lived in poor neighborhoods still didn't have access to PCP. So we did a notable thing to reducing the uninsured rate. We did a notable thing to expand Medicaid, but we still had a significant access challenge for those individuals. And much of the last 12 hours or 24 hours that we've been here, and for the rest of the conference, we're really talking about digital health and all the myriads of ways in which we could be leveraging those tools or those technologies in order to provide for access. And it makes it even more complicated because digital health is not monolithic. And in fact, it's actually quite complex, and they actually interact and engage with each other. As somebody who works for a technology company, you've heard stories about like, well, is the speed fast enough? Is the data server fast enough? Is it usable? Each of those things and provide a different layer to ultimately produce the outcome that we all ultimately want. Better safety outcomes, better health outcomes. In each of those things of where the state of the technology is can have significant downstream effects on whether that technology results in better access and results in better outcomes. Now, we've already reviewed this hype cycle, and so I won't belabor it, but I do believe we're somewhere in this like, kind of peak of inflated expectations, and we might start to hit this real trough of disillusionment. I think we've gone through phases with this with different technologies. We've gone through that phase with EHR. We've gone through that phase of thinking about wearables. We're going to go through that phase when we think about large language models and generative AI. And to be honest, we can't turn our attention away from them because they will have such significant implications for how we function and how we work, and our patients will use them, whether we want them to use it or not. And so we have to actually take it by the bullhorns and really think about how do we walk our patients, how do we walk our academic medical centers, how do we walk our industries through the slope of the enlightenment to a direction that actually we use technology for better and for good. So I made the story more complicated, but I'm also going to make it simpler, which is ultimately who gets care and who gets access to care is really the conversation we're having here. And we're oftentimes kind of almost doing it, we talked about earlier, like retrospectively. We're just seeing the downstream effects of it. And I think what I challenge us to think about is how do we go upstream, prospective, to think about interventions or systems or processes that we can build in place to actually improve access to care for many different people. And that doesn't necessarily have to be across dimensions of race and ethnicity. It can be across age, it can be across language, it can be across any dimension that you want to think about. And it will vary based on where you live, where you work, and the therapeutic area or clinical condition which you are a part of. And to tell this story, I think we really lived this out to get so many different use cases during COVID. And so, not to bring too many of us PTSD, but I will tell a bit of a COVID story here, because it really highlights how quickly inequities can play itself out. And so, Memphis area residents without internet must wait days for vaccination appointments while others go to the front of the line. And so this tells the story of who has access to internet and who could actually access the vaccines the quickest. I actually thought this article took it even further. Even in poorer neighborhoods, the wealthy are lining up for vaccines. Suddenly, our clinic was full of white people, said Mr. George Jones, the head of Bread for the City, which provides services to the poor. We never had that before. We serve people who are disproportionately African American. So this is a story of a vaccine clinic that was placed specifically in a poor neighborhood. The entire line outside the door was all non-Black or non-Hispanic individuals. And that has to do with the story of who has access to technology, is able to access care first, and are often first in line. And actually, if you read the story in depth, they actually took a very simple fix, which is they just geo-fenced who could actually schedule into that clinic, and they geo-fenced it around the neighborhoods in which they were actually trying to meet or to serve. And then quickly, just within one design change, within 48 hours, they said the entire racial makeup of the line to that vaccine clinic flipped basically with a flip of a button, literally. And in my own background, we've looked at this question, particularly for telemedicine. And so prior to the pandemic, the only place you could actually think about telemedicine was in the Medicare population. So back in my day, only Medicare was the place that actually could actually reimburse for telemedicine. And was particularly for Medicare in rural areas here. A number of colleagues and I did this deep analysis here to really look at, okay, fine, if that's the case there, would rural areas even have access? And the answer fundamentally was no. And what it showed here was actually rural areas didn't have sufficient enough broadband to even meet the minimum standard to actually have a telemedicine visit. And this was pre-pandemic and thinking about that. So areas, again, in which the policy was designed to allow for better access for telemedicine, where they didn't have access providers, didn't have the infrastructure necessary to actually provide the thing there. So layers upon layers. I'll give a Penn Medicine example here. Many are well aware one of the complicated things here can be that actually we saw disproportionate uptake of telemedicine. And I actually will say it's actually it's much more complicated story than one would think. And so at base value, I'm gonna put up this slide here, just really probably hits everyone's assumptions here, which is video visit use at Penn Medicine was lower amongst underserved populations during the heart of the pandemic. And this is fundamentally what it shows here. Everything to the left of the line, less likely to use. You can see kind of classic demographic factors that you would have imagined had lower uptake of telemedicine. But when we actually looked at completed telemedicine appointments at Penn Medicine, actually was a kind of a mixed picture. We actually started seeing something a little bit more of something split along the line, where actually it was actually potentially producing better access for individuals who are female, Black, Latinx, Medicare, sicker individuals. And stories here started coming in, and it kind of mattered how you deliver that care. So this is a study by Laura Usher-Pines here, who looked at disparities, or excuse me, looked at, uptake of audio versus video in FQHCs. And you can basically, if you follow this kind of left side of the graph here, you can see here that in-person appointments started coming back up, but actually audio visits held pretty steadily for FQHCs, really providing an access point as we kind of lived our pandemic experience. And it was really notable for behavioral health here, that if you actually looked at that graph, you could see here that audio only appointments, really improved access for behavioral health services. And if you follow the blue line for all visits, the volume of behavioral health appointments actually started jumping up significantly, meaning there was a little bit more access. Now, this isn't a slide of the story I'm about to tell, but it's actually a slide to remind us of how much things dropped off in the beginning of the pandemic, which is the national output of outpatient visit volumes plummeted in those first couple of months of the pandemic here. So remember that graph as you then look at this one, which is we looked at this all data in outpatient settings at Penn Medicine over the course of 2 years here. And amongst non-Black patients, actually the dip looks about the same. So if you look at the top graph, looks exactly to mirror the national image here. But we also did was we separated out phone visits and video visits from office visits here. And you can almost see this valley was being filled in by video visits and phone visits during that time to fill up for that. Interestingly, when you looked at Black patients, there was actually no dip whatsoever in visit volume during that time. Completely filled up by phone visits, completely filled up by video visits to make up for that. So you have this really complex story of lower uptake by different groups, yet at the same time, amongst those that did use it, it actually was a lifeline for many different individuals, and particularly Black patients in Philadelphia, which many know if they know the Penn Medicine region is filled by West Philadelphia patients. So I'll take you back to an even further story in a program that I was deeply involved with here. And so I want you to almost bring out that PTSD to March 9th, 2020. And so if you recall, there are lots of stories from Northern Italy that were starting to scare us. Probably remembered the cruise ships that got locked in the harbor here and weren't allowed to dock for days. ICUs, and some of you probably worked in those ICUs. In Seattle and New York, just felt like they were filling at the brim. And down the street in Philadelphia, not much was happening, but we were bracing for a storm. And we had a lot of patients that were starting to really jam up our phone lines and our emergency departments, really scared about the impending situation that was about to come about. And like many in this room, most people were focused on the ICU. Yet what we learned from even the early days here was that for every one patient with COVID in our ICUs, there probably were 50, if not more, individuals infected at home in the community here. Most would get better on their own, but some would actually get very sick. And as a primary care doc and a general internist, I was focused mostly on this home environment. What was going to happen to those individuals? How were they going to react? What was the support that they could use in order to feel safe to be at home? And so much of the world was really designed and really aiming at to tell you whether you were infected or not. We were really focused on answering a very different question, or a slightly different question, which is whether you needed to go to the hospital or not. Because what we wanted to do here, and we do this every day in primary care even to this day, is we wanted to get patients to the ED when they needed it, and we wanted to keep them home and make them feel confident that they could be at home when they didn't. COVID, all these symptoms, but what really mattered to us also was that people would die from respiratory failure. And so we were designing a program of how we can monitor individuals in the home, make them feel safe, and really try to prevent this really crucial event of death by respiratory failure. What we created was a program called COVID Watch. And it was one of my earliest experiences really thinking about designing a remote patient monitoring program. It's actually really given me a lot of lessons since. And so the program here was designed for patients who were presumed for COVID-19 who are self-isolating at home. And what we did is we administered twice daily automated SMS check-ins that asked patients how they were doing symptomatically. And we backed this with a 24/7 dedicated telemedicine response team to patients who were replied worsening respiratory symptoms. Now I'm going to quickly say, like, how did we come up with this design idea? It was a lot of iterative testing where we actually did a lot of beta testing. We did a lot of user design. We did a lot of phone calls to patients. We tested out different mechanisms of twice daily versus trice daily versus 4 times a day. And why could we do a 24/7 service? Because we actually already had 24/7 telemedicine programs already in existence. And what we did is we piggybacked on those programs to allow them to have multiple different uses. And so I think one thing that to highlight a theme here is to also think about the existing infrastructure that you have, and can we use them for many different purposes other than the singular purposes that they're designed to allow us to expand our services or to grow our services. I put up this slide because we ended up publishing on this a number of different times and largely supported by a PCORI grant here. And actually put up, it wasn't our planning here, but in the New England Journal of Medicine Catalyst, we actually had back-to-back articles with our colleagues at Northwestern in Chicago. And this slide here is not to say pick on anybody or do anything. It was everyone was kind of designing programs urgently and emergently at that same time. But it gave us an opportunity to almost do a side-by-side comparison to really tell a story about remote patient monitoring, about potential opportunities to think about automation and efficiency here. And so at Chicago and in Philadelphia, we're able to manage about 1,000 patients per day. Whereas in Chicago, they were a 12-hour service from 8A to 8P. We were able to be 24/7. Their man-woman power was 500 daily staffing hours to get there. Whereas because of the automation, we were able to use 64. They were sending in 9 individuals per day to the emergency department. We were sending about 6 individuals per day. And overall, when you do a back of the envelope calculation, thinking about the man-woman hours it was per those days, it was saving our health system on average about $2.3 million per every 100-person days. And when we've evaluated this study published in the Annals of Internal Medicine, incredible high patient satisfaction and a mortality reduction that was shown through this automated program. And the graphs also tell the story too, which is it allowed us to manage things efficiently. So over time, 30,000 individuals were able to be managed. That graph to the right here, the green is basically all automation of just patients responding to it. And then you can't even barely see it, but there's like a little pink line in there for active escalations. That's how many escalations that we were kind of managing per day, but we could do whole populations at the same time. To tie back to the health equity story, and if you walk yourself from left to right here, we were looking at all steps along the way to see differences between Black and white populations. And so here you can see there are substantial differences in Black populations who were testing positive, substantially significant Black populations who were enrolled in the programs, but acceptance was equal on par. And if you go through engagement and escalation of outcomes and referrals to the ED, equal on par as we looked across it. So we were able to over-enroll, if one could tell the story, amongst Black populations, and yet provide the same quality of care on the back end, primarily through algorithmic automation. And I will say we monitor this here, but there's probably even better ways in which we can purposefully design for the system to actually have given these outcomes there. And that's a foreshadowing to later. We also spend time interviewing people to tell stories that it's also not quite black and white. So many patients found it comforting. I was grateful that at least they would text me because my daughter was in the hospital. My grandkid had to go to school and my granddaughter had to work. Sometimes I needed to know if I could ask for help or something. I mean, my desperation was based on not having help if needed it. But not all found it. So these are quite funny quotes. I thought it was in between helpful and annoying. I just think a phone call could have been better because they also would hear how you sounded as well. Because sometimes people can really, they hear how they sound, and I think that helps. They should call because sometimes you speak Spanish, even more if you don't know how to use the telephone. I don't text, I don't chat with anyone because I didn't know anything about it. So you can think about here, if you really are expanding here to be equitable, to really hit all the populations, you actually have to start to design a program that actually can meet people where they're at, either language preferences or communication preferences. You start to add on layers of complexity to really enhance a population health management type program like this. And so the story I carry here is that the lessons that I learned in an academic medical center actually carry forward here to also thinking about how we should be designing these programs on the industry side and how we should think about the structures that we create here. So I'm going to tell a story here about Verily, but also tell a story here thinking about one example and one place's attempt here to embed health equity principles into the work that's done. So a little bit of Verily, because I think it's helpful context here. And I was told not to do any commercial talks. So this is not it. This is really just to give you context. So our motto and our mission is to bring the promise of precision health to everyone every day. And you might hear it because it actually sounds very familiar to the conversation that we've been having for the last 20 or so minutes. It's one of my motivations that I switched over very early was because I was really intrigued or interested in here thinking about this kind of precision health effort here. We oftentimes had the conversation here thinking about precision medicine, pharmacogenomics, individualized care. I've also thought about it here on the level of like the care that we can provide that actually gives people the right type of vehicle or the right type of bicycle to help them get to their ultimate destination. And that's been my underlying motivation. And I also take a step back and think about the patient stories here. And obviously there's the story of being a physician, seeing patients every Friday morning and being able to be a part of people's lives. It's also a story about we're also all patients. And I look at this picture because it really hits home to me. I have 3 young kids at home. And I think about their lives and the arc of their journey. I think about their mom. And I think about all the ways in which we are also taking care of others. I also think about this woman here, who's a woman of color here, and how she may view the world differently. She may have different perspectives on what she has fears for her child, or she has hopes for her child. And so how can we as a health system, a health ecosystem, really provide that care for all the individuals that are there and help them along in their journey? And I think we're just scratching the surface, but and certainly I think I've dedicated my life to thinking about that ultimate question there. And it's not rosy also in our current state. So on the research side of the world, we know hands down that US clinical trial data does not reflect America's diversity. In fact, it's like terrible. There's another image here that I usually present. It's actually gotten worse in the last 10 years. That we've actually had more and more underrepresentation throughout all US clinical trials amongst Black and brown individuals. And so it really impedes on our, not just Verily's ability to meet this precision health promise, but I think it's meeting our lack of a scientific standard and an ability to really think about populations that are going to use a device or use a drug or use a medication here. And the cost is astronomical. This is a Deloitte study. There was a joke about actuaries. This was done by actuaries who looked at actually what are the cost implications if the US healthcare doesn't start to do something about health inequities. And it'll cost the US health system, not the people, not the patients, but the US health system, an estimated $1 trillion in excess spending because of the implications of disparities, social determinants of health on outcomes for patients. And so how do we, as a system, try to do that? So Verily plays one role in the larger ecosystem. And the way in which we're doing it is really thinking about the data that we need to really reflect the diverse populations that we have. And it's not just from whom, but what types of data. And then even further, and really critical, is high quality data. And so we really are obsessed about the breadth of data in which we are trying to collect from individuals, the length of time, really developing longitudinal relationships with participants and patients, and also the depth of that data. And it's part of our goal here of really bridging this divide between research and care. We know all these facts and statistics, that 80% of trials fail to meet their research timelines, 83% of participants are white or Caucasian, it takes 10 to 17 years for a new drug to make it to market, costs $2 billion per drug discovery, the total cost of care, $8.3 trillion, and yet we have half the population in with chronic disease. And one of the underlying challenges, we all know this, but it's almost like too big for us to kind of wrap our heads around sometimes, is that the data are in little pockets and silos. Patients got it on their watch. Patients got it on their phone. The unit is the health system's EHR, not the patient as the central element of data which they traverse. Data elements are over in a separate radiology file or PACS system. We have new data coming up with genomic data sitting over here. It doesn't talk to each other here. And Lee brought this up earlier, which is to think about fire really as an opportunity. And we've totally drunk that Kool-Aid early. But I will say we're a long road ahead of us before we actually recode every single thing into fire and actually come up with an agreement that those data should actually talk to each other. I actually think, though, actually, I will say fire recoding is an enormous task. I'm just going to put it out there. The agreement for the data to talk to each other and to be interconnected to each other is actually the elephant in the room that we still haven't quite overcome and start to think about. And so the place we're starting here is thinking about the patient or the participant here. And we're, again, obsessed with thinking about their individual journeys here. And what we've done is created a couple of capabilities to really enhance this ecosystem. And so it's not only the app platform that we have, but in the devices that we have from a study watch. We have a retinal camera service to digital pathology and lots of other companies that we work with to think about the data that they're collecting and how do we actually make them sing and talk to each other. We also have an incredible platform backbone that really allows us to facilitate and accelerate the research endeavor here. Digital recruitment, digital administration of PROs, enabling video visits, both for care and also for research possibilities. How do we think about the role of remote patient monitoring? How are we processing that data? And then finally, how are we running the analytics on that with our data science and artificial intelligence teams? We think that these capabilities will allow us to accelerate. So the platform that we have, the data that we have, and also really being really forthright about facilitating novel study designs. And so I just have two more slides, and then I think we'll have plenty of time for questions here, which is one thing I usually mention, but I realize I did, which is many of us know us by our parent company, which is Alphabet. And I'll say Alphabet's biggest company there is Google. One of the Google culture parts that we have brought over to Verily, though we're separate from them, is thinking about the participant experience. It's actually one of the joys that I get to work with here, is working with state-of-the-art social scientists, user experience, user design individuals who are thinking about all the human factors engineering, all the kind of ways in which a device is touched, all the ways in which a screen is displayed, and running an enormous amount of studies in order to help us think about how do we create something that's frictionless, how do we create something that actually the user or the participant thinks is valuable, and how do we empower that individual to be a part of their care journey here. And so it's all of these kind of multidisciplinary team members, like the room that we have right here, that I think is really going to facilitate and enable us to go faster and to really create something that is of value for the ecosystem. And then finally, I do want to say this is the journey towards health equity here is also not, is actually just quite fraught with challenges. You can have a place that's full of 20 and 30-year-olds who are well-intentioned and well-to-do, but it's not their reflective muscle to think about health equity. Because when it comes down to it, there's processes and demands on their time to move at hyperspeed, to break and to recreate and to discover, to sit also and adhere to strong engineering principles, and to really start to embed health equity into the company here. It takes a very concerted and what we say cross-functional effort here. And I'm lucky to work here. I don't think your pointer here works quite strongly here, but Vendel Washington's up at the top there, and he's our co-lead here for the Center of Excellence at Health Equity. Used to be the Office of the National Coordinator as the director, has really been spearheading thinking about how we think about equity here. And the way we are going to execute on this is really to think about all along the process here of product development, of research here, of how we're engaging with partners in marginalized communities, how we're educating and enabling, we call them VEEPs, our company, how do we drive with that data so we're always having line of sight to how we're doing across different socio-demographic breakdowns. How do we build and automate so that we're actually building programs or products that actually create more equitable outcomes? And then actually, how do we be a part of the larger community here and how we lead and advocate for health equity? So I think this is my last slide, but I think it's really just a moment of reflection that I wanted to provide. we are at an early inflection point. And I think we've only scratched the surface here, but there's a lot of hard work to be done ahead of us. And I think it actually will require the entire community here. And I think generating evidence of what works, doesn't work for whom is more important than ever. So I'll pause here. Oh, great. Oh, perfect.
So we have some time for questions. We're going to take a little bit of time from lunch, and I think we'll still have time to enjoy a break. But I want to take advantage of having Dr. Chaiyachati with us. So please, questions from the audience. Julian.
Thank you. That was a fantastic presentation. Something that you said suggested that maybe it would be worth discussing a fine point that's causing a lot of challenge. You mentioned the challenge that fire sounds good, right? And it's central to a lot of the work that's being done. And we heard Lee talk about that and its importance. But it, similar to HL7 probably, is an example of a standard that's a published standard, but making it work for you to transfer the data that you need still takes a lot of heavy lifting. And I think it's helpful when characterizing this issue is to look at other standards that make it that are easy to implement, usually by industry. And the way that typically works is that there's a consortium of some kind. So there's the Bluetooth communication standard that we all know and usually love. But there's the Bluetooth consortium that makes sure the standard works, and all the different manufacturers work in that consortium in their test labs to make sure they're interoperable. That's also true with Wi-Fi, and that was true with the Continua Health Alliance to a large part. But there are other things, other standards that are designed for communication of health data that don't have an alliance and don't have anything that really ensures interoperability. And so when we try to use it for projects, new products and research, we're kind of stuck trying to make something that's supposedly a standard, pardon me, but isn't necessarily implemented in a plug-and-play fashion. So your example of the pain and suffering reminded me that maybe it's worth calling that out and seeing if you have some thoughts about how that could be addressed, given how important this need is in the community.
Yeah, I can actually give an answer from two perspectives. One is having worked on the operations side, on the health system side, and then also I'll give the my answer is probably an amalgamation of both here, which is we haven't quite hit the threshold here where everybody starts to convert in mass over. We've got a couple of unique actors starting to convert over to Fire, but what's the point of Fire? Is so that the data can actually interoperate, not just within system, but across systems or with different new data sources. And so until we reach actually a critical community threshold, that peer pressure isn't there. I firmly believe that this is actually a role probably of two kind of different actors to really continue to push hard on. One is certainly on the regulatory side to continue to incentivize that. I imagine here a health system response here is that it requires an intense amount of resources here in order to execute it. That includes personnel, and then also financial resources to do it. And who's going to put up those funds and money to do it? I also know of different companies that are trying to help accelerate that process as a kind of a for-profit vendor company. That's not us, in all clarity here.
And your points about having adequate drivers for it are critical. In those other industries, typically the industries have come together, and you can define industry however you want, including 100 hospitals, have come together and they said, we're going to work together to ensure there's a pathway that will work. And basically they seed the market when there's a greenfield initially. But when in these other areas where people just developed a standard hoping that it'll be implemented interoperably, these flounder for years. And that's been happening in, for example, some of the IEEE 1173 communication standards. Excellent work. But again, it's kind of each implementation is an implementation. And it's very difficult without these, we'll call them consortia because they're usually nonprofit consortia. It sounds like maybe we're getting closer to that based on what you said. Yeah, thank you.
Great. Other comments, questions from the audience? I do have a question about the hype and the performance curve. So, if we are on this peak of this hype curve and, if we're destined to follow it, we're going to fall into this trough. But do you see some key things that might leapfrog into the performance and avoid the trough that you think are reasonable? What would be, if you were going to come up with a strategy to say, hey, let's just get right into doing some things well, what might be the key things that you would try to do? Any thoughts on that?
Yeah, I'm gonna quote somebody at a different company real quick. So the New England Journal of Catalyst actually runs a podcast series on AI in medicine. If you ever want something fun to listen to, at least for my own sake, it's quite enlightening. Peter Lee over at Microsoft actually was one of the early individuals, and he's led a lot of generative AI and the chat GPT elements here. And he actually tells a story, which I 100% agree with, is that there's like this unbridled optimism here. And it's actually on both sides. So on one side here is consumers or health systems believe that there's some magic that Microsoft or Google has to automatically fix things, and that we can do things in like a week or two. And I will say we can move very fast, but this is a lot of foundational work in order to help support us in being able to move forward here. The other side to that also is that there's unbridled optimism of people who work for health tech companies. And it's everything you imagine, 20 and 30-year-olds who are just like lots of solutions and lots of ideas and lots of like energy here to really try to create things. And I think we have to bridge that to kind of meet some reality. I call that softening the landing from this like peak of optimism here. The other part to it too is actually helping each other solve for real problems that matter today. And I think there is something about solving for patient needs and also provider needs. So as a provider, speaking from my personal stance, like the inefficiencies of which I go through my day-to-day of providing clinical care just feels like it should be solved at some point. And it does require dedicated technical expertise and dedicated experimentation to help us get along the way. And that needs to happen. On the patient end, they also still need to feel like they have access and feel like they're engaged with their healthcare providers. How do you create both those solutions at the same time, where one isn't kind of conflicting with the other? I think it is possible here, but solving for actually getting some wins here, I think will take us a long way from hitting that trough of disillusionment and kind of, I don't know, soften the landing so that we actually kind of buckle up together and lock arms moving forward.
I have a question in the back. Yep, Megan.
Krisda, thank you so much for visiting us and thanks for your comments. I want to latch on to your comments about health equity. And the last few years have seen this groundswell of efforts in health equity from health systems to companies to what have you. We're starting to see that moderate and in some cases reverse. So I'm curious from your perspective, what are you needing to think through to keep the momentum for health equity moving forward as there starts to be some backlash and some concerns about the viability of health equity efforts?
Yeah. I'll make two comments. And Megan, I don't know if you were saying this in one of your comments. So it's not a political comment, but there's been a lot of kind of commentary about the words that we use, equity, equality, diversity. And there's been a lot of nomenclature debate over the last 6 to 12 months. And I've seen it play itself out on the public side. Interestingly enough, the private sector can kind of hold tight to what it wants to do. And it has more to do, at least from my experience, and of one person and of one company, more so to do with the leadership that's there and embracing that and being able to just lean into it. In some ways, I actually have found myself surprised that I've been somewhat insulated from the kind of nomenclature debates that exist out in AMCs or in the public sector side here. So that's just a commentary and observation that I have. The second part is what are the structures and processes we need in play here that don't make it an appendage to what we do, some sidebar thing, but actually it's just an innate part of what we do. And really, it's somewhat easier in the sense that we really live by that motto of precision health for everyone every day. And using that as an anchor just really says like, it's kind of a no-brainer that we actually have to excel I think about diverse recruitment into our products and diverse longitudinal engagement to kind of maintain those attachment points over long term. But there's a lot of steps that have to happen there about the workforce recruitment, the types of experiences that people have, not just in their own life, but also in the ways in which they worked before, but then also just through the mechanisms and the checklist, actually, that engineers and product managers go through. Sorry, I thought about checklists as I looked over at Meghan. I think that I would probably look at many of you in this room and help me think about that too. But you would be amazed that engineers and product managers love checklists. And so the goal is to get on a product manager or engineer's checklist so that it is something that they're done. And that's actually how they're paid. Just to provide some insight there, is an ability to execute on their checklist and how much of their checklist they execute on. So we've been working pretty hard at actually trying to create health equity, like I call it muscle memory within the company, to where it's just simply embedded into what they do. Now, there are implementation challenges here. Does it generate more work? Is it more work that's actually the right type of work to generate? And we talk to them all the time. You know what they really hate? Hate the app going too slow. They hate widgets breaking. And I just say, well, let's just not have a patient break from this or patient get harmed by this. And this is an easy kind of sell for you. But that actually is something that we should uphold ultimately.
Other questions or comments? Okay, well, thank you so much for your talk and for joining us. And we will break for lunch, and let's convene back here at 12:45 for the next panel. Look forward to seeing you there. Enjoy the break.
Okay. Hi, everyone. So my name is Maxime Cannesson. I'm from UCLA. First, I want to thank Jeff and the rest of the team for having me part of the program. Thank you very much. It's been a great experience. It's great to see a lot of familiar faces in the audience. The session now is going to be about healthcare and big data. We are having 3 speakers, and then we'll take the questions at the end of the third talk. I'm going to, if you can display my slide, I just have 2 slides. And the reason I would like to show some slides is because I came to the US actually about 15 years ago, and when I came, a lot of connection with the Society for Technology in Anesthesia. That's how I got to meet the American academic community in anesthesiology with Dr. Feldman, Dr. Barker, Dr. Goldman, many others. And there is a slide I'd like to show you. It's because in 2004, the Society for Technology in Anesthesia had their annual meeting. And Dr. Julian Goldman was the chair of the meeting. And they had a workshop where they discussed the future of perioperative technologies. So it was 20 years ago. Do you have the slide for me, if you don't mind putting the slide up? Mm-hmm. Oh, you're working on it, okay. So just a few. So the Society for Technology in Anesthesia, if you don't know it, it's a society that's been created. One of the founders of the society, his name was Ty Smith, and also a lot of academic anesthesiologists in the US, very focused on technology, were part of the development of the society. It's a society which I see as a society that brings innovation and technology to anesthesiology. And then what I've noticed then in my career as an academic anesthesiologist is that actually these innovations are escalated through the APSF, and there is a committee on technologies, and some of them are escalated with the ASF. That's what I understood later on in my career. But you have the mission statement from the Society for Technology in Anesthesia that actually aligns a lot with the goal of the meeting that we are having today. And this is what came out of this workshop in 2004, where the goal of the workshop was to discuss the future of perioperative technologies. And Julian, who is here today, was the chair of the meeting. First, I'm very impressed that in a workshop, you can put together like a poster like this with no scratch it's very well put together. I mean, that would take me probably 2 weeks to put something like this together by myself. But if you look at what they come up with, you can see there is already a lot of what you are discussing today, right? We are talking about the electronic medical record. We are talking about wearable technologies. We are talking about alert system and clinical decision support system. And we are putting all of these technologies within the process of care. And that's something I realized today, that no technologies by itself is going to improve any patient outcome, because the technology itself cannot be implemented. To implement the technology, you have to redesign the process of care. And so it's very impressive to me when I see 20 years ago already, all the people from the STA came up with this idea. So now the session, the first speaker is Dr. Michael Mathis. Dr. Mathis is actually an associate professor. You told me, Michael, you became an associate professor 5 days ago, so congratulations. Dr. Mathis is a cardiac anesthesiologist at University of Michigan. He's NIH funded. He was on the K Award, and your co-PI on the R01 has made tremendous work on perioperative technology, the use of health data. He's the director for research for MPOG, benefited from great mentoring with Dr. Tremper, Dr. Ketherpal, and Dr. Mathis is going to discuss machine learning, deep learning, and data analytics in the perioperative setting.
Thank you. Thanks for that intro, Maxime. Very nice. I need to get a recording of that. I think if I were to tell my family or my kids that, they seem to be not that interested. So I'm just going to have to play that back to me and myself sometime. But yeah, thanks for having me here today. A lot of really inspiring talks thus far, and it's just a phenomenal opportunity. Just to go through a couple of disclosures, I don't have any personal financial relationships with any vendor, but my work, as Maxime alluded to, is supported through the NIH as well as the Department of Defense, paid to the University of Michigan. And so what I wanted to do today, and I'll probably jump through some of this early content pretty quickly because it's probably the most advanced audience I've given this talk to. Some of you guys are probably further along than me on some of these topics, but just want to provide some background and context to where we are today, like what got us here, and some of the terminology around machine learning and AI that gets maybe thrown around a little bit haphazardly. So I just want to set the stage for just kind of a baseline about what we'll be talking about today. And then after this, I want to quickly transition to more interesting things that I think are best illustrated through going through examples of either current or near future examples of machine learning and AI that anesthesiologists might conceivably use. And for each example, I'm not going to go into the full details of each of these studies, but I suggest for those that are interested going into those details, they can just read about these studies. But instead, I want to use the 2 examples that I have the time to discuss today as a way to illustrate a few critically important dilemmas in machine learning applied to healthcare that we've already heard a lot about today, and that all clinicians should become acquainted with. And so by the end of this talk, I hope that I've brought to the forefront some of the ways that we can apply machine learning derived inferences appropriately and mitigate against some of the logistical, social, and ethical dilemmas that they will bring in, which we'll also cover in other parts of this panel. So just really quick, some background and context. It's helpful to kind of talk through the different types of AI, just so we're all on the same page. It can be illustrated in 4 different levels. There's type 1, the first type of AI is called reactive AI. This has been around for a long time. These are AI systems that have no memory. They're task specific. An example of this is Deep Blue, the IBM chess program that was able to beat Garry Kasparov in the 1990s. We're long since past this type. Type 2 is limited memory, and these are AI systems that have memory, so they can be used, they can build upon past experiences to inform future decisions. Some of the decision making in Google self-driving cars are designed in this way, and there's several really important weaknesses and vulnerabilities here, which we will highlight in this talk. The third type is theory of mind. It's a psychology term. And when applied to AI, it means that a system would have the social intelligence to understand emotions. So we heard in Lee Fleisher's talk that quote about how humans have godlike technology, but medieval emotions or primordial emotions. I think it does ring true, and it's a challenge that we have with human factors engineering and kind of the human-machine interfaces. And then lastly, there's this level called self-awareness, where AI systems actually have a sense of self, which gives them consciousness, and machine, with self-awareness can understand their own current state. They have, the ability to bypass our own intelligence. And so to be clear, where we're at today is this second stage. The other stages are still, far off in the future, but I'd like to just talk about the limited memory stage, which is really just kind of at the tip of the iceberg when we're applying it to healthcare. That's what we're going to be talking about today. What's the goal? You guys have seen this type of slide before, I'm sure, but it's helpful to reiterate that physicians will always have a place in medicine. Machine learning algorithms are great tools, but no substitute for the judgment, intuition, and care of a thoughtful clinician who understands the full impact of our clinical decision makings through experiences taking care of tens of thousands of patients in their lifetime. There's strengths and weaknesses to both humans and machine learners. Again, I'm preaching to the choir a little bit with this audience, but with machine learning, the advantages are that you can make rapid and accurate and quote unquote unbiased decisions, but I put that in quotes because if algorithms are trained on clinical decisions made by humans who have biases, it will learn those biases and reflect those back at us. So we have to be aware of that. The downside is that there's often a lack of transparency or understanding exactly how the algorithm arrived at either a treatment recommendation or a diagnosis or whatever it's being used for in the healthcare setting. There's also this lack of understanding of the downstream consequences of the decision. And so that's where humans are very important. We understand the implications of our clinical decision-making through experiences taking care of, again, tens of thousands of patients in our lifetime. but we are very expensive, and we are slow to process information on the scale when compared to machine learning algorithms. Why do we care? Again, I'm preaching to the choir, but changes induced by machine learning and AI, they're disrupting every industry, and healthcare is certainly no different. And we all know that these changes are coming, and some of them are already here. The best thing we can do is prepare for them. And just like interpreting or trusting or applying studies in anesthesiology or any other published clinical journal, it demands the reader to have a basic literacy in statistics and study design, interpreting, trusting, and applying technologies using AI and machine learning derived inferences. They demand a literacy in machine learning methods. So that's kind of my motivation to a clinical audience for why we should care. Finally, why is it so hard in healthcare? These are just reasons that I'm sure we've heard before, but one of the most important is that mistakes really matter. So if Facebook were to misclassify your face as your twin brothers, that's annoying, but it's not really dangerous. Contrast that to a prediction about the diagnosis of sepsis or a patient deteriorating. That can be much more catastrophic if the wrong inference is made. Also, our culture is just less tolerant of errors made by computers. So a self-driving car wouldn't just have to be better than a person to be accepted. It would have to be nearly perfect. Another issue is that being right isn't enough in healthcare. It's not just about getting to the right answer. We need to actually understand the mechanisms of our answer and be justified in our clinical decision making so that we can mitigate and anticipate and mitigate against the next problem that a patient will have for which we may not have an algorithm to support our decision making. And then finally, there's just limitations to data sharing. We've heard a ton about this interoperability issue today, this morning. And there's certainly the PHI and data sharing issues. And there's also simply even if we were able to overcome those, there's also the issues of proprietary nature of some of these algorithms being used. So with that overview, we can jump into two, I think, deeper examples of studies that have been published using machine learning and AI-based algorithms, and use those, again, as a substrate to talk about logistical, social, ethical dilemmas in the implementation of these algorithms. And so first thing I'm going to talk about is a study published in ATS validating a deterioration index model among hospitalized patients with COVID-19 admitted to the hospital in an inpatient setting. And the goal of this study was to detect before a patient deteriorates, defined as being transferred to the ICU, being intubated, mechanically ventilated, or dying. So trying to predict deterioration of a patient with COVID-19 admitted to the hospital. A cohort was at a single academic medical center, admitted to a non-ICU setting. And the data collected was basically what is routinely collected on most hospital inpatients. Didn't try to extend beyond that. So just staying with what's routinely collected within a EHR as a starting point. The goal was to produce a score 0 to 100, representing the likelihood of deterioration. And the algorithm performance was average. It wasn't amazing. It's not a worthless algorithm, but also far from perfect. And for those who are interested, I direct you to reading more about the performance and the limitations here. You can read the study. But what I want to talk about with my time here today were some more deeper questions about this algorithm. How does it work? Why should we trust it or not trust it? And in what clinical context would it be more or less effective? And then also what should we do with this information? And as it turns out, there's multiple considerations for a model to be trustworthy and useful to clinicians on the front line. At a minimum, the model has to be accurate, but that's only a starting point. There's many different layers to address for a model to be, again, trustworthy and useful to clinicians. So building up from this base layer of accuracy, we've heard this before, but that needs to be transparent. So a clinician needs to understand what factors are driving a prediction model, not just the end result. And in this situation, mechanisms are very important. So just like the many causes of hypotension will imply different treatments, the same is true for a prediction model. Is it the patient's arterial lactate of 4.5 that's driving the prediction, or is it the patient's respiratory rate of 6? Beyond this, models need to be credible. And that is to say, does the variable that's driving the prediction fall in line with subject matter expert opinion, or is it in contrast to decades of literature on a particular topic? And that's not to say that experts can be wrong, they can be, but it's uncommon. And so for a model to be credible, it needs to be influenced by variables that have plausible biologic mechanisms underpinning the relationship. For example, if a model was influenced, if this deterioration model was influenced by the patient's age and vital signs and a blood gas value, that's potentially more credible to a critical care physician than a model that seemed to be driven by perhaps maybe the day of the week or the patient's height, serum chloride level. And that's not to say that that useful predictions can't be made on those variables. It's just to say that there are variables that experts hold in higher regard and will carry more weight than other factors. So if it falls in line with factors that an intensivist has come to trust through decades of established research, review of the literature, and care of the tens of thousands of patients coming through ICUs, again, that has a more credible, that's a more credible model. And then finally, at the pinnacle of all this is that a prediction model needs to be actionable, or at least informed by modifiable risk factors. So it's one thing to have a prediction model for deterioration that's influenced by age, comorbidities, patient sex. But when it's another thing when it's built upon variables that can be modified in real time, such as the blood pressure, pulse ox, the hematocrit. And when you have variables that are plausibly tied to interventions, again, you're still having to grapple with this association versus causation issue. But if they're at least plausibly tied to interventions, then there's at least the potential to inform clinical decisions beyond just risk stratifying patients. So taking into account these principles of transparency, credibility, actionability, here's how the EPIC deterioration index, and I have no financial interest in the EPIC deterioration index. This is a slide that's publicly available, but it's a good example of how I guess healthcare prediction modeling is starting to think about these principles of transparency, credibility, and actionability. I just want to show again how this might work, and how information might be displayed to clinicians in a way that's more useful. So not only do patients get a probability of a patient, again, deteriorating, defined as going to the ICU, being intubated or dying, but they get transparency into what characteristics are driving this machine learning model. So it's really the patient's age, the respiratory rate, and the fact that we can't get a neuro exam on this patient that really seems to be under the hood driving this prediction right here. We get some credibility in understanding how important these variables are to the model. And then finally, it embraces actionability by incorporating at least a few potentially modifiable risk factors. Now, this isn't a panacea, but by showing what's under the hood, this deterioration index is much closer to earning a clinician's trust than displaying a seemingly magical black box risk score on the left. So I think it's a start. It's not, again, there's many more problems to be solved, but I think this is, again, a large step towards useful information being presented to clinicians. Another dilemma to address here is this issue of data set shift. So to make a model trustworthy in healthcare, we need to take on this issue, which is broadly defined as an evolving mismatch between data that an algorithm is trained on versus tested on, which can lead to the underperformance of a machine learning algorithm. I bring this up because there's a lot of prediction indices, such as the EPIC deterioration index, that were found to have a precipitous drop in performance when we had the black swan event of the COVID-19 pandemic, where patients admitted to the ICU were dramatically different. We had a completely different kind of demographics set of a profile of patients admitted to the ICU in 2020 than we had the year before. So there's this issue of data set shift that a lot of hospitals are now taking on and thinking about. And although the COVID-19 pandemic is a stark example, this issue of data set shift is happening in much more subtle ways all the time. It can happen, again, when the patient demographics or comorbidities of a patient population going to a healthcare system changes. But it can also happen when there's some fundamental change in the healthcare delivery system. So if you're switching software vendors in a healthcare system, again, there's this issue of interoperability, and we may have underperformance of an algorithm simply due to the changes in how the data are entered. The changing definition of a disease. So if the definition of sepsis or the definition of hypertension changes as defined by consensus guidelines and on a panel of experts or society, that will influence the performance of a prediction model. There can be changes to clinician incentives. So the billing for a heart failure exacerbation, the billing for that admission becomes is doubled. There might be a new incentive to document this more frequently in the medical record than there was the year before. And so all of these things happen in subtle ways and can really erode clinician trust and usefulness of these algorithms. And this has led a lot of hospitals to start thinking about developing healthcare algorithm governance committees, which can actually kind of monitor and turn on and off algorithms deployed in a clinical setting based on both kind of a command center broad level overview of the algorithm's performance and also just observations from frontline clinicians who might say, hey, this algorithm that seemed to be working well last month, it's not working well at all right now. Something's going on. And so different hospitals have been thinking about doing this. It's not just how good the performance of an algorithm is at the start. It's about how do we maintain these algorithms? How do we govern them? How do we ensure that we're doing less harm than good? And so U of M, just like some other medical academic medical centers, has developed what's called the Clinical Intelligence Committee, where we have worked on developing ways to monitor algorithms that are embedded into the EHR and making sure their performance doesn't dramatically change over time. The key to having an effective algorithm governance team work is to keep that communication between the frontline clinician and the governance committee very tight and rapid, and needs to be a very multidisciplinary committee. Both clinicians, informaticians, ethicists need to have the ability to communicate very quickly with each other. And so there's a QR code for a New England Journal of Medicine viewpoint on this issue that I have on this slide for those that are interested in learning more. Second example I want to talk about today is now a study that's been published 5 years ago, but I think it has an interesting point that I want to illustrate. It was a study published in Anesthesiology looking at the prediction of post-induction hypotension. And the goal of this algorithm was to use data available in the EHR prior to induction to predict the likelihood of post-induction hypotension. It used a single center data set of older children and adult patients, and again, used data that was commonly available in the EHR, both in the anesthesia H&P and in other sources within their EHR, including baseline blood pressure prior to induction too. And what we found in this study was that in a test data set, the best performing prediction model, again, just yielded modest performance for predicting hypotension using data available prior to induction. Again, not perfect, not worthless, somewhere in the middle. And again, if you're interested in learning more about this algorithm, I direct you to the study. But with my time here today, I want to talk about what would we do with this information to make it useful and actionable. And the answer to this is, like so many things in healthcare, it depends. It depends on the nuanced clinical context, and it also depends on the shared values of the anesthesiologist and the patient, which we can call judgment for the purposes of machine learning modeling. And so in this slide, I just show kind of the anatomy of a clinical decision being made, or really any decision being made. And we can start with data that is used by a machine learning algorithm to make a prediction, which is simply what a clinician needs to know in order to understand what will happen next. And then there's this other component that gets much less attention, which is judgment. And that's the values used by a clinician or algorithm to value different outcomes. So this is basically what a clinician needs to know in order to take action. And I want to just walk through a hypothetical example of how this algorithm published might be used and some of the dilemmas that we have to confront as clinicians if we're really going to make this useful. So to illustrate this concept of clinical judgment, I want to work through a hypothetical example. This is a 74-year-old gentleman who is relatively unhealthy, severe carotid stenosis, COPD, renal insufficiency. They're getting a major surgery. And let's just say we plugged that data into our post-induction hypotension prediction algorithm. We find that the probability of post-induction hypotension is 98%. And in this example, let's just assume that the algorithm has basically perfect accuracy because there's still some huge limitations to the algorithm, even in this case, which are important to consider. If we believe that hypotension is bad, which we may or may not, but let's just say hypothetically we believe that and we want to do something in order to mitigate the effects of hypotension. And so for the sake of argument, let's just say this ASA4 patient with carotid stenosis is at a 1% chance of having a stroke if we do nothing. And they're at a 10% chance of having a pulmonary complication related to their COPD after the surgery. And they're also at a 10% chance of having acute kidney injury based on their baseline impaired renal function. So if we argue that the risk of a stroke or any of the other complications is unacceptably high, we can take action. One action we could do in this simplified hypothetical example is we can give the patient a fluid bolus, and that will raise their blood pressure, which is at the detriment of more fluid in the lungs and maybe increases the risk of a pulmonary complication, but it's at the benefit of the kidneys, which have improved renal perfusion, maybe a reduced risk of AKI. We also have a third option. We can give patients some phenylephrine or some norepi, and in this hypothetical example, let's just say that it's equally effective for mitigating the risk of a stroke. It cuts it in half. And it doesn't pour fluid into the lungs, so maybe we have a similar risk of a pulmonary complication. We don't have an increased risk of a pulmonary complication. But it does clamp down on the renal vasculature. And again, in this hypothetical example, let's just say it leads to an increased risk of acute kidney injury. So where am I going with all of this? We have three choices, three consequences, clear trade-offs. And if we recognize that not all complications are equal, that is, having a stroke is way worse than having a pulmonary complication or acute kidney injury, then we need to make a judgment call. And we can't just, if we were just being purely quantitative, we can't just add up these percentages. It's not enough to know that a stroke is worse. We need to know exactly how much worse a stroke is than a pulmonary complication or acute kidney injury. And so I'll pause here for just a few seconds, and I'll let you ask yourself, how many acute kidney injuries or pulmonary complications would you be willing to tolerate in order to avoid one stroke? Is that 10, 100, 1,000, 10,000? An infinite number of pulmonary complications or acute kidney injury? Let you decide. It's an interesting thought experiment. So these judgments are things that we as clinicians do intuitively all the time, but we rarely explicitly codify these into relative values, which is fine. We can rely on our experience and training to have a sense of what's important. But if we're really going to be precise about minimizing harm to this patient, at some point we do need to decide exactly how much worse a stroke is than acute kidney injury or pulmonary complication. And so this is actually, when we do this, this is actually a machine learning technique called reinforcement learning, where we reinforce our decisions with good outcomes. We penalize our decision-making by bad outcomes. And we adopt a policy, which makes the judgment call about the relative burden of each bad outcome, and then decides on the outcome, the values, and then it will make a decision that minimizes the total overall burden. And so I recognize this in this hypothetical example. Let's just say that a Stroke is 50 times worse than a pulmonary complication, 100 times worse than acute kidney injury, and that's totally debatable. And I actually encourage this debate because I don't think we often have it. But let's just say in this example, these are the values representing our judgment as a clinician. At this point, you can actually do some math. Now, it just becomes an expected value problem where we multiply the burden of each outcome by the probability it'll happen, assuming that these are the entire universe of complications. I recognize that's a vast oversimplification, but let's just say in this hypothetical example, these are the three things that we're worried about. And so what we find out is we can do this, and we can figure out that giving a vasopressor is the best choice among these three courses of action for this patient. And so we give some phenylephrine. Maybe the patient has acute kidney injury after the surgery, but wakes up neuro intact. And so taking a step back here, the really interesting part about this whole problem was not the probability of the hypotension, nor was it the probability of any of these complications happening, but rather it was the unspoken judgment, the clinician's intuition about the relative harms of each complication that was at the core of the clinical decision-making. So how do we get at this? So forgetting machine learning for a second, should we be having these kinds of conversations? Who should be involved? Should it be hospital, other clinicians? Should the patient be involved? So I just want to jump back to our decision kind of anatomy slide. We're making great progress with analyzing data to make predictions. But there's much progress to be made looking at quantifying judgments for clinical decision-making policies. The stroke versus the pulmonary complication versus the AKI in this, again, overly simplistic hypothetical example. But that's really where we need to make progress if we're going to be implementing these types of algorithms. How to kind of figure out this judgment, this intuitive judgment that we have as clinicians caring for tens of thousands of patients over our career. It's really, I don't have a great answer for how to get at this issue, but it is an interesting thought problem. And what I can say is that whereas we can't explicitly quantify our own judgments, that might be okay. We can actually use an algorithm to reverse engineer and learn our judgment by predicting our actions rather than predicting our outcomes. So an algorithm learns our value system based on what decisions we make in a variety of situations. Of course, there's a huge caveat to this, which is that it will propagate our own biases if we're not careful. If an algorithm learns our own value system, we need to be careful about what biases we already have that influence those values. And so here's oops, I'm just gonna go back. I guess there's this more high-profile example of bias creeping into a prediction algorithm. There was a example where Amazon would try to predict whether a candidate applying for a position at Amazon would be a successful hire, and they developed an algorithm that looked at resumes and predicted whether or not this patient would be a successful hire based on previous hires. It learned that this algorithm actually, when they dug deeper, they found that there was a bias against females. If you had anything in your resume that revealed that you were female, it would deprioritize your score of your probability of being successfully hired. And so this algorithm was scrapped. It was absolutely flawed, and I think there's some learning to be done here, but it is an interesting example of how bias can creep into algorithms and have potentially catastrophic consequences. And it gives us an opportunity to reflect about how we need to mitigate against more subtle biases than a sex bias. Obviously, this is an important example, but there's much more subtle examples too in healthcare where this is happening, and we need to think about how we're going to monitor and mitigate against those issues. Just some take-home points. I think machine learning is conceptually feasible, and we can certainly take studies and embed machine learning algorithms in the electronic health record. But it's really the maintaining of those algorithms making sure they're generalizable, safe, unbiased, clinically actionable. Those are really the challenges that we have and that we've heard a lot of already really outstanding talks today about. What can we do today? I think some of the next steps are for us as kind of thought leaders in this area to make our colleagues aware of the limitations of AI and machine learning, use it to improve care and not to incentivize misguided practices. That's a huge issue. We need to know what are the right problems to solve. So usually these are lower risk issues. So we may not be wanting to necessarily focus on predicting sepsis or clinical deterioration, but maybe we want to just figure out a way to optimize our outpatient clinic schedule or at our pain clinic based on the weather patterns or based on the day of the week or based on the patient's complexity. That might be a lower risk problem to solve where maybe the data for making that prediction is available and it's not subject to outliers or nuanced clinical contexts. We need to understand the inputs coming in. So if we all know the saying garbage in, garbage out, but if your data is irrelevant, inaccurate, or biased, even the most sophisticated algorithm won't be able to work. We need to seek transparency, actionability of these algorithms. So just like we need to know how a pulse ox works in order to understand whether we can trust and act on a low SpO2, we need to also understand how a machine learning model works in order to understand whether a prediction model can be trusted and whether acting on it would even make a difference at all. And finally, we need to encourage our clinician colleagues to learn our biases before an algorithm mimicking our behavior makes decisions potentially reflecting our own unconscious biases. So with that, I thank you, and I'll be looking forward to other panelist talks, and we'll be answering questions at the end of this panel.
Thank you. Thank you very much, Michael. So it was great because you covered a lot of the basics of the machine learning and the development of algorithms and so forth. So that gives us a lot of material for discussion in the end. The next speaker I'm going to call, it's my pleasure to call Dr. Susan McGrath. Dr. McGrath is a biomedical engineer. She's also a black belt, Lean Six Sigma. I think it's important to mention because to me that really demonstrates the expertise she has between the biomedical engineering and also the process redesign and the implementation phase of the work she's been doing for close to 30 years, working in the industry, working in academia, working for the military. And really, Dr. McGrath is probably the most experienced person for implementation of systems that improve patient safety based on digital solutions. She's been working at Dartmouth for many years, the core director of the system analytics and analytics surveillance, and they've developed digital safety nets that have been actually implemented in real life with great outcome, great impact on patient safety. And so it's a pleasure to have Dr. McGrath here with us and share her experience with actual implementation of this system.
Thank you. Thanks for having me. Thanks for this opportunity to share with you a lot of the work that we've done. This is a smattering of things that we've done over the years, so not intended to be a complete view of everything that we've done. All of the talks this morning sort of inspired me to change what I'm going to say a little bit, so some of the slides might be a little bit off, but there's such a rich discussion to be had here, and the depth and breadth of the presentations today are just really inspiring. Just in case I don't remember to do it at the end, I want to recognize that there are many, many people who've been involved in our work over the years. This work that I'm going to talk about covers almost 25 years of collaboration amongst multiple disciplines. So engineers, physicians, nurses, biomedical engineers, systems engineers, human factors engineers, physicians, and not just nurses who are bedside nurses, but all different types of nursing participants. And I do have a relationship with Maxime to deliver talks like this as a consultant, just so you're aware of that. For those of you that don't know, Dartmouth-Hitchcock is a hospital that's about 400 beds located in rural New Hampshire. We have a very high CMI, top 20%. Ooh, I didn't forward. There you go. Thanks. Thanks for that heads up earlier. So Dartmouth-Hitchcock is a rural hospital, very high CMI, top 20% amongst academic medical centers, the top 5% in the nation. And we have very high occupancy. We have the largest number of Medicaid and Medicare patients in the state of New Hampshire. We also draw patients from the state of Vermont as well. So we're a pretty busy place, lots of surgical specialties and many medicine patients as well. So this particular work was initiated by this event. We had a patient in their 30s, that was brought in for a routine medical procedure. It was a surgical procedure. They had been assessed prior to that surgery, and after the surgery were in the inpatient unit. They had opioids and were given additional medications for anxiety, and they were found dead in bed. And my colleague, George Blake, who was then patient safety officer at Dartmouth-Hitchcock, who I had been working with for several years on remote triage work, unrelated to in-hospital work, called me and said, you need to come over here. We need to take a lot of the ideas that we've been developing for remote triage and bring them into the hospital. We can't ever have this happen again. This is something that we just won't tolerate. And so that really has started since that time. All of the work that I'm about to show you that spans, that was about 2006. And so from that time to now, so it's nearly 20 years, but we were collaborating for many years before that. So this should be a familiar case to you, right? So this is something I'm sure all of you have heard about, but what should never happen in any hospital anywhere. This is a totally preventable event. So Dartmouth-Hitchcock made this commitment not only to reduce opioid-related deaths, but unwitnessed arrests totally. So it started with the patient who was on opioids and quickly expanded. And so we sought to develop a system. We didn't buy a monitor and install it. We developed a system with processes, with evaluation, with measurement that we implemented with bedside monitoring using pulse oximetry on all patients all the time. So at that time, we elected to use pulse oximetry because we felt that it gave us multiple parameters with one sensor that we thought would have high patient acceptance, which turned out to be true. And we decided to monitor all patients all the time because risk prediction systems would not have detected, given high risk to that patient that died. And so we felt that there was no really good way to ensure that we would not have another case like the one that brought us to this place. And so we monitor all patients, their entire general care stay, medicine and surgical patients. I highlighted the word surveillance there because the system, we were not the first to try to do continuous monitoring in the inpatient setting, but we were the first probably to think about it as a system and to bring in a human factors engineer to figure out how we could make this system so that it was a partner to the nurses. This was not an extra thing for nurses to do. This was something that was introduced as a collaborative system. This was intended to be technology that was serving the nurses at the bedside who have a high nurse-patient ratio. And the intention here was to draw attention to severe and sustained deteriorations. And I think that's really important to understand. This is not multi-parameter monitoring where we're alarming all the time on SpO2 of less than 90. This is supposed to say to a nurse who's busy with Bob, Elizabeth needs you now. You need to come now. There's a serious thing going on here. And the only way that we figured that we could have nurses participate and manage those alarms was to have very wide alarm parameters. So we alarm at an SpO2 of 80, and then on pulse rate, it's 40 and 50 and 140, and we've subsequently reduced it to 40 beats per minute is our pulse rate low. We also introduced an alarm delay before we get to an audible alarm. So if you hear an audible alarm, the SpO2 has been below 80 for 15 seconds. And then we use directed notification. If you are the nurse responsible for that patient, you are the first. We use pagers, so I'm going like this to illustrate pagers. But now we're using phones, which are probably still right here. And so it's directed notification. So it's not broadcast to the entire unit. We don't have every nurse getting every page, and the alarms are actually turned down because we have pods, and so only the nurses in that area should really be hearing those audible alarms. So all of these things were designed. This was a system that was created intentionally, and we piloted that system in a single unit, orthopedic unit, and did leadership rounding and were there daily. The vendor was there daily. We were collecting data all the time. We were changing settings as needed based on the feedback that we got from the nurses. And then the system was rolled out after everybody was comfortable with it, and the nurses felt like the number of alarms was something that they could manage. And so I just, again, want to emphasize that this was a system that was designed very carefully for this particular setting to solve this particular problem. We also, over the next few years, developed a roadmap where we saw what we had done in the inpatient setting, that the data that we were collecting and starting to process and report on could be used to develop systems at multiple levels. And so over the years, we had an ARC P30 looking at failure to rescue from 2015 to 2019 that was based on the idea of taking it from the floors with threshold alarms and then creating a whole suite of tools that could be used by nurses at the bedside, and then using sort of a command center way of thinking about things so that we could do resource allocation of our rescue teams. We could move flex nurses to units where there was higher acuity patients at certain times, and also activate those rescues if we needed to. And then, of course, you can see where that's going, from one site to multiple sites to the at-home environment. And we really still believe that the data set that we've collected is very informative for moving into a home setting and trying to detect events that happen there. Okay, so what's the data? So we have continuous monitoring data collected every second from every patient that we've monitored since 2007. We have a massive Oracle database, bless our IT people for doing this for us. It is part of the medical record. We have 220 plus beds that are on this system. So we're constantly collecting this data. It's probably close to 500,000 inpatient visits, which is somewhere on the order of 2 million patient days, something like that, that we have. We are able to marry that data with the electronic health record. So it's time synchronized, so we can line things up. So we can line up when a patient landed on the floor, when they were admitted to the system, when they were transferred to a higher level of care, when they came back. We know all their diagnosis codes. We know when orders were placed. And so if you see an order for lactate, we can time sync that with a physiologic record, continuous physiologic record of that particular patient. We also integrate vital signs that go into the medical record as well that aren't collected continuously. We also have several things that we calculate, Charlson and case mix indices for each patient, and state scores, NEWS, NEWS2, QSOFA, and MUSE. These are calculated retrospectively using methods that we've developed for missing data and old data. And we also have, of course, access to our rescue databases so that we know if there was a rescue, we know what the disposition was, we know if Narcan was administered, and so on and so forth. So we think we can form a pretty good picture of what's going on with the patient in the inpatient setting with this. So we've used this for a lot of different purposes. First and foremost, back in 2007 when it was implemented, the question, and you heard them this morning, can we afford this, and is it going to do anything for us? And so our early papers were really focused on saying, yes, we can save money by doing this, and yes, we can reduce transfers to higher levels of care, and also reduce rescues. And so our leadership was convinced based on that to roll it out to the rest of the surgical and medicine units, and that's how we got a full system implementation. We also use this as the black box from an airline that was referenced this morning. So if we have a patient safety event that happens, we immediately get a request to provide the second-by-second data matched up with the other data to provide back to the floor so that there can be a review of what happened with that patient and how that deterioration could have been caught earlier, or what can we do better, and what went right, how was it that we were able to rescue that patient, and what were those patterns. We have a dashboard for quality assurance and safety that we show that I'll give an example of in a little while. And we also do research. There are so many things that we've done where we've had unexpected results where we go, wow, would you look at that? how about if we do this? And what if we added this or did it this way? And so there's been a lot of innovation that has come from the very boring act of measuring the system to justify in its existence and to maintain system performance over time. So we've just gotten a lot out of being able to measure things with our system. So the pilot performance impact was referenced this morning a little bit differently than it's shown here. We had a 48% reduction in transfers to higher levels of care and a 65% reduction in rescue activity. That was, again, an orthopedic unit versus 2 units that did not have the system implemented. I think the p-value on those was 0.01. So fairly good differences in that unit where there was absolutely no difference in the other units. We also showed, we did 2 financial analysis with 2 slightly different results with the approaches, but saved somewhere in the order of $1 million per unit. That's a 36-bed unit opportunity cost based on that transfers to higher level of care. Alarm rates 2 to 4 per patient per 12-hour shift, well below what we would consider alarm fatigue. Even now, when we have other alarms like bed alarms added in, it's still a manageable situation. We're still just about at that number. A later study that I did showed that about 85% of all the alarm conditions are resolved within 30 seconds and 99 before there's escalation triggered to the pager or phone. What we were seeing a lot of is nurses coming into the room to help the patient and not silencing the system, putting it in standby prior to taking the sensor off. And so many of our alarms have to do with people adhering to the way that they put the system together. And I say they, I mean nurses help to design the system, so it's their process. Oh my goodness, I'm not going to be able to show it. Okay, so that slide, which does not show all of our control charts for our system. And so I apologize for that, but what it should show you is that we instituted a dashboard where we measured all of the things having to do with the system: rescues, transfers to higher level of care, utilization, different kinds of rescues, so separating out codes, stat airways, hurt calls, and all those things. And we tracked them over time, and we were able to show that the system was performing pretty steadily. Even 10 years later, we were getting essentially the same results that we had gotten in 2007, and that the CMI of our patients had gone up significantly during that period of time. We had also had the loss of a lot of experienced nurses, so we had a lot of lack of experience. So we were very pleased to see that some of the system numbers were holding fast during that period of time. My apologies for that. So in addition to, so we didn't do mortality in our original work because those deaths are fairly rare, right? So, but 10 years after we implemented the system, we decided to do a look back and see if the patient that had started all of this, who had died from the opioid overdose, would have been saved. Did we meet that mission of never having another patient die of an opioid overdose in the inpatient setting? And the short answer to that is yes. So in 10 years on monitored patients, we had 0 deaths that were opioid related. We had 0 patients that had harm. During that same period of time, we had 3 deaths in unmonitored units. And the reason that we had that is it was during a rollout period. So not every unit had the system in place. And so all the deaths during that 10 years happened in units where we did not have monitoring in place. We had 1 death in a unit where monitoring was available, but the monitoring was not being used at that time. So I'll also comment that patients can, of course, refuse to be monitored. And so we have a way of dealing with that and really encourage people, nurses, they have a script that they can provide to the patients to really encourage them to be monitored, but not every patient is monitored. So this is just remarkable to me. And so discussions of randomized controlled trials and all the things that would prevent us from doing this, to me, a hospital that had 0 deaths over 10 years should be enough evidence for every hospital in the whole United States to adopt continuous monitoring carefully. The other thing I'll say about cost while I'm at it is that we didn't know that we were going to have a reduced number of transfers to higher level of care. So when the system was implemented at Dartmouth-Hitchcock, the money that was used to buy it was came from a reduction in inappropriate ordering of telemetry of patients in the general care setting. And so when we were not the only ones to do that, Ohio State had a 53% reduction in telemetry orders. I read another paper I browsed this morning had a 43% reduction. So if you have appropriate ordering of telemetry, those very much more expensive systems, you can have less of them, and that money can go towards continuous monitoring of all patients. And so there are ways to address that cost issue other than the transfers, the opportunity cost and transfers to higher level of care. Okay, on we go. I think I was already at the next slide. Okay, so over the years, we've upgraded the system. So we now use something called Radius PPG. So it's a wireless monitoring system, goes to the finger. At one point, we were using a Radius that was on an armband. We also implemented the Root system where you can see trends at the bedside. So the more information that can be seen right at the bedside, we think the better. We'd already published a paper that showed that hand-entered data, vital signs, is often wrong. I think we estimated or calculated a 6% higher SpO2 value when recorded by hand versus the actual value that was recorded by the device at the time. And so ADT integration, the ability to get accurate information into the medical record, and also to be able to collect vital signs very quickly. This was a huge win for our nursing staff. We were able to save hours in terms of vital signs data collection, more utilization time with the wireless system, less risk of entanglement and all of those things. So this was an upgrade that we did starting in 2015. Okay, so another one that you can't see, oh, it's that result, so that's fine. I'm relieved. Okay, so now moving away from looking at things like patient days and rescues and transfers to higher level of care, so things that we do in the thousands to things that we do in the billions and the trillions. So this is analysis of the physiologic data that we collect second by second. One of the earliest things that we did, this was my student Josh Pike did this work for us, looking at the distribution of SpO2 and pulse rate in the general care setting. I also call this, I have it listed as a change management slide because we had a lot of pushback when we went to move from the surgical side of the house to the medical side of the house. We kept hearing, my patients are different. They don't have the same physiology. They don't have the same number of rescues. We don't need this system. And we were able to show with the data after we implemented on the medicine side that they're identical. There's no real difference between the physiology in either sets of those patients. They have the same number of rescues. In fact, at that time, our medicine side of the house was having more rescues than the surgical side of the house. I tried to list the number of patient days and points so you could see because this is a big data presentation. Here's another system study that we did. So we were often asked the question, why didn't you look at respiratory rate instead of pulse oximetry? And we wanted to answer that question. And so we implemented a acoustic respiratory rate monitor in several units over a number of months and collected the data. So first we collected it in the background with no alarms, and then we used that data and plotted it and did a simulation of the number of alarms we would have at each alarm threshold so that we could appropriately choose the alarm thresholds for respiratory rate. And so that's a real use of data where we're not just picking things out of the air, and we were able to add that alarm to the system without increasing the overall alarm rate by more than, I think it was 1 alarm per patient per 12-hour shift. We also use the same system to try to understand if we should add respiratory rate to our surveillance system. And just as a reminder, the surveillance system is intended to bring you to the bedside immediately when something very bad is happening. And so we looked at whether or not we could get more bang for our buck by switching to the acoustic respiratory rate sensor rather than pulse oximetry. So we compared values of the two things, and I think this was over 1 billion data points that we looked at. The respiratory rate sensor worked and has since been improved dramatically, and you heard a lot about different wearables. So that technology is there, usable, ready to go. But for the purposes of bringing attention to the bedside and adding another sensor or swapping out the pulse oximetry, we decided that for us, the right thing to do was to continue to alarm on pulse oximetry. So this is not to say that you shouldn't also measure respiratory rate. It's to say for us, for surveillance, for that purpose, we chose to stay with the single sensor that was very well adopted by our patients. The staff knew how to use it, and we were getting very good results with that system. Another question that we've been asked over the years is whether or not you can safely monitor patients who are on oxygen using pulse oximetry. And in theory, patients who are on O2 may drop off more quickly, and that rate of decline once they start to deteriorate could be a concern that you might not get there in time to rescue that person. But up until the point of this study, we just didn't see that in practice. And so we hear it, we heard people talking about it, so we wanted to try to explore it and see if we could detect this in our population. And the answer is we could not. And so we were able to see that patients who are on oxygen have higher mean oxygen levels, which, as you would expect. And if analyzing their desaturations, as shown in the top right-hand picture, the group that was on room air had more desaturations, an average more time spent in a desaturated state than the patients who were on oxygen. And of course, in the other states that we called recovery and normal, those numbers were different according to that higher percentage in desaturation. So when we look then at the characteristics of those desaturations, so the magnitude, the duration, and the slope, to see if there was a difference between patients on O2 and on room air, we did not see a difference between those two groups of patients. This past year, we decided to take a better look at this. And so now we're looking at almost 6 years of data. It's 120,000 patients, so that's somewhere 700,000 patient days of data. And what we've done is try to detect whether or not there are signs of late recognition for those patients. So are we getting there too late to rescue those patients? And we don't have all the statistics quite done, so I'm reporting some preliminary data here. But I can tell you that patients that are on oxygen in this cohort of almost 6 years do not have higher rates of rescue, especially the more serious rescues, so stat airways and codes. We don't see that those patients have higher rates. We also defined a planned and an unplanned transfer to higher level of care, because you can call a rapid response team without the patient really meeting the criteria of a rapid response team. So we didn't want to say that if someone had a rescue, that they didn't meet certain criteria. So we look to these types of transfers to sort of really understand whether the transfer was one that was planned or unplanned. Was it an emergency that had to be undertaken, even if there was just a life safety consult, which is a consultation at the bedside. So we found that those patients on supplemental oxygen did not have higher rates of those unplanned transfers than those that are on room air or transfers in general. So it looks to be that we're not harming patients who are on oxygen by monitoring them with surveillance. We are able to rescue those patients when needed, just as well as we can patients who are on room air. Also, deaths, not higher rates of death after rescue either. More on this later, not today, but we're also going to go back and do the desaturation calculations on this much larger cohort as well. All right, so one of the questions that we get asked all the time is, how can you possibly use an SpO2 low of 80 for your system? That's unconscionable. And so again, this is for surveillance. So this is the come now sort of arrangement. And there's a balance here between alarm management and having nurses feel like it's not a burden and that there's something actionable to do at the bedside versus having too many alarms and you can detect deterioration perhaps earlier, but there's going to be a lot of alarm fatigue and people just not coming to the bedside at all. So we did a study looking at retrospectively what number of alarms you would have had if you had used various thresholds and enunciation delays for pulse oximetry, so both SpO2 and pulse rate. And you can see in the top right-hand corner these dramatic drops, right? So each one of the colored lines represents a different threshold for the parameter. And then as you go across from left to right, it's the delay in enunciation. And so if you're looking for severe sustained deteriorations, you're down the bottom and going to the right. And we compared the impact on nurses using surveillance monitoring configuration to the two other configurations that we use in our hospital, which are condition monitoring, which is when you have someone that's a known risk and you want to more closely monitor them, and also critical care monitoring. And you can see the dramatic uptick in the number of pages and escalations and alarms that that nurse would be exposed to with those other configurations. And so we believe strongly that continuous monitoring should be in place for all patients all the time, but it should be appropriately implemented to manage the exposure of nurses to those alarms. And this is one way of doing that. Okay, so I think this is close to being the end. So there's been a lot of discussion of AI over the morning, and there will continue to be during the rest of the conference. And I wanted to say a couple things. So in our failure to rescue work, what we found was that there's a lot of emphasis on scores to find certain things. There's a sepsis score, and we found that physicians that perform certain types of surgeries like orthopedic surgery and a few others have scores specific to their patients. And so we think that that is a dangerous place to go. And what we just saw in the EPIC deterioration score is a view of a general deterioration. Something's going on with that patient. And we would tend to agree with that way of thinking about things. So moving from the general to specific, and AI or pattern recognition acting as a guide and a recommender, or helping people to draw attention to certain things rather than it being a decision maker. So really in a decision support and not necessarily in a highly automated way. And here's an example. And even though this is for a specific condition, this is a study that we did to look at patterns for pulseless electrical activity. So after we had realized that we had eliminated deaths from opioid-related overdoses, PEA was our next highest cause for rescue that was listed in our rescue database. So we went after this. And we looked at two things. One is trends in the mean and trends in variability. So you cannot get any more simple than this in terms of data analysis. This is not complicated at all. And yet we can see in these charts, so I think that these are 5-minute increments leading up to a PEA event. And you can see those trends start to increase over time. And we were able to look at those trends and write up a staged way of thinking about this. So, hey, you have a patient that has these characteristics, they're more likely to have a PEA. Second one is, well, you've got a patient that has some changes in variability in their parameters, so you should be maybe watchful waiting with this patient. And in the part 3, about 20 minutes before an impending PEA, you might see this pattern. And if you do, we might want to implement an alert that brings somebody to a bedside. So this is simple, and it meets a lot of the criteria that Michael just mentioned, right? So transparency, being able to peel back the covers, you can justify things, and it doesn't necessarily tell somebody what to do. And that, I think, would be decided by a group of clinicians and determining the actions that are here. Same thing with news and muse and all these things. You can score somebody all you want all day long, but if people don't know how to respond appropriately, and if it's not an actionable request, then people are not going to use the information that you're giving them. So with that, I'll just summarize by saying that having multidisciplinary teams, including engineers, human factors engineers, nurses, physicians, all types of clinicians, work together to develop systems in a hospital rather than to implement technology is an absolute must. And the benefit of having a person like me at Dartmouth-Hitchcock for the last million years is that we've been able to really take deep looks at this and make sure that our patients are safe, and we can keep improving the system for our nurses, who are the front line of detecting deteriorating patients at the bedside. And so I think that those points are really important related to AI or any other type of technology that you would implement at the bedside. So, thanks.
Well, thank you very much, Sue, for sharing all your real-life experience with this topic. So I'm going to introduce the third speaker. The third speaker is Dr. Cecilia Canales. Dr. Canales she's a faculty at UCLA. She's an assistant professor. Actually, I've known Dr. Canales for, I think, about 15 years. Dr. Canales, when I met her, was the director of the Simulation Center at UC Irvine, so she developed skills about human factors in medicine. She was also actually managing my lab, my research lab. And in my lab, about 10 years ago, we started developing systems to collect data, especially high-fidelity waveforms data, and to share this data with collaborators outside of UC Irvine or UCLA, or even with the industry. So we had to navigate, and actually Dr. Canales was the one navigating all of this, the ethics, the contracting, the compliance, data sharing agreements, especially in places like UCLA with a lot of celebrities coming, and a lot of questions about health equity and large data set. After that, Dr. Canales went back to medical school, did a residency at UCLA, and then joined the faculty at UCLA, I believe 2 years ago. She's now funded by the National Academy of Medicine. She's a scholar in diagnostic excellence for advancing language equity, for perioperative neurocognitive disorder, and also funded by the National Institute of Aging for a program for minority aging. So Dr. Canales is going to discuss the ethics of big data.
Thank you, everyone. Hi, I'm Ceci. I am just really thrilled to be here today. I haven't been part of a conference like this where I feel like you can really put a string from the first person who spoke today all the way through. There are so many connections in everything that we do. So I'm really just thrilled to be here. I'm going to check to make sure that I know how to move things forward. Dr. Cannesson was very gracious for the introduction. And really, my goal today is really to talk about some of the ethical considerations, really focused on equity, regulatory, and other considerations. And I'll discuss briefly the National Academy of Medicine framework on health care and innovation and equity. They actually released some guidelines based on working groups that they've had for a while, but they just released them about a week and a half ago. So when we talk about ethics, I think this exhaustive list here, so many of our speakers have actually already touched on a lot of these things. And I'm going to really focus this on a few things, like I said, equity, regulatory, and just a few other considerations. But why equity? And I think as most people in this room, if you're really involved in quality improvement or safety, this work is health equity work. So several years ago, I wrote a paper on the ethics of big data and artificial intelligence. And one of the things that I found just so interesting was one of the reviewers asked, why can't a white man code for the entire world as long as there is representative data? And I found that really interesting for a lot of different reasons. And really, I took that as a challenge of, I am not really expressing what I want to express in the correct way. I am not reaching the audience that I want to reach. So why does representation matter? Well, I don't care if it is a white man, an Asian man, a trans man, or a Black woman. You are leaving out a vast proportion of the population when one phenotype is really looking at the data. Now, I am very honored to be a physician scientist, and I saw this documentary, and my bias when I saw this, picture a scientist. What comes to your head? And I can tell you, rarely, even in my own lab, am I mistaken for a physician scientist. And I just find it really interesting when you look at the world and you look at the experiences people have, when you look at anesthesiologists or healthcare providers in general, so much of how we manage or we treat our patients is based on our experience. So representation matters for many different reasons. I love this example from Joy from MIT. She's a data scientist. And she was working on something completely unrelated. She is a Black woman physician scientist. And she found by accident, really, that facial recognition did not work for her skin tone and her gender. And so she did an experiment and she looked at a lot of facial recognition systems out there. And by and large, dark women were misidentified at much greater proportions than white men. So what does that have to do with medicine? And in June, I met Alina James, who is doing some incredible work, and her presentation was on visual learning. She's a dermatologist. And she found that she found that there is a problem, that there is an underrepresentation of dark skin pictures in education material for our medical students or nursing students across the board. And she found that this is a problem. And really the only high representation of dark skin tend to be for very socially stigmatized things like infectious diseases. Then you're much more likely to find pictures in medicine, in education, in our textbooks that we're all learning from. And again, why does that matter? Because it actually matters in the type of work that we're doing on a day-to-day basis. So one of the post-COVID things that we have found is that it came to light that things as simple as the pulse oximeter that we use every day to make decisions in anesthesiology, in the ICU, in the floor, for remote monitoring, for all of these things, they tend to perform less well in dark skin. And again, why does that matter? Because one, patient safety, that should be enough. But if that is not enough, then thinking about now that we know what legal implications do we carry as safety ambassadors. So this paper out of JAMA really went through and talked about kind of what are the legal implications of this. If we know that pulse oximeter isn't working as well, and we don't check oxygen saturation, blood oxygen saturation for dark skin colors, could that put us at risk for legal implications? For patients to be able to sue us or sue the hospital for not having adequate monitoring for our patients. There's also a proposed change to Health and Human Services rules that specifically prohibits covered entities from using discriminatory clinical algorithms in healthcare decision-making. So again, I think that this speaks again to a lot of the work that we're doing here, both as providers, as inventors, as patients. And so really a lot of work now has been done to try to mitigate some of these issues. People are kind of seeing it in a different light. And this is some more really out of our department in collaboration with some data scientists, where they're specifically trying to tackle this issue head on. And I think that is part of representation and why representation matters. All right, so we talked about representation, and part of representation is bias. Unconscious bias, which again, I think Michael talked a little bit about and we've talked about in different areas. I'm not sure how many people notice that this is actually in Spanish, but this is in Spanish. We tend to have a lot of language bias, which is part of my work that I do. So again, years ago, we talked about what are some of the biases that we have to really think about from an ethical standpoint. So is AI, our machine learning programs or algorithms fair? And what is fair? That is a very, very, very big question. But what implicit or explicit bias is being integrated into these algorithms? How is the training data representative of our target population? Again, we could go on, but really, what is an algorithm? So take a little a Crayola here, and so we have an input, a set of rules, and we have an output, and that is an algorithm. And how are they made? By humans. And we all have biases. I have biases. Every person in this room has biases, whether they're conscious or unconscious. And these are built by our set of experiences. I can't tell you how often, I'm a new graduate. I have not been faculty for very long, but I can tell you that every time I worked with a different attending, they had their own rules of how I was supposed to do my job. You never do this. You always do that. And what built those experiences was their past experiences. What they have learned, they are now teaching me. And that is how algorithms are made. Whether they're conscious or unconscious, you are pushing forward your sets of experiences. And I am positive that my life experiences and how I see the world and how I interact with the world is very different than each and every one of you. And I don't think that most people who are doing this type of work are trying to be racist. I don't think people are trying to cause harm. It is the unintended consequences of not realizing that there are vastly different views of how we interact with healthcare. So I think that these examples here are just incredible. One, looking at how using an algorithm on resource allocation. So these data scientists created an algorithm. They take patient information and they decide these patients are sicker based on how much money they spent, how many hospital encounters, how many things are they doing. So now we're going to create an algorithm and we're going to put it out and we're going to roll it out and help us to decide who is going to receive higher level of care. Not realizing that underserved communities may not have the money, may not have the insurance, may not have the trust to go to the hospitals as frequently. So expenditure is not equated to health. So when you roll out the system, Black patients who were of equal health to white patients had less resources allocated to them. And that's because this algorithm was created by someone who didn't realize that maybe people who are disadvantaged are not spending as much money on healthcare, not because they're not sick, but maybe because they don't have the resources or they don't have the trust of the institution, they don't have insurance, they're not able to make it to regular doctor's appointments for a whole host of reasons. And when you think about this and you think about health disparities, equity really needs to be at the cornerstone of innovation to improve access. I don't think machine learning, AI is this terrible thing that we should all run away from. I think quite the opposite. We need to adopt it in a way that improves access. When you make equity the cornerstone of your development, of your algorithms, of your institutions, of your care paradigms, that's how we are going to take a very flawed system and improve access and equity to care across the board. So we need to learn how to be proactive instead of reactive. When we look at historical data and you say, well, the data doesn't lie. We're just taking the data and we're applying algorithm to the data. If the healthcare system is flawed, the data is flawed. And if you don't think about it from that perspective, you may have very good intentions and introduce irreparable harm to your patients. Whether it's language access, people with disability, race, cultural norms, other social determinants of health, if by bringing in people with vastly different experiences, you're going to be able to tackle some of these issues in a way maybe that you would have never thought about yourself, but bringing in a multidisciplinary team with multiple people in various areas, you're able to tackle this. And I'm going to share a recent story actually with a colleague of mine. Not in my department, but we're both applying for grants, and we have similar language equity work in different fields. She was hired in, she's a PhD, and she received a mandate by a director of a center, said, you need to bring me your people. I can't recruit your people. How are you going to bring me your people so that we can have representative data? That is part of the problem. If you can't hire a research assistant and expect that that is going to change the way data is collected, data is inputted, data is annotated, that does not solve the problem. It may be the first step of actually having some representation for some clinical trials or different things, but when you say, bring me your people, that's a problem. And if that doesn't get to you, if equity just on its own doesn't get to you, there is a huge return of investment. When you look at the data across different companies, different sites, if you have a diverse workforce, you have a much higher return on investment. So for hospital systems, for companies, think about putting equity in your cornerstone to improve the bottom line. From a regulatory standpoint, these are things that we have been talking about for well over a decade, whether it's privacy, data security, data ownership, data stewardship, governance. It's really something that people have now started to, the lay people have started to really see this coming to the forefront. It's at their conscience about consent, for example, or what harm is done to people. Again, I think that we could all have very good reasons for wanting to do certain things, and we think about data as a whole and not necessarily always as an individual, or vice versa. We only think about it as an individual and not necessarily as a whole. But you can have patient privacy issues, whether it's leaked data, but when you start to aggregate data and you think of unintended consequences. So what happens when prediction models say that this person is going to be sicker and actually insurance companies will drop a patient when there's no safeguards for patients who are going to become sick. And we've heard of stories in the news where Google or Facebook or somebody knows that you're pregnant before you do because things are changing. You haven't gotten your period and it's on your tracking device and it's on your iWatch and everything is integrated. All of this data is out there. And when you start to aggregate this data together, it really isn't de-identified anymore. And the regulatory systems that we tend to think about is HIPAA. But there is such a vast amount of data that's out there that goes beyond hospital data that is not protected. So really we're at this cross-section between the ethics, innovation, and legal standpoints of who owns the data, who gets data, how do we share data, how do we access data. And there are a lot of different implications about how we collate, aggregate, and use the data, whether it's Epic, whether it's MPOG, whether it's your own at your own institution. We have to think about more from a regulatory standpoint what safeguards we're going to be putting in place. And really accountability. I mean, we've talked about transparency, but I think that this goes beyond transparency. We talk about the pulse oximeter and how does it work. I can tell you that many people use a pulse oximeter every single day and they have no idea how it actually works, or any type of monitor. So transparency is one thing to think about, but when we think about judgment, I think Michael was talking about judgment. Who is inputting judgment? Does that make you legally accountable for the work that you're doing? So again, another thing to think about. We recently wrote this paper, and it was a really fun paper to write on just ethics of big data and perioperative medicine, but really talking about unregulated AI at the bedside. A lot of companies, a lot of providers spend a lot of time and money into developing decision support tools, developing the pulse oximeter, and that's all great and good. It goes to the FDA, CMS, how do we reimburse? But what happens when ChatGPT is helping your first-year resident make medical decisions about care? And whether you like it or not, that's happening. You can have, it's July, you have your brand new intern who doesn't want to wake up their senior or their attending or their fellow in the middle of the night, and they ask ChatGPT, they do a curbside consult, and to see what they should do. And the reality is they have no idea what ChatGPT is. Again, a colleague of mine who has children was telling me, I was talking to her about this paper that I'm writing. She has two less than 1 year twins. And she asked ChatGPT what she should do about something. And I said, well, do you know what you're asking? Do you know what information? She's like, oh, it even had PubMed IDs. And so I know that the data was real. It's like, oh, you really have no idea what these large language models are and how they work. And very educated people, very smart people, very well-intentioned people just don't always know how to use the technology around them, whether that is an FDA-approved monitor or unregulated AI assist or curbside monitor at the bedside. So education is so important. It needs to be fundamental, not only for young, new trainees or medical students, but for each of us practicing on a day-to-day basis about what we're using and how it impacts the patients that we're working with. There needs to be greater education on data stewardship. We need to have greater education access to each type of device. Again, also recently, I had a colleague at a different institution, but a colleague who asked me, you know, can you teach me how to use point of care ultrasound? I need to learn how to do this. And it was to do ultrasound guided A-line. This is also somebody who supervises trainees at another institution to use ultrasound on a day-to-day basis. First, I was shocked that she would ask this because she supervises. But I was also very proud that she recognized that she needed additional learning and would go back and ask on how to use the technology, how to use something that she does actually use on her day-to-day patient care. And so often we have so much ego in what we should know or what expertise we have. It's very difficult for us to show where we are lacking. And this is something that we need to change the overall culture of how we look at these things, because again, it's not about ourselves, it's about our patients and what we're doing on a day-to-day basis. So whether that is learning about artificial intelligence, big data, the monitors that we're using, or just having a simple conversation with the patient, we need to do better. We need to communicate better. So the National Academy of Medicine, like I said, just over a week ago, published this framework for innovation in health and medicine. There's actually a webinar, I think, that you can get the highlights from. But they really thought about this from a systematic standpoint for such a long time. And so I really encourage you all to go through. These are kind of the bullet points and how they decided to address this. But it is a much larger document and something that I encourage all of you to go through and read. So looking forward, technology will evolve. The solutions that we think of today and the problems that we're thinking about today are not going to be the solutions and the problems of tomorrow. So when we think of these changes, these how we're going to address some of these issues, some of these inequities, I actually think that if we make equitable healthcare at the cornerstone, everything will improve. Not saying everything will be great, but you bring the tide up when you really make this as part of the cornerstone. You need to engage stakeholders. And by engaging, I don't say have your research assistant meet the community that you want to bring in, but actually make partners across disciplines and within the communities and make true partners that can help you develop your technology, develop your algorithm. You talk to the patients and you try to understand what matters to them. When we think about judgment and what Michael was talking about up here, about that judgment, and is it better to have a stroke or an AKI or pulmonary edema? Why wouldn't the patient be part of that conversation as well? Why wouldn't their family be part of that conversation as well? And absolutely incorporate education. If we do not teach people what we are using and how we are using it, it is never going to get better. And more inequities will 100% be systematically embedded into our healthcare system. Thank you.
Thank you, Ceci. Ceci, maybe you want to stay here, and then I'm going to call Sue and Michael to the podium. And is there any question in the audience?
Please. Thank you for those talks. Those were fantastic. A couple ideas just to share. A phrase I learned, which was really helpful, was ASI, which is augmented statistical inference. And I found that as a paradigm shift. The other thing I want to ask about was related to adding to the team. There's an idea of adding, statisticians, I think, to the team. Can you expand on that and how there might be more people involved in the care team? I think, yes.
Me?
Yes.
So I think that we tend to be very hierarchical in medicine. We think that we know best. We know more than everyone, and very paternalistic. Let me tell my patient what they need or what they want, what is best for them. And when you integrate multidisciplinary teams, when you bring in your bioengineers and they see what monitoring at the bedside actually looks like or in the operating room, it blows their mind. And it could be something as simple as how long is the power cord that goes to your device? They're like, oh, that's cute. Where do you think I'm gonna plug that in? The operating room is very, very, very different. So these are really smart people, and I could not do what they do. But if they make you a device that doesn't work in the context that what you need, doesn't matter. And so when you bring in statisticians, when you bring in people from the community, you bring in family members as part of their, you just survey the family, or you talk to them about what they care, what they want, or what they need. It gives you a very different perspective. And I love how in your remote monitoring, how you really have human factors experts help to design how people interact. And it is essential to make something that is not just a good research paper, but it is something that can be adopted into actual clinical practice.
This could, I think, be addressed by all of you or however you want to take it. The question is about how can we over time have confidence that an algorithm remains effective? And it goes back to data set drift, I think was the term used, and then also the possibility that there's been changes of practice since the validation, since the creation of the algorithm, the training, the validation of it. And Sue, this kind of occurred to me when you were talking about this huge data set that exists at Dartmouth, which was from 2007 to today. I'm kind of wondering, within that data set, some of it is maybe 15 years old or more. Is there anything there that may not actually be applicable today? So really, how do we make sure these algorithms are valid? How do we keep that confidence over time?
Yeah, it's a great question. And I think it's an approach that has to be multifaceted. There's certainly many different ways that your data set is drifting away from its original intended performance level and intended use. And again, some of that is practice change, some of that is changing patient demographics, some of it is literally an evolving science and different definitions of various diseases. And so I think, again, I had that slide in my talk just about the algorithm governance committee, but basically you need to have some very close-knit feedback loop between somebody who has a bird's eye view of the algorithm and how, from a command center kind of data diagnostics perspective can look at a high altitude your data quality and has insights about what could be degrading the quality of your data. Again, there's some obvious things like switching to a different software vendor or changing, maybe an updated, the ICD-10 codes are now being updated to ICD-11 codes. There are obvious things, and then there are subtle things too that I think you can have if you have some kind of, bird's eye view at a command center level of the quality of your data and what things might change over time. And then again, you need to have that clinician at the front line giving you feedback about is this algorithm that is used for clinical decision support, is it seeming to perform as expected, or is there something surprising this today or this month or this year? And tightening the response time and having all of the stakeholders involved, like, have an expertise in maintaining the algorithm. It's not just about how good your idea is, but it's how resilient it is to these things, which requires a multifaceted team of, again, statisticians, clinicians, ethicists, that needs to be very well developed. So pass along. Those are my thoughts.
Do I need to, can you hear me? Okay, so I think the answer is it depends. So practice changes all the time, and there are bazillions of clinicians that practice medicine independently without a ton of oversight on a day-to-day basis, right? So part of the question would be, how do you do it now when it's human beings that are doing the practice, and how do you have oversight of how they make decisions at the bedside? And I think some of the lessons about that could be applied to whatever algorithms you're also developing. And some things don't change very quickly. So I would argue that the SpO2 and pulse rate values of the people from 2014 are probably pretty similar to that of those in 2023. But we did go from, there's a difference in coding, all ICD-10s, ICD-9s. There's a big difference. We didn't have the same medical record system prior to 2011. And even when we switched to Epic in 2011, not all of our medical record system became available. So right now, if we're looking at flow sheet things for intubations when a tube was placed, we can't find that prior to 2016. And so that might make you think that there are fewer of them, right? But the fact is we weren't recording it the same way. So you have to have a pretty in-depth knowledge of the data and what's there and what's not. And I think that this is going to have to be done in small ways, and really trying to understand models of oversight when human beings do things. And if we're going to have an automated decision made by an algorithm where the human's not involved and it's not sort of a feedback or recommender system, there would have to be a different level of control than if you're having something that says, hey, that trend in that heart rate is going up from the baseline, something like that, which could be done by a pattern recognition algorithm. So I think there's a big range of answers to that question.
Great talks all, thank you. Sue, it's always great to see outcome studies in our field. They are difficult to do. One of the reasons they're difficult is that you have to have a matched control group. A lot of studies do control groups before and after some change. That's really not totally valid because you don't know how your patient population has changed in that period. Your controls seem to be well matched. But the only but I will add is the technology has already changed quite a bit since you did that study. Great study, but I strongly recommend that maybe you consider doing it again and looking at the advances in the technology that have happened already since then.
Yeah.
I think in our field, we're at a really exciting time right now. We talked this morning about, for example, wearables, and I bragged about one. Maybe redo that study with wearable technology because it opens the monitoring to all of those patients that are in that dead in bed category, that we've talked about. It should be zero. So what are your plans?
Yeah, so it's a really good question. So now that we have the system implemented in all of our inpatient locations, you can't sort of do it before and after. But when we implement new technology, we do roll it out as pilots. And so when we went from the wired system to the wireless, the first radius, we did gather data in all the places where we implemented the route and radius and compared some of those results to what we already had in the past. And so you can do that, and we would always, if we had the choice, do pilots and then spread slowly, because that's the best way, we think, to understand where the rubber meets the road and what's really going to happen with that system and get the feedback from the people who are using it on a day-to-day basis. I can design all day long on a chalkboard. When it gets to the actual floor, it's going to look totally different. And so as we implement new technologies, you can do comparisons. I'll add that we have really limited resources for doing analysis. So pretty much it's been me, and I had a day job for most of the past 20 years that I've been doing this. And so it's only recently that we've had a little bit more horsepower to do more studies. So it's always been for us, what are the things that we need to try to do and analyze that ensures patient safety and makes sure that we're using the system in the best way possible. So a lot of the analysis that I showed today was based on answering questions. Can we use this on patients that are on oxygen? You know, should we add respiratory rate instead of doing SpO2? So these were studies that were driven by questions that were really relevant to patient safety and maintaining that and having the staff have the best experience possible. And this is one of the reasons why we haven't continued to do studies of transfers to higher level of care and rescues, because we think that's a low on our priority list. We see that this is an effective system. I have 6,000 other things that I'd rather answer questions than to try to do yet another study that says this actually works to bring attention to the bedside when there's a severe event. And so, but there, you know, if you have the time and you need to show those sorts of things, I think it's always good to assess new technology when you bring it in a focused way.
Krisda Chaiyachati with Wearable. I have a complicated question that I'll try to make it simple, which is I feel like there is this tension between transparency, trust, and noise. And so the part that I'm trying to kind of relay out there is that the technology here is so complicated. And even the large language model people are just like, I'm actually not sure how it works, and it's producing those outputs. And yet there is a desire in our communities to know how these algorithms work, and yet they're changing constantly there. And actually, the more we explain it, the more noise we see on a screen or something else we have to read. And I'm curious how you guys think about that tension here across the board. And I don't know how to thread that needle ultimately to get to the trust part of this.
Yeah, I can answer. I guess I can give my perspective. I'd love to hear your thoughts too. Yeah, it's a challenge. I think you have to know. You know, kind of the intended use case of whatever, you know, machine learning model or AI-based technology, or it doesn't have to involve machine learning even, it can just, whatever the intended use case is, make sure you can meet the end user where they're at. And I mean, just as an example, yeah, I think in one of the slides on my presentation, I showed again that deterioration index, and you didn't get into the actual modeling strategy that was used and the exact, you know, the model, the exact like parameters in that model. It just showed you roughly how important were specific parameters in a model. And I think that's kind of some compromise in between having a complete black box to having everything under the sun. You'd have to be, you know, really have a very detailed understanding and a very rich data science background to fully appreciate that. I think it's somewhere in the middle there, in a way that is user-friendly, and I guess also recognizes where the limitations of the model is. It's not, you know, it's going to be a starting point. It's really challenging, I think, if you use a model again to make a fully automated closed loop decision, although that is out there. But I think giving, you know, ownership or agency to the clinician, I think is important to respect. And so in that deterioration index slide, you know, maybe what you would do is you could take, for example, your patients in your ICU census, you could sort them by how high the index is. You can look at which ones have changed overnight, and you can use that to structure how you do your rounds in the ICU that day, and which patients you might need to slow think. And that would be an example of giving the clinician the autonomy to still make the decisions that need to be made by them, but using the model in a way I think that's again leverages transparency, but again doesn't require an extensive data science training to be able to use.
Think about this in a much more simplified way. I don't code. I'm not a biostatistician. I am actually doing a master's in biostats right now, and I am not failing, but I feel like I'm failing every day. But I think about this from like when I was a child. I used to help my older brother do oil changes in his car. And I could go through and I could tell you what the pistons were, and I could show you how to actually do it, take the filter and put it in. If I open up the hood of my car right now, I don't know what 90% of the car is, but I trust it and I love it. I love that it is a hybrid, and I love that I get better gas mileage, and I feel safe when I get into the car. Likewise, I have no idea how my Apple Watch works, but you know what I look at every time after I go do my hot yoga? What did my heart rate zone get into? Because it makes me feel really good when it gets into zone 5. And it is a trust of at multiple levels. So if you're talking about the end user, is that the patient or is that the clinician? Whose trust are you trying to get? What transparency? I mean, I talked about ChatGPT and that people don't know what it is. I don't know what it is, but I know what it's not. And so when you are able to get a certain amount of information to know what you can trust and you can't trust. It is really good at these types of things, but it is not really good at these types of things. And once you have a kind of a basis for that, I think that you'll find much more engagement and much more people just willing to use it. I do not know how my hybrid car works. However, I know that it does, and I love it.
I'm going to make a very quick comment following up on this one, because I think, Michael, 2 years ago at the MPOG retreat, there was Eric Topol was here, right, in San Diego. And so he's one of the big guru of AI and big data and everything. And he was like, there was a question about transparency of AI algorithm and so forth. And he was talking to an anesthesiology community. And then his answer was, it's very funny to receive this question from the anesthesiology community, where we use a drug propofol every day. We blend consciousness for our patients. We have no clue what we are doing. Nobody knows how it's working. We don't know what consciousness is exactly, but we want to know everything about the AI system. So I just wanted to bring this up.
So I feel like this question has to be asked. Ultimately, AI algorithms are going to discover the bell curve of clinician performance. And we know that there's people on that tail of phenomenally excellent outcomes, and there are clinicians who have phenomenally bad outcomes. And I'm sure if we ran algorithms now, we could probably find out that information. And I was just curious how your teams manage that type of information, or how you choose to maybe not look into that type of information and the implications it could mean for physician training, or how we kind of police ourselves in our profession.
Yeah, I think that's a challenge. And yeah, there's this issue of your clinician self-confidence that, especially in trainees, that needs to be protected. And so it is a challenge. I can answer, I think, from in my role as a member of the MPOG research team and examining kind of practice patterns across clinicians and institutions. We will protect the identity. We will anonymize institution ID and clinician IDs in studies. And when we do a research study, we have it protected in that way. You can still understand differences in practice patterns across institutions, but you may understand characteristics of those institutions, but you won't be able to say, at least without great effort, that this is institution X versus Y versus Z. Contrast that to our quality improvement arm, which you'll hear about from Dr. Shah in a later talk. We've gone, and Jim Grant talked about it a little bit this morning. We have these CQIs, collaborative quality initiatives in the state of Michigan, where we did start with anonymized institutions again and gave you each during these quality improvement meetings that are attended by champions from each institution, we would give you kind of your anonymized ID, so you knew who you were and where you stood in relation to your colleagues. And in those meetings, it's been an evolution. There's an evolution. We've now, over the last decade of doing that, have bridged, crossed that, built that trust, and we have now de-identified at our quality meetings, which are protected. Again, we're signing waivers that what's discussed is protected information, and you're in the circle of trust. But we've gone to that, and it's all about the trust in your colleagues. And so you have to kind of gauge that, and I think there's a different answer for different contexts.
I would say that it depends. What measures are you looking at? Is it death, which usually tends to be a rare event? At least I hope it's a rare event for most of us. Or are you looking at AKIs? Are you looking I think that the quality of care or what is deemed to be the standard of quality, I think varies so much by context. If you are taking care of really, 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 really sick patients versus your colleague who takes care of really healthy patients in a surgical center and all of the patients are going home, it's very difficult to measure. And I can tell you, I haven't been an attending for very long, but my best anesthetic, I actually gave nothing, and I held somebody's hand right before they went home to die on hospice. So I felt really good about myself and the quality of care that I delivered. And I had multiple people tell me I would not have taken care of that patient because you didn't even give anything. I'm like, well, I held their hand. I gave some normal saline and I held their hand. Actually, it wasn't normal saline, it was plasma light. But I think we have to create different standards of what is acceptable and what you're trying to achieve. Maybe somebody is a great educator and is working with residents or trainees or nurse anesthetists and is helping to develop the next generation of clinicians who have empathetic care and who can take AI and actually integrate it with both. And if you're looking at the number of AKIs or how much PONV, I get a dashboard of that every month, and I know where I lie within my colleagues.
So thanks again for the talks and stimulating this conversation. One of the goals of this meeting is to try to figure out the path forward for what we're doing. And the pulse oximetry example is a good one of, I think, how challenging that's going to be. Skin tone is just one obvious phenotype variation that we can see. And pulse oximetry is a technology that's sensitive to that particular phenotype variation. But in reality, there's phenotypic variation in our populations that go far beyond what we can see or understand. Here we're developing technologies that are going to be sensitive to phenotype variations that we may not understand. I'm wondering, how do we get the wisdom to define the populations and then the resources to actually study those populations so that we're not embedding inequities in what we're doing going forward, particularly in AI, where we're using training sets to design the systems.
It's a really challenging question. I think ways that I've thought about it. I mean, again, I think the first step in a lot of again, developing new technologies or prediction algorithms is looking at specific subpopulations, and I think sex, race, ethnicity are very important. Age, but you're right. I don't know about the more subtle phenotypes. Maybe more challenging to dissect out. I don't have a really good answer for that problem. I will say I've in my experience looking at different prediction algorithms where bias, where you're at the highest risk of bias is when algorithms incorporate variables that are actions that a clinician takes. If you're trying to predict for example, if you're trying to predict a administration of Narcan or trying to predict a blood transfusion, rather than doing that and having an algorithm that will reflect back unconscious bias in those treatment decisions, predict the low respiratory rate with hypoxemia, or predict the low hematic rate. So predicting and using patient pathology, intrinsic patient pathologies in your modeling strategy is perhaps a better approach than taking actions like the blood transfusion or the Narcan administration that will either add bias in an algorithm for a research project or potentially have perverse incentives in a quality measure if you know that giving Narcan will flag you and lead to your underperformance on a specific measure. So you have to think through, I think, those things. But it's a challenging issue.
So I wish that I had the answer to that. I wouldn't be sitting here with student loans. I think I would have been able to pay everything off already. I think that multidisciplinary teams, one, again, when you get more people involved and they look at the same problem from different viewpoints, that's going to help in certain ways. The phenotype is just, some of the work that I've done is on frailty or looking at cognitive changes after surgery. And when you look at Alzheimer's disease and the vast research that they've done looking at imaging, inflammation markers, looking at predictive factors, and you can't really find the solution. We haven't cured Alzheimer's disease or dementia. But I think that a lot of work is being done in genomics right now, and actually, or the omics, where they're putting a lot of different sources of data together. And that may be how a decade from now, maybe we're going to be able to find sub-phenotypes of different types of diseases that respond to different types of treatment. But I think that we also have to just, like one of the things that you said about blood transfusion, for example, like I think about that, and it's not just the decision to give a blood transfusion. I am fortunate enough to go work at one of a very underserved community hospital a few times a month. And when I have patients there that need a blood transfusion, I can't say, oh, I wonder how many, have we cross-matched? My first question is, do we even have any blood in the hospital? Resource allocation is completely different. And so when decision algorithms look at like blood transfusion, for example, it is so easy to say, oh, it's just what the provider, like what decision did they do, but actually the resources that are available change so much how you make your choices. So my availability of having blood in the hospital for a crash C-section at a community hospital is my threshold to transfuse, or not even threshold to transfuse, my ability to transfuse is going to be so much more different than at our major, at UCLA major university hospital. And so I think that that's why we can't find all of our phenotypes yet. So skin tone, yes, we can see, but tissue density for breast cancer, melanoma, so many different things that you can't see, like delirium, dementia, frailty. I think that we just don't have good enough data yet.
Let me just ask what Jeff did a little bit different way, and you can react to it, or we're getting close to taking a break. But we humans are full of biases. So we have biases already embedded into the clinical care. So the question, although we'd like to achieve perfect AI that has no biases, is can this be an assistant, a tool that improves the care while we search for perfection, rather than throwing everything out at the beginning? And again, remember the hype curve I showed this morning, the hype was at its apex when the performance was at its nadir. So we want to continue to do this. And an example, and this kind of dates back to Dr. Spock and, you know, the Starship Enterprise, some of the things he did. But I read like a year or two ago where you could take a selfie and there was AI that you could have on your iPhone that would generate your vital signs, including oxygen saturation and heart rate variability. So the challenge of that, how you take away all those biases within that kind of technology, which is coming, is got to be immense. And there may be more people that know about this within the audience or up on the podium than I do. But I don't know if you want to react to that or take a break or.
Yeah, I think it's challenging. I think it comes with, I think the onus is, I agree with you, we should not just discard or discredit these algorithms. We should educate our clinician colleagues and other healthcare allied health professionals on the limitations. And so I think it's incumbent on us to improve our education efforts. Again, I alluded to this in my talk, just like reading an article in our medical journal assumes a basic understanding of classical statistics and statistical methodology. We should start working on teaching those kind of issues related to bias and the quality of data influencing the association observed. So those are the things I think are incumbent on us to educate our colleagues about to improve care.
Okay, I was listening to what you said, Jeff, about, well, it's patient safety, let's remember, and what's next, and so forth. And I just thought it was worth reflecting on, or my interpretation of some of what I heard in that the work at Dartmouth has proven the value of this fail-safe, drown-proofing, safety system that has limits that are not necessarily, they're not going to be useful for early detection of a subtle issue, right? That's not the purpose. And I admire the fact that for all this time, you've focused on that mission, right? That was the problem. You worked to solve that. It took you a journey through different technologies, a very relatively complex implementation because it's so difficult to connect the systems together. But ultimately, you have it and you have the data and you've proven it. That's different and a different goal than so many other things that we're talking about and we want to see. We want to see more sophisticated detection of developing problems, customization and personalization for different patients, not just different populations, based upon their issues. That will become more sophisticated given the sophistication now of AI technologies that have come so far. But most people who've spent a little time with AI realize, like everything else, it fails, and at least in this phase. And we're a long way from where we can trust self-driving cars, for example, without any humans in the loop or oversight. So even as we move and test the waters of the advanced technologies, we're going to have fail-safe. And the fail-safe could be the human in the loop, the expert at the bedside, interpreting the suggestions, the guidance of the next AI system. And that was an excellent, I think we all learned a lot in the presentation today about the nuances. So, it's not an either or that we're hearing about today. And that's what, that's the message I'm receiving, is that you need to have the backup fail-safe that's simple, understandable, not based upon machine learning, or it's inherently explainable because they're simple rules and they're based on physiology. Low sat, bad. Low heart rate, bad. And then we'll be able to do all the other things on top of that. So I think from a patient safety perspective, we should remember that we need very simple, highly robust, easy to understand, fail-safe that then will support a future of more sophisticated technology.
Can I comment on that?
We're getting real tight on the break.
Okay.
You have 30 seconds or?
Well, I just wanted to say, so once you have the fail-safe, our goal has always been to move up the time, right? So we've been working on understanding, using the data that we've collected, how can you do that? And so trend analysis. So we've spent a lot of time looking at that data, and an AI system would do what I did with that PEA thing. You choose a set of features, you do principal component analysis or whatever other thing you want to do, and you figure out which features are the ones, and you use a discriminant function, and there's a million new names for discriminant functions now than when I learned this stuff in the 1980s. But it can be a gradual implementation. So you can start simple and build trust and do little things at a time that help people understand, and before you get very complex. People understand features and feature extraction and what to do with rules. That's what rule-based systems do, and neural networks and all that stuff. It's not all that different than what you can explain to a human being. So I think that there's a pathway there. I think that moving up the time is absolutely the goal, and doing that in small ways I think would be really helpful.
So let's take a 20-minute break. About 3:20 or thereabouts. All right. Thank you.
So I have a... thanks. Yeah. Thanks, you guys. That was really super.
Great talk.
Really great.
Yeah.
So
fantastic.
I have a great...
Hey.
Oh, great. Thanks. Glad you enjoyed it.
Yeah, sure. Yeah, sure. Yeah, before I forget. Yeah. Yeah.
Always.
Do this.
So we had a nurse, Nancy Karen, who was the floor nurse where the patient died, and she was all over this stuff. She used to take her nurses to the central station every day and say, "What trends do you see?" So we've had a lot of nurses. Oh, thank you, Steve. Thanks for the opportunity. I appreciate it. So yeah, it's important. Okay, you're very welcome. Thanks.
Yes.
Oh yeah. Hi. Nice to meet you.
If you're comfortable. We were planning on it. Yeah, we want to respect that. About the data. Yeah, he probably has. Oh, here we go. Yeah. Putting it on.
Yeah.
Building some applications. Some very similar to what we're having, but this question about how you store the data. We have a platform that stores the data.
Yeah. Happy to answer those sorts of questions for you. Yeah. Yeah. Right. Right. So I'll be honest, we do have an agreement with Massimo and organizationally that for this work and using that data, we limit it to that team and ourselves. So there would not be an opportunity for us to give you our database. And frankly, it took us 10 years to negotiate with our folks at DH and Massimo to work on some of this stuff. So,
it's turned off here, right?
But I can happily tell you like how we did things. That's not a secret. And
I'll go like this, that way it won't
yeah,
move.
absolutely.
So does this
Yeah,
does this
and you
make-
can
make
do
it a
this.
fact?
There's more than one way to do this. You don't have to use pulse oximetry. You can, and now we're moving to more of a command center sort of thing to allocate resources.
Excellent.
And so evolution over time. We work with Mayo on a paper that's coming out soon, a pro-con paper where they already use selective notificate they select their patients based on a risk profile, but then they have a central monitoring people monitoring those patients and not so much the bedside nurse, right? So they have a different model and it works. So I think that there are some key features that you have to include, but there's more than one way to design it. So yeah, I don't ever do them. Yeah.
Speed up.
Yeah, absolutely. Yeah. I am not, and neither is my colleague George, who usually
Forward.
goes. Yeah.
And this is if you want to. I guess pointing and stuff's hard because you got to point in two places.
Mm.
Yeah. Okay, I'm set.
Yeah. Right.
Yeah.
So part of that time, I already have something
be
that
looking up
I
here,
promised my
so.
daughter I would do with her this afternoon. So, yeah, yeah. Okay.
So
Great.
Nirav
Yeah,
is
no.
a
Let me know.
expert.
Okay.
You know Nirav
You're very
Shah?
welcome.
Yeah.
Okay.
So
Oh,
he
good.
runs
Good.
you know,
Glad
the
to hear that.
NPOG
Yeah. Thanks.
Aspire meetings. And he has talks where he's puts himself later on, so he can either make it longer or shorter depending on where they are on the schedules. So he's a schedule modifier person. Yeah, exactly. Yeah. So I can use up all the time, and you can just come up and say, Aspire, the end.
Are you with this crew? Yeah. I'm looking for somebody. Can I just take this off? Yeah. Okay. All right.
Yeah, right.
And then it's on the.
You want me to drone on longer?
Tucked it in there.
Forward. What's the mirror thing? How'd you do this?
Absolutely.
No. This. What is that thing for?
It ends a slide down. That's probably not a good one.
I don't want to touch that.
Yeah. Just the big green. Yeah, the big green one.
The big green one. The red back one.
Oh, cool. Thanks.
Yeah. Mine are a lot of pictures, hopefully. So, Medtronic. It's, yeah, how you doing? Yeah, sure. Do a test. You're going to flip it on. What's your name? Hugo. You do good work, you know. Oh, okay. Yeah, on and off. Yeah. Old age, we forget everything. But yeah, I mean, the focus is definitely floor and home, avoiding ICU admits, avoiding hospital readmits. The end. I mean, that's a huge. That's what. He's done that his whole career. You know what is really sad is that he published several articles a decade ago on pulse oximeter accuracy and did not mention that he was with Massimo. He started doing that recently, but in the first 15 years, I mean, he's been with Massimo for 30 years. You know, that's not really. Well, I think in his mind, he believes what he's saying. But a paper is going to come out in a few months from Phil Bickler's lab that's going to refute what Parker says. In a huge data set, 160 volunteers. It says, well, no, it won't refute. It will definitely will say that Massimo is not more accurate. This went back and forth with reviewers like 4 times. There was one thing that they would not emphasize, but it's in the table, but they didn't mention in the discussion. I said, here's a blatant difference between the two devices in the data. It should be at least mentioned in the discussion. And they passed over that. I don't know whether in the final paper they take do that or not. I had to say, I'm conflicted, I won't watch by bio, bias market through Medtronic, got it. But this is the number in the table. I'm not like making it up. It's their data. So we'll see how they handle it. Yeah. I'll just tell him, sue him. I don't know. I claim ignorance, you know. Yeah. Yeah. This disclosure, this option for FDA clearance to allow you to upgrade your algorithm if you have an upgrade control plan approved by them. Otherwise, any change in the data set, any change in anything, you have to resubmit for clearance. I'm telling you, that's a real pain. I've gone through that 4 times, you know, it doesn't get easier. And it takes time. So they've had some podcast or chat things where people have been on there trying to say, how do we manage? I mean, I'm going to present the stuff that I went through, which is pretty brain dead simple. They would approve it. You show me the publication. You show me the arithmetic. You show me that it's done properly. You're approved. Now it's like, take my word for it. Blah 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 number. You know, and now they're going. This is different. This is different. Well, yeah. Yes. What I can say is that the FDA is meditating about it right now. So you should probably be involved in those discussions, you and Sachin, to help figure out something that's going to work. Yeah. FDA has nothing to do with it if you don't sell it. So the hospital can make their own, and they can iterate every month. They update every month, whatever they do. So I think probably for places like Epic, instead of making this one number, they should say, here's the software, and here's your data. You can iterate on your numbers. Because they got in trouble with that, their sepsis one that came out looking good at one place. The one at Michigan showed it was terrible. You know, they take it to another institution. And they both can be right. It's a different patient population. So, yeah, that was outstanding. Yeah, thank you. That was really outstanding. You have turned into a phenomenal speaker, just a phenomenal speaker. Well, you've hit it. You've hit it perfectly. And I think what helps is not only your practice, but you're talking about stuff you've done and you know about. Right? It isn't like you're having to make up other stuff and make up some story about it. You're just talking through what you know and explaining it to the audience. So that is really, I'm glad he got promoted. What the heck? I was like, is he a solo assistant? That can't be true. Thank gosh. Yeah, right. So about, I was used to be a board examiner, and I'd get there, and they'd see, I had George, Sachin, and Chad, all were assistant professors. They're all on the editorial board of anesthesiology. And people say, what kind of a jerk are you? You want to promote these guys? I mean, they're on the board of our main journal, and you want to, it's not the university. It is tough. We had a guy applying from Stanford, and it's like, Stanford's a chip shot compared to Michigan. Michigan is hardcore. You cannot, you can't push it. Yeah, right. Yeah, you can be just about Nobel laureate level, and if you want to go in less than 5 years, it's a hard push. It's not even worth it. They want all some. Why is this exception to all the other faculty of the history of the university? Yeah. Oh, yeah. I tell you. Yeah. We have lost some great, he's one of, we probably lost, yes, yeah. Yes, and he's a nice guy. Yes, yeah. Yeah.
Okay, good afternoon, everybody. We're going to get started in about a minute here. Maybe we can start the slide deck. Thank you. Okay. Well, good afternoon, everybody, and thank you for coming back after that break. It's been a wonderful day. It's fantastic to be here. My name is Jonathan Tan. I'm at the Children's Hospital Los Angeles and the University of Southern California. This has been a really wonderful conference today. If we think of the theme throughout the entire day, we've talked about wearables, remote data, we talked about big data and the applications within patient safety and anesthesiology. And for this third session, we really wanted to tie that loop from that slide that Jeff Feldman provided earlier this morning, where we bring it all the way back to the bedside. And so session number 3 here is about turning data into care decisions at the bedside. And we have a really nice panel of 3 wonderful experts that'll be sharing their experience and their knowledge with us today. Dr. Tremper will be talking about clinical decision support. Dr. Shah will be talking about multi-center approaches for using analytics for quality improvement at the bedside. And then lastly, Dr. Meghan Lane-Fall will be talking about implementation science, really that really critical part of bringing technology into the healthcare system. It's all about implementation and the process of going through that scientifically and ensuring that things are done well. I want to start off this session by having just a few poll questions. So if you want to bring out your phone and take a look at that QR code, we'll jump right into it. Great. Here's that first question. So which aspect of anesthesia care do you believe can benefit the most from clinical decision support? So I see some answers changing here. Looks like answer C, patient risk assessments in the lead up. Keep on going. Fantastic. Okay. So the next question, what challenges have you or your colleagues faced when implementing or using clinical decision support tools in anesthesia care? And really select all that, all that apply in your experience. I see alert fatigue really winning the here. Great. And then another question is, what do you foresee are the main implementation challenges to bringing analytic technology to the bedside? Yeah, it's really interesting to see that culture change and working technology into a system that's already established, well established, and traditional, such as in healthcare, really becomes one of the major challenges that we see. Okay, here's the last question. For the clinicians in the room, do you currently have access to patient data, including real-time vital signs and alerts for clinical decompensation on a smartphone, tablet, or portable device when you're away from the patient's bedside? Looks like a pretty close 50-50 or 55-45. Okay. Well, we're going to kick off this session with Dr. Kevin Tremper, if I can invite him toward the stage here. Dr. Tremper is a professor of anesthesiology at the University of Michigan. He was also the previous chairperson at the University of Michigan Department of Anesthesiology. He has a long and established CV of well over 300 publications and founder of AlertWatch, which he'll be sharing some of that work here during his talk on decision support. But I think one of the most impressive things I've seen from his work and his legacy is really the amount of effort and leadership that he's put within his own department to build up analytics and informatics. And you see that in many of the younger and mid-career faculty now that are here at this conference and around. So without further ado, thank you for being here, Dr. Tremper, and the stage is yours.
Thank you very much. I'm going to take credit for Mike Mathis and Nirav Shah to follow. First, my disclosures. I am have some decision support software patents. I was a founder, president, inventor, equity holder in AlertWatch, University of Michigan startup company. It was acquired by BioIntelliSense. They're a company that makes a little sticker, transmits vital signs for 30 days. AlertWatch is the display, and it's marketed through Medtronic. Most of what I'll be talking about is the OR, but it's being applied through this sticker in the display to floors and home. And everybody's sort of focused on where the real danger is when we take them out of the ICU or we send them home. Approximately 1 in 50 surgical patients undergoing open procedure will be dead within a month. Now, that's open procedures, but the data suggests that, as was reported earlier, about 190,000 cases a year, which would put it the third leading cause of death in the United States, is perioperative mortality. Now, if we did everything perfect, we wouldn't cut this in half, but we may cut it down a bit. Even more discouraging, though, is maternal mortality, which the rest of the world seems to be getting better, and we seem to be getting. Now, recently the data has gotten a little better, but still, for industrialized nation, it's pretty abysmal. So I'm going to talk about decision support in sort of 3 levels, and 3 levels of sophistication. The first is decision support that's based on calculations and alerts. And these are things that are done live, but you could actually do them yourself if you had a calculator and somebody helping you do it. They're the farthest from AI. They're just brain dead. I'll talk 3 examples. One is this I&O balance. I mean, it's just arithmetic, but it's very hard to do live while you're taking care of a patient. The next is escalating alerts to help us follow the protocol. So we have protocols. It's very easy when you have a problem to have a committee, develop a protocol, implement it, roll it out. It's very hard to follow it. I mean, it depends on, very frequently the people that make up the protocol aren't the ones that are having to do the protocol. And virtually it falls on nurses most of the time. And they actually have another job, taking care of the patients. So sometimes following the protocol can get in the way. And this hopefully another form of decision support can help. And the last time it's machine learning, which we've learned about. So I want to, since I got the stage up here and you invited me, I'm going to talk about my favorite subject, me, okay? So how I got to where I am is sort of just fell into things. In 75, I was a graduate student in engineering, and I met a guy, Irv Fatt. He was one of the developers of the soft contact lens, used to be glass. And he and his colleague, San Francisco, John Severinghas, said, if you like to apply engineering to medicine, you should go to medical school. And you should probably try to work on non-invasive oxygen monitoring. So they basically said, this is a 1975. That's what you should, that'd be a worthwhile project. Finished medical school, and then I wanted to apply some of these techniques in humans. And so if you want to work on monitoring outcomes on sick people, come work in my ICU. That's been Will Shoemaker, and I worked with him for 3 years. Then I got to Michigan, and I got some money to develop a system, and I said, if you want to collect data from clinical data, make an AIM system. So I recruited Mike O'Reilly from University of Vermont. He was doing liver transplant anesthesia, and I said, look, I need a partner to help me develop a system. Would you do that? And on our third try, we went with one company, failed, the second company failed, and we finally went with this little startup company called SEC, run by two brothers, Vic and Sachin Kherpal. And Sachin was the programmer, Vic was the president, and little did we know after 8 months into the project that Sachin, during the day, was a medical student. And nights and weekends, he was writing all the code that we were doing. We got the data in and from the OR and said, if you want to do large observational research to determine perioperative risk factors, you need more than one institution. We were doing observational studies. It was single center Michigan because we had the data from the information system, but it really is just our site and there's so much variability. So we started MPOG with Sachin, Nirav, and Mike Mathis in a group. It's a huge group now, statisticians and data science people. Finally, if you want clinicians to know where, when, and which patients that these things apply to, you have to have something that's live, supporting them at the time and point of care when they need to know it. And that's when I started working on AlertWatch. Other part of this, my father was a test pilot. He got me flying this little plane, J3 Cub, 65 horsepower, 80 mile an hour, top speed and still air. Don't fly everything you can't land on. It's hand starting, so you were going to land. So following anesthesia and aviation have just followed each other incredibly, actually. And this is these are the crashes in commercial. This is per million flights, so about 10 per million, and then they plummeted, got tremendous improvement. What happened here? They started the FAA. They started looking at crashes for the first time. Add 30 years, you've got ASA standards, and this society starts. So we're following them in their footsteps. What happened here? That they were 1 in a million crashes. You say, what? Wouldn't you be satisfied with that? I said, not if you're the pilot. And they have an enlightened self-interest. They're actually on the crashing plane. So they wanted to make it better. And what they did is they changed the cockpit from this multiple gauges to the glass cockpit. First in military and then in commercial, and now in everything has a glass cockpit with a primary flight display. You'll see it when you look in there. Blue sky, brown dirt, yaw, pitch, horizon. Not that many numbers in there, but the alerts will come up in the order of importance to be addressed by the pilot. So they focus the pilot with tons of data coming in, but focus them on what's important at this moment in time. So trying to follow that analogy in 2007, a while ago, I wrote this on a piece of paper and I took it to an engineering master's student. She had free time. She was going to go get a job at Epic, but she finished her work in March and I said, can you make this into a thing with like moving lungs and beating heart? And I want to have inputs from the EMR, et cetera. So, and hey, why don't you add red, yellow, green? I've always liked that. Red is bad, green is good. And then there's that little did I know yellow would be a big problem. So automated calculations to improve care. This is doing stuff. If you were back with me, 16 years ago, you said you're in the OR. I used to do INO balance all the time. As a UCLA resident, you had to just keep a track of it. And nobody does it anymore. But why should you? It's in the record, it should do it automatically. So let's do automatic calculations. Pulling the data from the EMR, the record, the laboratories, the flow sheet, which we call the AIMS, and the HMP information for comorbidities, and put it into one display. And 4 years later, we had a prototype. I said, well, okay, let's see how it worked. Let's do a study. So I go to the IRB, and my study was put it on for 2 weeks, turn it off for 2 weeks. On for 2 weeks, off for 2 weeks. See if it makes any difference at all. And the first question, some guy, he was from the engineering school, I don't know why he was there, he said, is this FDA cleared? I go, of course not. What do you mean FDA cleared? Epic's not cleared. Cerner's not clear. Why would this be cleared? He goes, well, I think it needs to be cleared. I go, well, or turn it on and on and off, and then get consent from each patient before they go to the OR. So I'm going to say, we developed a safety system. We don't know how well it works. Can we turn it off for you? And get everybody to sign that. First of all, we couldn't even turn it on and off by patient. We couldn't do that. So little did I know, 2011, the FDA had the Medical Device Data Systems Act, which classified software as a medical device. And this is clearly an MDS Class 2 device, because below, regulated devices are software that functions to analyze, interpret, and do calculations. And that was the whole purpose of it, was doing calculations live. So that was a problem. So I've looked at the FDA documents. I am not a reader of that type of information. So if you want to get some up-to-date information, they published something in last fall, September 2002, which is really a great coalition of all the stuff you need to know. And the title of this document they published is, Your Clinical Decision Support Software is a Device? Yes, No. And they gave examples of it. Asked 4 questions, examples, and the final answer was, if it has risk scores for disease conditions, probability of disease conditions, or time-critical calculations inputs, it's a device. It must go through clearance. So this is like, great. This is going to be a problem. So studies on hold. I went to the business school because what do I do now? And they said, oh, we'll get some patents for you. Don't worry about that. I said, that's great. I said, I got to run a department. They said, we'll find a CEO for you. Don't worry about that. And I said, well, I need some money, don't I? And they said, you find the money. So they were going to put up, and it's even worse than that. We got 4 patents, talked to the lawyer, it was really great. After he started the company, they said, okay, it's $86,000 for the patent attorney. I go, what? You didn't tell me I was going to have to pay for that. I would have talked way faster. I would have, geez. Anyway, 5 years and $500,000 later, got FDA clearance for this sort of device. So the general layout is that, this is the patient icon display. This is the yaw pitch of the plane. A little more complicated to get, icon for each organ. These are demographics over here, INO balance and alerts on the other side. So I'm going to go through 3 examples of this and a 4th one from OB. So it either can be a patient display or it can be a heads-up display, basically a flight tower. And this is what WashU has done. WashU is a little surveillance room. They're watching all the ORs. They have a very sophisticated version. They watch and they randomly call into the room if they see a problem. Anybody familiar with that? Their act fast ring. Anyway, it's really pretty amazing. I was curious. So they randomly, if they see something funny, they put down what they think's going on, what they would do, and they randomize whether they call the practitioner and say, start discussing this. I go, well, how did they take that? I mean, somebody's like calling you big brother, super big brother, and they say, well, they liked it. They were lonely. Nobody talked to them. So it was like, they weren't so surprised. Didn't take it poorly. Okay, so for an INO balance, it's pretty simple. 4-2-1 rule, fluids in, fluids out. But we wanted to give INO fluids relative to the person's blood volume. So how do you get a blood volume assessment? It's hard to see it here, but this blood volume is 3,810 cc's, estimated blood volume. So where did that come from? 1962, Nadler, this physiologist, did an incredible study on radiotagged red cells in volunteers, women, men, short, fat. And then for the validation cohort, he did another with radiotagged albumin and another study with radiotagged red cells. So it was incredibly well done. So they don't do things like that anymore. But it was so old that he said to fit the data, he had to use an IBM. He didn't use a computer. He sent the data to IBM because they had an electronic computer, to do this. So that's the equation in there. Height cubed times weight plus a factor. So then I thought, well, if I know the crit and I know the blood volume, and all of a sudden I put in 500 cc blood loss, I wonder what the next crit will be. I could give an ongoing sort of estimated crit. So there's this guy, Jeff Feldman, did this study in 1995, and the big fad then was take the blood out, hemodilute them, because the blood you get from the blood bank could be contaminated with HIV and who knows what. And then you give them their good blood, keep it in the room nice and warm, platelets working at the end of the case. So he has this equation that he developed here. So I stole it. I never told him this. And I ran it backwards. And instead of saying, here's the initial crit and here's the final crit. So I know the blood volume. I put in the EBL from the surgeons, what they lost, and I calculate estimated crit is crit over E to the EBL or EB plus blood added. So that's another example. Another one is blood pressure. It's amazing. We started blood pressure in 1906 on that first blood pressure. And it was about 100 years later that the first paper came out and said it may affect outcome. And Sachin did a paper on that looking at the RCRI, Leeds Revised Cardiac Risk Index, that has all the preoperative characteristics and post-op. That study, 99 circulation, didn't use any intraoperative data because they didn't have it. So we said, let's redo that with intraoperative data. And one of the factors he found was heart rate tachycardia over 100, blood pressure below 50 for 10 minutes, or 40% drop for 10 minutes. That was followed a few years later by this study at Walsh, the Cleveland Clinic, which everybody's probably familiar with, that basically showed that for troponin rise over here, creatinine rise over here, for kidney injury, cardiac injury, this is cumulative time, 10, 15, makes 25, plus 10 makes 35, cumulative time under that pressure. And this is 75, 70, 65, 50. When this came out in anesthesiology, it had gigantic 55 on the front of the journal. And Walsh said, it should have said 60, or maybe even 65. But so that's easy to do for the computer. You just hear this, as soon as you get to 10 minutes, it just stays up there, red alert. You're now at 12 minutes, you're at 15 minutes, you're at 25 minutes, you're at 30 minutes. At some point in time, you go, well, this person may be at risk for postoperative problems. They've got like 34, you take over a case, they've been 36 minutes below 60. You can adjust that metric. There's a little adjustment bar there to make it below 65 or below 70, wherever you want it to show. So actually, another shout out here to Mike Mathis. He did a follow-up study on this saying, does it affect how sick you are going into the OR? Correct me if I'm wrong, Mike. Anyway, so if you're super sick, very sensitive to renal injury. If you're not so sick. So these are 4 different risk categories: super sick, medium sick, not so sick, healthiest of the sick. These are all patients admitted to the hospital. They all got creatinines drawn post-op. But amazingly, the not so super sick ones down here were unaffected by hypotension, and these are very affected by hypotension. So a little more than just one pressure fits all. So we went back into this study. This study was published in Anesthesiology. This is a terrible study, and the editorial written about it focused on what a terrible study it was. I knew it was a terrible study. It's retrospective, one mark against it. It was user versus non-user. So it was user selection. This was in there. Faculty or CRNA could pick it up and look at it, or could they not pick it up? So we knew some of the people, the application was never brought up. So we know the non-users for sure. The users that brought up, we don't know if they ever looked at it. It's on a separate screen, but their next trip to Hawaii or their whatever. So I'd say that the users were probably at best 50% users. The non-users were truly non-users. So we looked at several outcomes in 26,000 patients. These are all patients expected to be admitted to the hospital for 2 days or more. So they were in big cases. There was some process measures. There was less hypotension. There was a more consistent crystalloid. Tidal volume fell within 6 to 8 cc's. The primary outcome measures are going to be, is there less troponin and creatinine bumps? Not really. They were really different. But there was a length of stay from 6 days to 5 days and encounter charges of less 3,600. But that kind of got lost in what a terrible study this is. Dan Susserman used to be best friend. So escalating alert. So this is the first level of decision support. It's doing calculations you would do if you had time and a calculator. It would be painful, but you could do it. This is the alerts for protocols. So we had 2 near miss OB events close by each other within a month or so. It really, when you have a near miss event in OB, it's frightening. And so they saw the alert watch. They said, could you make a version for labor and delivery to watch the mothers? So we got Tom Klumpner is one of our OB anesthesiologists, computer groupie. Now that's usually a contradiction in terms. No offense to OB anesthesiologists, but the computer group is usually ICU or part cardiac. They're usually not OB, but he's very talented. So this is labor and delivery, 50 rooms, same kind of layout. This is a surveillance room. In the dark, this is triage, antepartum, yellow active labor. This is pushing. This is phase 2. They're fully dilated, and this is postpartum. So there are two things that cause maternal, the two primary causes: late detection of postpartum hemorrhage and late detection and poor treatment of preeclampsia. Those two things. And the NIH says 50% of these, at least 50%, are completely preventable. So to have a woman in a hospital with an IV bleed to death, just doesn't seem like it should happen. It's like dead in bed. But and this is the most depressing thing. A dead child is not as bad as a dead new mom. I mean, you look at the impact is just earth-shattering that if a mother dies in the hospital. So with these two events, we got forward in doing this. So the user interface looks the same, kind of, but it's got a little baby in here. And these are demographics, gravity, parity, et cetera, progress of labor. And there's a series of alerts. So the first alerting thing we wanted was there's ACOG PPH risk factors. And there's a list of high risk, and there's a list of medium risk. You have one of the high risk, you go into a high risk group. If you have two or more of the low risk, you go into a high risk group. And green is good, yellow's okay, red's bad. Orange means comorbidity with that organ. So this organ, uterus, has orange around it, means it's a comorbid. That woman has gone into a high risk group. And these are the list of ACOGs, one of these or two or more of these. Some of these are, the nurses are supposed to assess this, right? So one of these has been on oxytocin for more than 24 hours. So they're supposed to go and try to figure out when did they start? Do I know if they had a risk factor? These are literally impossible for the nurses to do. They try to do them once a day. They prefer it once a shift, but it's really, they're taking care of patients. So to look at these and try to see which ones they triggered. So it's all in the medical record. We know when the oxytocin started, we know when it is 24, boom, or high risk. As soon as it's high risk, it looks at the IV size of the mom, needs to be 18 or greater, and sees the blood bank to see if there's blood for that woman in the blood bank. And if it doesn't have either one, it puts an alert. Consider type and cross, or type and screen at least, and get an IV size. So this one has an alert that says, oops, PPH risk, put an 18 gauge or greater. I don't know if you're up there. We get people that are, the biggest concern of anesthesia in our unit has been, why didn't they call us sooner? Or they're really giving a unit of blood on the floor in a 22 gauge IV. I mean, so we try not to get upset. I go, OB training, my wife's an OB, I love OB, I love her, but they did 0 months of critical care, 0 months of critical care, at least in our institution. So if a first year resident, if they see somebody that looks sick, it's like I see dead people, if you think they're sick and everybody else is just dancing around, they're sick. Don't be distracted by all the happy thoughts. It's like our OB is 50 rooms with like 12 simultaneous weddings going on. Everybody's happy, excited, new grandparents do. But when they turn sour, they go sour fast. The other thing is the use criteria, maternal early warning criteria. This is heart rate, blood pressure, a bunch of criteria. It's like for the floor, but this is for OB. And they're supposed to escalate care, whoever the escalator is, but frequently it's a resident or an OB resident or a physician when they meet these criteria. So we ran through the criteria and the number of calls would be astronomical if they just follow that criteria. So we said, we can't just follow those criteria per se. So what we did is we added shock index. This is shock index. This line is when the delivery. So during phase 2 active pushing, we're not worried about triggering any alerts. The movement's pushing, there's people in the room, so don't trigger anything. To hold all alerts, as soon as they deliver, activate all the PBH alerts. So the first study of this is the, looks complicated, but this is the metric algorithm that they'll go through, the machine's going through to determine who to call when. Hypotension for the OBs wanted hypertension for preeclampsia, tachycardia, shock index. We threw in anemia. We thought if the blood comes back with a crit 18, somebody should know, and shock index, which at that time wasn't part of it. And the FDA pushed back on this. We had to reapply to get shock index. Later studies have come out that it's a very useful variable. So we promoted it. We used a filter. This is like the best filter ever, the nurse. So if there's an abnormal vital sign, automatically pages the nurse for that patient and says, please recheck this. If they recheck it within 5 minutes and it's okay, all's good. If they recheck it and it's not good, physician's automatically called. If they don't recheck it, they're paged again. If they don't recheck it then, physician's called. So they know that if there's a funny vital sign, they now are just taking it again because they know there's going to be a physician waking up. Now, when we looked at the past outcomes, usually a junior nurse is given the worst shifts. They're relatively 2 in the morning, whatever, they said, it's not that low. And they just wait a little while. They're hesitant to wake somebody out in the middle of the night. Somebody yelled at them or whatever. But this actually eliminated all yelling. They could yell at us, but it's the computer. The nurse didn't page them. The computer did. And it's by an algorithm that the OBs agreed to, the nurses agreed to, we agreed to. We all agreed these are the things that should call a physician to get to the bedside to assess the patient. So all the emotional who to wake up when is disappeared because it's the computer. They could blame me. I told them to bring Klumpner. He's the one that designed it. I was just a bystander. And they get paged. Now that's phone, but they just get paged. Shock index, repeated, go to the patient's bedside. So we looked at the criteria. What happened with the number of pages? So these are for blood pressure, low, blood pressure high, heart rate, and these are the Muse criteria. This is in 24 hours for a 50-bed unit. There were 150. There was a page every 8 minutes. If the nurses follow the published criteria by maternal early warning criteria, every 8 minutes, a doctor would be paged. You can see why they're not doing that. So after we applied the don't set off alarms during active pushing and after you deliver. And then this nurse recheck, the physicians are paged every 6.3 hours. The nurses are paged 47 times a day. That's 50 nurses. The nurses are paged every 2.5 shifts to get 1 page. So the nurses themselves, every individual nurse, they're getting paged about once a day. So they were not upset with it. The OBs, residents who got paged the most, were most happy. And we did a survey, OB, anesthesia, nursing, and the question we said, made it simple. Should we keep this? Should we throw it away? 84% said keep it. I've not gotten anything with 84%. OB residents, 100% said we need this. Do not, and they're the ones that page nurses. We got the bad comments were from family practice faculty. What was interesting is they weren't even in the paging algorithm. They never got paged, and they hated it. I was like, what's with them? So we compared, the final was look at the outcomes. So we called severe postpartum hemorrhage was 4 units transfused, 2 units plus FFP, return to the OR, hysterectomy, uterine embolization, admit to the ICU. Those were criteria that we called a severe hemorrhage. We looked at 7,800 deliveries. We had 120 severe postpartum hemorrhage events, about 1.5%. And the, you can read this, probably too small. But we compared nursing criteria. That's it. So they followed the early morning criteria, assuming it was done perfectly, 24/7. They had a positive predictive value of 3.3%, and we had 5.1% on our modified one. And probably because we threw in shock index and low hemoglobin. So in addition, there was, these are the criteria, 5.1 versus 3.3 positive predictive value. There were, of the 120, there were 10. These were pages that went off before the patient was taken to the OR. So they were alerting pages by either alert watch system and or the what would have happened if they had the regular use criteria. But there were 10 that were completely missed by the use criteria, which were kind of surprised. Okay, last but not least, alerts that could not be determined. This is machine learning. I have a little bit on this, but not much because Mike Mathis has done it all. So on this section, I'll just jump through and you imagine what Mike said, stuffed in between here. Only example I have is Epic's sepsis model. We got a study at Michigan, said it didn't work so well. Another place said it worked pretty well. So it goes to show if you make a model on one institution, you can apply it to another and get a different result. That's the problem they were talking about. Patient population, timing of the data set, and the algorithm will change. So this is causing, I think, a major concern with the FDA. Because AlertWatch has gone through 4 FDA clearances. Every time we make a change, every time we take anything, we had to do colorblind testing. Colorblind testing, oh my gosh. Then we had 4 months to get them to approve yellow. They said, show us the published data on the yellow range. I go, well, there isn't any. Like American College of Pathology, these are all the, unless there's a published yellow range, you can't do it. I said, I said, you drive a car, right? You know that middle light? We could just take that out. I think it would be worse. And they all of a sudden, after like 4 months, they just said, okay. Like, anyway. This is really causing a problem. They've had several meetings. They've online things you can get into that you hear about their discussions of how they're going to manage AI-driven alerts and risk factor assessment. Because their whole system is based on give us the data, show us the publications, show us the calculations, show us the results. For AI-generated alerts, you can do the same thing, but once you have one data set and you have one number generated, that's the one you're stuck with. And then you add newer data, then you have to go and get another clearance, which would be tremendously expensive and time-consuming. So they have this thing they call predetermined change control plan. So that will be what people need to do. When they're sending in their first clearance for their deterioration index, they said, and this is our change control plan, what we're going to do. And they're actually pretty good at it. They'll do, check you, they'll have an audit, but they're giving you an opportunity to allow us to improve at a much quicker pace, given the amount of data and the technical capabilities. So my opinion of the issues are not insufficient analysis in machine learning, because I think we're going to manage those problems well. It just takes time. Currently, it's insufficient, accurate, high-resolution data. We did a study predicting COVID patients that need intubation, and we found a really good predictor. The biggest predictor was SpO2 to FiO2 ratio, the made-up FiO2, the 0.21 plus 0.04 per every liter of oxygen. Fake FiO2. But that data was collected every 4 to 8 hours, highest frequency. So what we've been talking about today, where data will be coming in live from patients, will make a game changer for all this. So thank you very much for your time. And I think that's the end here.
Thank you very much. Thank you very much, Dr. Tremper. I'd love to invite up Dr. Nirav Shah. He's an associate professor of anesthesiology at the University of Michigan. He's also the QI director of MPUG and also a program director for Aspire, which you've heard a little bit about earlier today. In his role, he oversees the quality improvement efforts of over 60 institutions for their quality improvement using MPUG. And in his spare time, apparently he's the Associate Medical Information Officer of the hospital. So thank you for being here today.
Thank you. Thank you. Thank you. Good afternoon, everyone. It's nice to be part of the Michigan Mafia here. Dr. Jim Suchek in the back, who was present during my first anesthetic, my first day of my CA1 year. Mike Mathis, myself, Dr. Tremper, who I guess I'd make you the godfather, and several others who went to Michigan Medical School as well. So pleasure to be here with all of you. I want to thank Dr. Tan for inviting me and the organizing staff as well. It's been a really impressive conference today. I've had an amazing experience. It's my first one as well, like for many of you as well, and certainly will not be the last. I know that I'm the penultimate speaker. I'm glad they saved the best for last. I have 3 things that I want to talk about. Hoping to be done in about 20 or 25 minutes or so. I'll leave time for Dr. Meghan Lane-Fall and some questions as well. I know many of you are familiar with MPOG. I'll spend a few minutes talking about MPOG infrastructure to catch folks up for those that are not as familiar. Really want to spend the bulk of my talk on our methodology for multi-center QI. MPOG does a bunch of other things. For the purposes of this panel, we'll talk a little bit about QI. And then finally, I want to highlight some challenges and opportunities, hopefully to set us up for a robust discussion afterward. I'd love to hear some thoughts from folks in the audience about things that you consider to be opportunities or challenges for MPOG as well. My disclosures, I don't have any personal relationships, but my institution does receive funding on projects for which I am either a PI, COI from several different sources, including Blue Cross Blue Shield of Michigan, from which you heard earlier from Dr. Grant, who I think is now on a plane. MPOG infrastructure. As many of you know, MPOG has a dual mission of research and QI, founded 15 years ago by Dr. Tremper and Sachin Ketterpal, really to help conduct multi-center observational analyses, initially for sites that had GE's anesthesia product centricity, and later, subsequently, in around 2014 or so, the same folks started to realize that, hey, this data can be used for quality improvement as well. 15 years or so later, we're about 80 or so now hospitals around the country. We have a cluster of 35 hospitals within the state of Michigan, primarily because of the support we received from Blue Cross Blue Shield of Michigan. And we'll talk a little bit about that later as well. MPOG aggregates data from a range of data sources, primarily the electronic health record. We grab the minute-to-minute physiologic data from the monitors, laboratory and diagnostic data, clinical care data like medications administered, inputs, outputs, staff information, intraoperative events, administrative data like discharge diagnoses and pro-fee billing codes. We also integrate or connect with registry data as well and have a separate pathway for that, both at the local level with registries like NISQIP or STS, and at the coordinating center as well with registries like MSQC or MBSC, which are some of the other CQIs that you had heard Dr. Grant talk about earlier. Most of the minute-to-minute physiologic data is the immediate perioperative period. So about 4 hours before anesthesia start to 6 hours after anesthesia end. I think that highlights already some of the opportunities as well as some of the challenges and limitations of MPOG. MPOG is structured in a very specific way. Fundamental premise of MPOG is that the data is owned by and controlled by the institutions who participate in it. The source data is extracted to a database that exists within local sites or local institutions' firewall. There's processing done at the local institutional level, including the removal of PHI except for data service. It's called a limited data set. And then that data is transmitted to the coordinating center, currently the University of Michigan. The data then lives within U of M firewalls, where MPOG conducts a bunch of computational analyses. We'll talk a little bit about that as well. And then, we use it for quality improvement. We use it for observational research trials. More and more, it's being used as the platform for pragmatic clinical trials and other things as well. But the fundamental storage and computational analysis occurs within the Michigan Medicine firewall, within Michigan Medicine data centers, and then is then shared back with our sites in a limited data set format. The approach for MPOG, so the slog of MPOG, the dirty work, the hard work that's been done over the last 15 years is taking raw EHR data and turning it into usable information. So we take variables like medications administered, like the minute-to-minute blood pressure information. We asked our sites to conduct validation on that data using some specific tests that we call data diagnostics or case-by-case validation. And then when they send it to us, we do some additional testing on it, some additional computational work on it that we call collation mapping or answer mapping. We build digital phenotypes, or computed phenotypes, which I'll describe in a little bit more detail. And then once we take, that raw data, the bricks, build it into walls, then we can build houses, which we call performance measures and other usable clinical data. That process started a decade ago with maybe our first dozen or so phenotypes. Now we have about 500 phenotypes. It's really what makes MPOG data usable. It's really the hard work that's being done at the local site level to ensure that clean data is being sent to MPOG, and then by our coordinating center team to ensure that that validated data is turned into actual usable digital phenotypes for both QI and research. So one example, I stole this slide from Mike Mathis. Another way of looking at it is that raw EHR data like ICD codes, like lab information, like demographic information, professional billing information, laboratories, other testing, that kind of stuff gets computed, that kind of stuff gets organized in a bunch of different ways to then turn out information like, was the patient under a general anesthetic or was it a MAC or was it a regional case? It lets us know what the baseline blood pressure is. It lets us know, for example, when bypass happened. What's super interesting is that if a person were to look at an individual electronic health record, it's pretty easy to determine some of those things by sifting around the electronic health record. But asking a computer to do it across 80 institutions, across every single case, millions of cases now, tens of millions of cases now, takes a lot of not just computational horsepower, but actually takes a fair amount of work at the coordinating center to design the computer algorithms, design the specifications for the algorithms to make sure that when we build a measure which excludes cardiopulmonary bypass times, for example, or excludes cases for patients who underwent cardiopulmonary bypass, we do it accurately. And really that, I think, is what makes, from a data perspective, MPOG. We'll talk about some of the other things that make MPOG in a little bit, but from a data perspective, it's really this validation, this cleaning of raw data into usable digital phenotypes. A classic example for us that we share over and over with our sites is something as simple as ASA class. You would think would probably be 12 different values, ASA 1 through 6, E or not. If you look across all the hospitals in MPOG, all of our institutions, there's actually 4,120 different ways in which ASA class is documented. And so we do the work on our end to turn that into those 12 values that we are all familiar with. And then multiply this by the 1,000 or so variables or concepts that we import from any given site. You get a sense of some of the work that happens at the coordinating center. So that's a little bit about MPOG infrastructure. I'll spend the next few minutes talking about our QI methodology. Pillars of MPOG QI have not changed over the last few years, built on the QI measures that we've developed from these digital phenotypes. We now have about, this is a little bit over 60 plus measures, multiple anesthetic domains of care, both process as well as outcome measures. We benchmark them as part of our feedback mechanisms, both nationally as well as locally. At the practice level, we provide individual provider feedback, typically monthly, that's benchmarked locally. And we try and link measure performance to the actual case. I'll talk a little bit about that in an upcoming slide. The quality committees are the primary governance mechanism of what to do and how to do it. They provide a check step. They provide feedback, guidance, best available evidence or expert consensus as well. Those committees meet at various times across the year, both in person and virtually as well, and comprise both our Michigan sites, so our cluster of sites in Michigan, as well as our sites from around the country as well. And then finally, an implementation component as well, where we take bundles of performance measures. We take what we know about implementation. I'm sure we have a lot to learn from folks like Dr. Lane Fall and others about implementation science, but we take what we know and what we have, and we build toolkits. We visit sites, especially within the state of Michigan, to learn from them about how they've used MPOG QI measures and how they conduct their QI projects. And then we have some programs as well that we've launched in concert with Blue Cross Blue Shield to provide some financial incentives for sites within the state of Michigan. Measure building typically starts with an idea generated from one of our sites, from one of our anesthesiologists or our CRNAs, from one of our subspecialty committees. Those measures then get discussed at our quality committee. And then internally at the coordinating center, we'll come up with a measure specification. We'll detail the rationale for the measure based on feedback from the quality committee, inclusion and exclusion criteria, markers for success, thresholds, limitations of the measure, and then that measure would then be approved by the quality committee by a vote. Majority vote typically signals for us that we should go ahead and build the measure. The measure building is done at the coordinating center level. So we have teams of nurse informaticians, statisticians, data scientists, project managers, faculty, who work together to build the measures based on feedback from these various sources. We test it and refine it. We do the validation for it. Many times we reach out to folks at your institutions who are members of MPOG to help us with that data validation, and then we publish it to our dashboard and add it to our provider feedback emails based on the direction from our sites. And we rinse and repeat. And this has really been our measure building and publication methodology. Importantly, all of our measures are reviewed at least once every 3 years. So every 3 years, we have a process in place to review measures, make sure that it reflects the best available evidence, either modify the measure, keep it as is, or most importantly, retire it if it no longer applies. And as we talk a little bit about some of the challenges that MPOG faces, we'll talk a little bit about that process as well. So as I mentioned, we have now over 60 process and outcome measures over a variety of anesthetic domains. They initially started in highly clinical domains like glycemic management, neuromuscular blockade, blood pressure management. As MPOG started to get more data related to patient outcomes, we started to build measures related to mortality, PONV. And then as the subspecialty committee started to become really engaged, we started to build measures along subspecialty lines, like OB anesthesia, cardiac anesthesia, pediatric anesthesia, which has a very robust program. And then more recently, moved into population health measures as well, either from national experts like Jody Sherman, who gave a talk at one of our MPOG retreats a few years ago and kind of inspired us to build out a sustainability bundle. Or sometimes the payer, Blue Cross Blue Shield of Michigan, which had a statewide focus across all of the quality improvement groups on smoking cessation and smoking cessation counseling, asked us to build some measures related to smoking cessation in the perioperative time period, and we did it in concert with them as well. So it really crosses a range of different anesthetic domains, a range of different population and public health measures. That is one of the opportunities when you have a really broad data set. It's also one of the challenges. Focus, continues to remain a challenge for us, and it's one of the things that we, I think are looking for guidance on and a position on as we continue to grow. A core part of MPOG QI is the individual clinician level feedback, and this is an example of our monthly feedback email that I get, that many of you get around the country. We send it to about 8,000 folks or so around the country on a monthly basis. It's typically reflects last month's cases. It's meant to serve as a link between your performance and the case that went into causing that performance. And so if you click, as an example, if you click on this train of 4 measure performance, you can actually get to MPOG's representation or MPOG's version of the anesthetic record. And the thought is that you could take that measure performance and look at the case to see how you arrived at that measure performance. And the philosophy is that looking at the actual case is that moment of practice reflection, and potentially can cause practice change if needed, or can also be an opportunity to let your quality champion or MPOG know that something is wrong with the data, for us to be able to fix and look at from a data quality perspective. And really, understanding or enabling clinicians to understand why cases did not pass a measure, I think, is the kind of fundamental component of the individual provider feedback level. Also, lucky enough to have participate in a program with the ABA to enable MOCA or award MOCA credits for following this process as well. And so trying to have multiple uses. At the practice level, quality champions, quality leaders, practice leaders can use this as a snapshot to look at departmental performance across the range of measures that MPOG builds. You can also use it to look at outlier cases as well. So you're able to drill down at a specific case level or at a specific provider level as well, to be able to see outliers or exemplars in your institution as well, and to enable either QA or QI projects. The same benchmarking, similar benchmarking that's available at the provider level locally is available at the national level institutionally. And so for practice leaders, we show them a institution's performance on a measure compared to all the other institutions within MPOG. We can also show them performance comparisons within an institution as well. So if you want, for example, at Michigan, we can show performance at different locations across the University of Michigan health system. And because we have a broad data set, we can do interesting comparisons, like for example, the variation in use of sugammadex and neostigmine across MPOG sites. This was the result of a question from one of our sites a couple of years ago, and so pretty quickly we were kind of able to almost kind of stunningly see that there was really wide variation in the use of sugammadex and neostigmine. I think this was 2022 data, maybe about a year and a half or so ago, where across MPOG sites, still had a bunch of folks that were primarily on neostigmine, also had a bunch of folks like Michigan that were primarily on using sugammadex as neuromuscular reversal. So you can do kind of some interesting analyses with the data that we have. So I will toot the horn of some of our Michigan sites. I did want to share some of the work that we were doing within the state of Michigan as part of the CQI program. This is one example. So we built a measure looking at temperature outcomes or hypothermia in our patients several years ago. We released that measure nationally in 2 our Michigan sites. We discussed it at our statewide quality committee meetings that Dr. Grant had talked about earlier this morning. What's super interesting, Mike alluded to this as well in his talk, and in the panel discussion afterward, is that the data is necessary with these meetings, but it's not sufficient. And so what you actually need to make any progress in any quality improvement initiative is trust and collaboration. Multiply that like 10-fold if you're doing it across centers, and 100-fold if you're doing it across competitors as well. And so over the years, we've had to build in systems where folks, you have to drop the fact that Beaumont and Henry Ford are each other's throats at the competitive level, at the institutional level, but at the provider level or the, at the anesthesiologist or CRNA level, we are just trying to take better care of our patients. Establishing that culture and the mechanisms for that, I think, has been, maybe the hardest part of what we do, what we've done within Aspire, within our state of Michigan group. But you can look at some, kind of, I think, some pretty impressive statistics for like cutting the rate of post-operative hypothermia in half. This is all unpublished data that we shared a few months ago at our meeting. If you look at adherence to our hyperglycemia measures, you can see, from 60% to 80% over the last 8 years, slowly over time, seeing increased adherence, even with the addition of new sites to the treatment and management of hyperglycemia. If I look at measures that you think would be very rare events, like not giving a reversal agent, you can see kind of slow and steady climbing of and improvement in performance with things like the appropriate administration of reversal agents. And then, excessive tidal volume administration, again, even with the addition of new sites each and every year, you can see the message has gotten out through the dashboard and through the collaboration. I will say there are other measures which we haven't shown any progress in at all. Of course, I didn't include those in this talk, but if you look at, for example, our blood pressure measures, those are ones that, for interestingly enough, even with a lot of focus and a lot of publications in the literature, we really have shown, kind of marginal improvement, if any, performance across our collaborative over the last few years. And then finally, I just want to highlight a couple of challenges and opportunities. This is by no means exhaustive, just kind of scratches the surface of some of the things that I thought of as I was thinking about this talk. I think, our biggest opportunity and challenge is in systems in groups like the CQIs. Blue Cross of Michigan has been a great partner for us in helping to fund infrastructure at both the coordinating center level, but most importantly, at the institutional level. So, what institutions around the country pay for or have to self-fund, Blue Cross Blue Shield of Michigan funds for hospitals within the state of Michigan. It's really, been amazing at lowering the activation energy needed. It represents, honestly, only part of the cost to be able to join, but even that, partial funding has proven to really, really grease the wheels in terms of joining a group like Aspire or MPOG. And as Dr. Grant mentioned, there's been a lot of evidence to show that these CQIs have been successful, and we've really glommed on that. We've really used that to engage our sites within the state of Michigan and to have providers become really active members of MPOG. There's 2 programs within that. One is the P4P program, and the other is Pay for Performance, and the other is VBR, value-based reimbursements. Those are both incentive programs that we co-administer with Blue Cross Blue Shield. So Blue Cross Blue Shield provides funding either at the hospital level or at the provider level. We use charts like this to award points to institutions within the state of Michigan for either showing up, coming to the meetings, or for improvements in quality based on pre-specified quality measures. And based on performance, they can get either hospitals or sites can get anywhere from 2 to 7% uplift, which in a low margin hospital environment can make a big difference. Now, the opportunity is that money talks. When you throw dollars and you show dollars at something, it definitely grabs attention. There is a downside to that as well. We sometimes, the discussions, instead of being about, the implementation science or quality improvement, end up being about minutia around measure specifications because folks are worried that they're going to either, have a measure be flagged or not passed because of some issue which may or may not be relevant. And sometimes kind of getting involved in that minutia makes you kind of lose sight of the bigger quality improvement picture that you're trying to relay. All things considered, I think both of those programs really has helped us focus on specific quality improvement efforts within the state of Michigan. I think replicating that across other states, I think would be, amazing progress from a perioperative quality improvement perspective. We've launched a study with Dr. Zach Landis-Lewis et al., funded by the National Library of Medicine, on precision feedback. And so this is to take the standard MPOG email, add in feedback specific to a provider's preferences, or add feedback specific to a provider's performance. This is about to launch a pilot cluster randomized pilot trial and then a full cluster randomized trial next spring. And it's really to gauge if this software-enabled precision feedback service can improve compliance with measures. I think a really exciting component from a feedback perspective, and hoping that MPOG can really learn from this project to really take our provider feedback to the next level. And then, I wanted to throw in a couple of challenges. I think a big challenge we have is measure fatigue with 60+ measures across a bunch of subspecialties. Folks, providers, we've talked about provider burnout earlier. Getting a dozen measures that you're graded on every month, having practice leaders look at dozens of measures on their dashboard is a lot of work, and takes a lot of mental and emotional energy to process. I think, at MPOG, for every one measure that we've retired, we've probably built 10 measures. At some point, that ratio needs to get a little bit smaller. I think we need to think about, just because we can build a measure, should we? And then, I think the types of data that we have, in many ways, we're very accurate. Are we hitting the right target? Should we be focusing on things like patient-reported outcomes or clinician-reported outcomes instead of data from the EHR, which has been our mission, our sole mission over the last decade and a half, are some of the things that we need to think about. There's been some evidence to show that compliance with measures improved compliance with measures after the implementation of feedback occurs, but I think there's other evidence which shows that sometimes the measures are ignored, and so we need to grapple with that as well. And then finally, I want to just briefly discuss I think a major new opportunity, and that is using MPOG data to improve the experience of both learners and experienced physicians. And so I'm talking about anything from a basic assessment of the learner experience, what types of cases have learners or physicians or CRNAs been involved in. Are you seeing the right types of cases as a resident? You don't want to leave residency not having managed massive resuscitation or not having managed a number of difficult airways. How do you know that providers are getting that experience? I think using MPOG as a platform to ensure that, to expose that, I think will be a huge opportunity. And then taking it to the next step of competency-based training. If based on what MPOG knows about a provider's performance, someone mentioned that earlier in a question. Can we target education? Can we target training? based on specific knowledge gaps that we know a provider or an institution may have. Just a couple of thoughts. Would again love to hear from others about how they feel and regarding any of these opportunities and challenges. And with that, I would like to conclude and thank you all and hand the mic over to Dr. Lane Fall, and looking forward to the question and answer session in a few minutes. Thank you.
Thank you very much, Dr. Shah. It's a real pleasure to introduce our last speaker on this panel. Dr. Meghan Lane Fall is the Vice Chair of Inclusion, Diversity, and Equity. She's a David Longnecker Associate Professor of Anesthesiology and Critical Care, and her research focuses on implementation science in a perioperative setting. I'm really happy to have you here, and she's also, of course, the Vice President of APSF. So thank you for being on this panel.
All right, we'll do this. Anesthesiologists are all about workarounds. Okay. How about now? Nope. We're going to do this. All right. So I'm equipped with a unique set of skills, one of which is getting a program back on time. So it's my honor to cap off a wonderful day. I am going to sort of give my comments briefly so we have a lot of time for discussion. But you may have found yourself thinking there's been a lot of interesting innovations that have been presented. There's been a lot of really provocative conversation, but how do you actually get these innovations to the bedside? How do you get people to change their behavior? I don't have all the answers for you, but I do have some insights that I hope will help. So I'm going to talk to you about something that's near and dear to my heart, which is implementation science. I don't have any financial conflicts of interest to disclose. I do have a fair bit of grant funding from the agencies on the screen. And as Dr. Tan mentioned, I'm the VP of the APSF, which is a foundation, an organization that is very near and dear to my heart. I have a couple of objectives for you in the time that we have. I want you to be able to say what implementation science is. My bar is pretty low. And I want you to be able to describe the relevance of implementation science to emerging technologies. I'm going to give you first a reflexivity statement. So I do a lot of qualitative research. And one of the things that we do in qualitative research is we tell you who we are, because you want to understand who's talking to you so that you can contextualize what they tell you. So I wear a lot of hats, as many of you do. I'm an anesthesiologist. I'm trying to keep the patients alive. I get to wear zebra lead sometimes, which is fun. I spend most of my clinical time in the ICU taking care of surgical patients. And then the majority of my professional time is as a health services researcher, trying to understand how we deliver care, trying to make sure that we can achieve the outcomes that we set out to achieve. I run a social science lab that uses implementation science to improve patient care. So we're really focused on quality and safety. We do a lot of work around handoffs, but really it's using social science to generate insights about how to care for people and how to get teams to perform the ways that we think they ought to and that we think that they can. I'm the executive director of the Penn Implementation Science Center at the Leonard Davis Institute of Health Economics, which is a mouthful. We also are interested in using implementation science to improve care and outcomes. And there's a big part of my portfolio that's focused on health equity. So that will inflect and inform all of my comments. So I'm a co-lead for Accelerate Health Equity, which is an initiative to improve health outcomes in Philadelphia, where we have the dubious distinction of ranking 67th out of 67 counties in terms of health outcomes. So we've got a lot of room for improvement. And I'm also the co-lead of a newly funded NIH initiative to improve maternal health. And so our hub, Amethyst, is focused on using implementation science to improve maternal health. So I have mentioned this phrase a couple of times, but I want to tell you what implementation science is and what its relevance is to improving outcomes in health. Kevin Costner's character in The Field of Dreams said, if you build it, he will come. And I think in a lot of ways in healthcare, we think if we build the thing, if we make the new, shiny, great thing, they'll use it, right? That's all we have to do is make it. But we know that's not true. So if we think about what gets in the way of our reaching our goals for clinical care and reaching our goals for patient outcomes, some of those issues are related to access and getting the right thing to the right people. Some of those issues are related to knowledge and knowing what the right thing is to do. And I'd say a lot of what we heard today is related to building that knowledge. But sometimes we know what we're supposed to do and we don't do it. And that's where implementation science shines. So really what this field is about is bridging the evidence to practice gap and taking what we know and doing that last mile of delivery of getting it to people, getting it to systems. We have a lot of evidence-based practices in perioperative medicine. This is just a sampling. These are some of the things that we know we ought to be doing, and we don't do them. And so implementation science is one of those tools that we can use to try to understand how to bridge that performance gap. The official definition of implementation science comes from the flagship journal. So Eccles and Mittman said that it's the scientific study of methods to promote the systematic uptake of research findings and other evidence-based practices into routine practice to improve the quality and effectiveness of health services and care. It's a mouthful. It's a little awkward, but that's the official definition. My favorite definition actually comes from Ann Sales, who's a nurse by background, but is one of the godparents of implementation science. And she said, implementation science is the study of human behavior change under organizational constraints. And that's really what it is. That's distilling it down. So we're studying how to make people change and people that are embedded in organizations. So all of the theories and the concepts that apply to behavior change apply here. And everything we know about organizations, about management, applies here as well. So who should care about implementation? Everyone. But patients and families and caregivers come to us and they assume that they're receiving the best care. They think that we know what we ought to be doing and they expect us to deliver it to them. So they care about implementation a great deal. Researchers who are developing these innovations, other innovators, developers, you're doing the work you're doing because you want it to reach people and you want it to improve health or outcomes. And so you should care about implementation too. The clinicians that are delivering care to the patients, I in the ICU, I want to deliver the best care possible. I don't show up to work to deliver substandard care. Payers and health systems want to make sure that they're receiving value, and we've heard a lot about value today. And then regulators and legislators have an obligation to their populations to make sure that implementation happens. So I'd say it's everybody. My favorite cartoon about implementation says, I've never actually stormed a castle, but I've taken a bunch of siege management courses. It's sort of one thing to think about it and talk about it, and it's another thing to do it. So I want to share with you a few insights about how implementation can work. In the research realm, we think of implementation as late-stage translational research. So it's related to all the other research we do, but it's way on the end. It's T4, it's translating to populations, but it does fit in the whole biomedical research spectrum. A simpler way to think about implementation science is what we call the IMPSI subway that I developed with some colleagues. And basically, if you've been to DC, New York, Paris, pick your metro of interest, you start off here identifying a practice of interest. And so let's say it's post-operative monitoring on the ward. And then you ask yourself, has the practice of interest shown efficacy? Does it work? At a mechanistic level, does it work? If we don't know that, we should figure that out. That's really important. And you want to design for implementation, right? So you want innovations that are implementable, but that's not implementation science. If you have an innovation that you know works, and I think Dr. Khanna presented some provocative data that would suggest that we think this works, then we move on and we ask ourselves, has the practice of interest shown effectiveness? So in the real world, with real patients, with comorbidities, with clinicians that are busy with competing priorities, does it actually work? If we don't know, we can study that on its own, or we can study that along with implementation. And so everything that's in the lower right corner that's green, and Dr. Tremper, we did red-green, we did color blindness testing on this too. So I know the colors are different. Everything in the lower right corner is implementation science. Trying to understand the context in which these innovations are being implemented, what will make it easier or harder to get people to do it, which strategies work better than others. Admittedly, implementation science is a mutt of a field. So I told you it's human behavior change. I told you it's under organizational constraints. Any theory, any field that has anything to do with those concepts will feed into implementation science. So public health and program evaluation and psychology are sort of standards, along with management science and org theory, but increasingly systems and human factors engineering, and marketing too. There's a lot of marketing concepts that go into implementation. Audience segmentation, how do you deliver the right message to the right people in a compelling way? All of that's relevant to implementation. So what makes implementation science different than what we normally do? Why am I talking to you? Why is it important? There are 5 key features I want to share with you just briefly, I teach courses on this, so I can tell you about it ad nauseum, but I'm just briefly going to run through why this is different. We really focus on having a thing. There's an evidence-based practice that needs to be implemented. Now, the sort of bleeding edge of implementation science is applying these approaches to innovations that are still in development. So there are folks that are interested in applying these approaches more broadly. But generally speaking, we have a thing that we have a signal, we have an idea that it works. Otherwise, we're not using implementation science approaches. We do this work in partnership. And the concept of stakeholders has come up a couple of times, and I'm going to bring it up again later too. But this work needs to be done in partnership with the people whose behavior we're trying to change and the people whose outcomes are going to be influenced by the innovations that we're interested in. We don't do this by ourselves. This is not armchair science. And this is one of the key features of implementation that I would offer to you as important as we think about the adoption of emerging technologies, is you have to work with the people who are interested in the thing that you're interested in. Our outcomes are actually different than traditional effectiveness outcomes. So when I do an implementation science study, I'm interested in usability, feasibility, acceptability, appropriateness, adherence. I want to figure out, are people using the thing? How are they using it? Under what circumstances? How do they feel about it? And those are the things that we shoot for. Ultimately, we're trying to improve health, but implementation outcomes are proximal to that. The fourth thing that makes implementation science special is that we love context. Contextual nuance is great for us. All the stuff that makes a trialist insane, all the noise that a randomized controlled trialist doesn't want to see, we like the noise. The noise is information for us. So the nurse that says, oh yeah, we post this thing on the board and then this is how we do this process, but in this unit we do it this way, we love that. And that's the information we need to figure out whether something is going to fly or not. And then finally, we have specific language and methods and theories and frameworks. We have a whole taxonomy of implementation science that makes us a little bit special. There are some focal areas in implementation science that I'm not going to go into, but just so you know kind of what we're thinking about as a field, health equity is very important to us. There's a concept of de-implementation that I think is crucial. So our last speaker, Dr. Shah, alluded to all the quality measures that are coming out of MPOG, and you're creating 10 and then maybe sunsetting one, and at some point maybe that's got to change. We have a lot of things we do in healthcare that we ought not be doing anymore. And so there's a group of folks that are interested in figuring out how to de-implement. Policy dissemination is really important, and then I've highlighted in yellow here the ones that I think are most relevant to what we've talked about. There are some tensions in the field. We tend to do work in individual contexts, but we try to generalize lessons, and we're still trying to learn, if you do a study in 5 different ICUs, what does that mean for all of them? If you do a study in one community, how does that generalize to another? And we're still trying to figure that out. We have lots of imperfect evidence, and I would argue that some of what was presented here falls into that category. The best evidence we can generate is still flawed, and so we have to figure out what to do with that flawed evidence. We have to figure out how to spread and scale. So as we learn lessons, how do we make them bigger? How do we understand complexity? We are interested often in individual innovations, but how do those innovations slot into all of the other things that a clinician might have to do, or all the other issues that a patient has to consider? And how might those other priorities influence the implementation of the innovations that we're interested in? And then we want to balance speed and rigor. So we're doing this because we want to change. We want to foster improvements in health. We want to do that quickly because there are people that need our help now, but we don't want to do it so fast that we don't understand what's happening and why it's happening. There are 3 challenges I'll share with you. One is equity. There are lots of guidelines on how to do implementation work equitably. It's important for us to consider equity because there's a risk of us actually widening evidence to practice gaps instead of narrowing them if we're not thinking about all the different populations that might touch an innovation of interest. So there is this risk. There's also a question of when innovations are ready for implementation and what standards of evidence actually make sense. So I want to complete my time by talking about what implementation science has to teach us about adopting emerging technologies. So I've got 5 lessons for you here. I would say leverage qualitative data. We've talked a lot about big data here. It's often numeric data. Numeric data are great. There's a lot to learn from numeric data, but there's a lot to learn from talking to people and watching them and looking to see what they create. We're running a multi-center study now standardizing OR to ICU handoffs in 5 different health systems, 9 hospitals, 12 ICUs. Every one of them is laid out differently. So if I go into an ICU and I say, oh, you know, all you have to do is put these people in, you know, in the room and they'll talk to each other and you'll have a thing on the wall. And they're like, which wall? What wall space? We can't all fit in the room. And you don't learn these things unless you actually talk to people and look at their workflows and look at their work environment. So qualitative data can be really helpful in understanding whether implementation is going to fly or not. Workflow is paramount. Looking at Dr. Wenger in the crowd here, there's a lot of other folks that appreciate the importance of workflow. If you tell a nurse, here's one more thing to do, guess what? It's not happening, right? So you want to think about all the things that people have to do, and you want to make their work easier and smarter and not harder. But you want to consider all the systems that they work in. You want to make sure that you understand all of the other tasks that they have to perform. This is an example of a process map that we generated for work that we're doing in handoffs. What you're looking at is a swim lane diagram where every row is a person and every box is a task, and each person has a different workflow. So as we're thinking about changing behavior in all these different settings, we need to understand, well, what is the respiratory therapist doing? What's the nurse doing? What's the anesthetist doing? And it's only with that understanding that we can generate an innovation or an expectation that actually complements the workflow of the people that we're working with. You want to match your implementation strategies to context. And I will say here, relatedly, that education is necessary, but probably not sufficient. And one of the key findings, one of the key insights from implementation science is that you need to understand why people are behaving the way they're behaving. And if you want to change their behavior, you need to target that reason. And sometimes it's a knowledge deficit, in which case education is great, but often it's not. And if the knowledge deficit is not the issue, then educating them is not going to fix it. We have lots of complicated ways of dealing with this in implementation science. This is a logic diagram that takes determinants, contextual determinants on the left. We articulate change objectives, we determine implementation strategies, and then we measure outcomes. This is just to say that there is a systematic way to characterize context and then to come up with strategies that actually match the context. If the problem is that you have a poor culture of safety, the strategy is to target the culture of safety, right? If the issue is that you don't have enough outlets to plug in a new device, you give new outlets. But you need to target the strategies to the context in order for this to work. The fourth is to bring all the stakeholders to the table. I told you I would come back to this. This is something that's really, really important. And it's also important to appreciate that the incentives and priorities of the various stakeholders that you engage will differ. And so you may need to deliver one message to one stakeholder and a different message to a different stakeholder. And it's not being duplicitous. It's targeting the message and the information you have to people in a way that makes sense to them. So we do a lot of stakeholder engaged work. On the left, this is Deborah Grandison, who's one of our patient partners for our Maternal Health Equity Hub. She had a very difficult pregnancy and is really passionate about improving maternal health. And her perspectives on how to do this work are very different than mine, but just as important as we try to engage patients in the innovations that we're interested in. On the right, you see me talking to a couple of our ICU nurses in our handoff work and helping them understand what we're doing and what we're expecting them to do and getting their insights about how workable it is or not. And then finally, you need to design implementable and usable technologies. And this has come up again. You know, if you design something, and I think one of our speakers from Southern California said, you know, where am I going to plug in the thing? I'm in a hybrid OR. It's giant. I already have a lot of devices. Where am I going to plug in the thing that you want me to plug in? And will it work in the trauma bay on the right? Will it work in a low-income country? You have to think about whether the things that you're designing actually make sense for the settings that you have in mind. So hopefully that's something that comes up early in the design process and not something that's late. So these are the 5 key takeaways. I think we're doing okay on time. And I say thank you, and then I think we'll move to the panel. I've totally screwed up your mic situation.
Oh, I think it's fantastic. We have another one here. I'd like to invite all the speakers back up to the stage for a time of Q&A. If anyone has questions, please raise your hand or step up to a microphone. That'd be fantastic.
Okay. I can share with you. That's good. That's good.
Hello. Hi, my name is Sabaya Ranjavi. I'm from Philadelphia at Penn. All of these talks were incredible. I actually just wanted to share an idea or a comment that you were saying around education and using MPOG data around both educators and trainees. And I think it's phenomenal. I think we get very little feedback as educators on how well of a job we're doing, other than maybe end of rotation questions, but I don't think that those are very effective. And I'd be really interested to hear about, if you already have ideas on how you're going to collect that data, because you can obviously see, what cases they were in, but how are you going to collect data around what they thought about it, what outcomes there are, and then thinking longitudinally, what can you do from training to then practice, and what you can kind of tie together across that. But I think it's a very exciting area.
Thank you. Yes, I know, totally agree. Super, super exciting. I think the primary conversations that we've had to date with, both folks at the University of Michigan, as well as some other, thought leaders around the country, is using, existing MPOG data to help number one, understand the learner, the resident experience. Some of the examples I gave before: difficult airway, massive hemorrhage. Just following the ACGME case, or the case guidelines, are you meeting the index cases? Are you able to fill in gaps, knowledge gaps, based on information you've received from MPOG? But certainly, new data types with an MPOG is always a little bit more difficult. I think the primary focus is using on existing data, but I would be, maybe offline afterward, like really interested to see your thoughts and potentially connect you with some of the folks that are in this space right now at institutions like Vanderbilt and Michigan and OHSU and other places around the country.
I wanted to ask a question, and I think as we think about all the talks today, and as we focus on emerging technologies and patient safety, I think, wow, there's so much going on. There's industry, there's new technology, there's big data, there's qualitative data, there's implementation science, data science, there's clinicians. There are clinicians that are definitely not here in the room that we all work with every day across the entire spectrum of the perioperative area. What's the best way forward? What should we do? I'd love to hear actually your perspectives for all three of you. What should we be thinking about doing? And each institution is in a silo by itself as they try to incorporate and think about whether we should bring in some data-driven technology into our operating room. How would we go about that? And it almost seems like a consortium needs to be done to help individual institutions make these decisions for them.
So I have two thoughts about that. One is, whenever I'm dealing with a really sticky issue, sort of organizationally, I start thinking about strategic planning, which has been very helpful in helping organizations think through where they are. So doing some sort of needs assessment with respect to emerging technologies, what technologies you're using, where are your performance gaps, where are your opportunities, what kind of technology do you have in place, what kind of people do you have in place, and what skills do they have? And then moving from there to be strategic about which things you might target. As an organization, you might think about the ambulatory setting first, because that's where your biggest opportunities for improvement are, or you may think about other targeted settings. The second thought is that you need to have the right teams in place to do this work. And so you need people who have expertise in informatics. You need people that have expertise in change management of some kind. It could be implementation science. It could be quality improvement, performance improvement. You need to have really capable data analysts. But there's a human capital piece of this that I think is really important to invest in alongside something that looks like strategic planning to focus efforts.
I have a self-interest in how you care for old people. So I think that this session today has been great, and that our focus really needs to be on the floor and home. And we're really comfortable with the OR, and I think with Aspire and we got that. And I don't think we'll be lacking from things to improve upon and data about that, but we're really a void when you get to the floor. And that's, everything's a void there. Hopefully they make it out, maybe they don't. So I think this focus on floor, hospital at home, because that's where reduce healthcare costs and improve quality at the same time. We don't have enough clean kills in the OR. I mean, we used to. Anybody old as me? I mean, no capnometer, no pulse ox, no nothing. Blood pressure cuff by hand. You'd be horrified. I was horrified when I was doing it, so, but the changes made in the 80s and 90s really reduced that clean kill. Now it's improving on less, renal failure post-op, maybe less MI, maybe other things. But I think the huge opportunity is the fluoride at home. And when are you going to expand MPOG to that?
Yeah.
That's your job.
Right. Thank you. I think, from MPOG's perspective, I think one big thing that we talk about but have not found a solution to yet is to reduce the investment or the resources needed to join MPOG. I think, you saw the map earlier around the country. It's mainly the larger academic sites. There's a few community hospitals around the country, not many. Many of them are part of larger health systems within the state of Michigan. It's been, Blue Cross Blue Shield has really provided, a lot of the funding. There, it takes investment from the anesthesia department, from hospital leadership, from hospital IT. Those are real barriers at many institutions across the country. I think, Dr. Fleisher referred to FHIR standards earlier, having national standards of data integration and data sharing. I think, MPOG would certainly support a lot of what he was talking about, but reducing the activation energy, making it easier for an individual site, whether they're an Epic site or a Cerner site or some other anesthesia system or hospital HR to join. I think, is really the next way forward to enable collaboration, across a larger body of hospitals from our perspective.
For you, Nirav, about the 60 process and quality measures that you all roll out across your system. And to Dr. Canales' point earlier about her practice in LA, where she can work in the academic medical center and have all the resources, and then she goes to the community hospital and has fewer. In MPOG, do you need to adjust for resources that are part of your network? And if you do, how does that take place?
Yeah, I think, a primary issue, a challenge with an MPOG is that, for many of the institutions, under-resourced institutions, don't have the systems in place either from a IT perspective or hospital leadership to be able to commit, to make that investment to send the data. I think that is one, kind of structural component, which has been a huge issue for sites that have been interested in joining organizations like MPOG. And I think the other challenge we have is to make sure that the measures that we build or the QI initiatives that we build take into account things like social determinants of health, other measures of disparity or deprivation. I think right now that's a gap. There's ways to filter information by various demographic variables, but it is definitely a clear gap, and it's another area where I think there's both a challenge as well as an opportunity for not just for MPOG but other registries like and other quality improvement groups like us as well. Thank you.
Hi, Arnie Ibsejo, Mayo Clinic, Rochester. I know it's close to 5, but I think this is something that's going to hit all of us, and it's dear home to me. Nirav, it's a 2-part question for Nirav and Meghan. Nirav, MPOG, how have you leveraged it to address the staffing shortages issues that are affecting patient safety? And for Meghan, how do you foresee implementation science as being a big part of how we address that issue?
Okay, I'm first. Okay. Great question. It's funny. We have a summer MPOG QI summer Aspire meeting where all the hospitals that are members of MPOG join us. It happens to be in Lansing every year. Get about 35 hospitals representing maybe about 15 or 16 anesthesia departments or practices. And pretty much every single one came up to me this July and said, we are hiring. We need people. We don't have people. And that is a huge challenge because pretty much every quality improvement initiative, in Michigan medicine, maybe we're luckier than most, but across the state, and even across the country at many other academic institutions, quality improvement initiatives, other MPOG-related activities come out of personal time. It's because of passionate people. It's because people who are invested in it, they want to do anything that they can to improve care for their patient, make the time, and it is really challenging. And so I think, from our perspective, we need to think about, I do not think we've necessarily been successful at this, but we need to think about what are things that we can do to reduce the burden of the practice leader or committed individual. The one thing that we have been committed to from day one is to reduce the burden of abstraction. So, across all the CQIs within the state of Michigan, as an example, there's 19, I think Dr. Grant mentioned, 17 out of the 19 rely on a trained nurse abstractor at every site to pull data from the electronic health record and other sources and type it into another module, enter it in another module. And from the day one, MPOG, a part of our commitment is that we would never do that. We have steps to validate data across large data sets. We're never going to make an individual clinician or a QI expert, do data abstraction. And so, I think staying true to some of those fundamental tenets, is one thing we can do. But in many ways, it has been a challenge. I think the pandemic, started it, but it has not ended with the in this post-pandemic area. But how do you get folks to focus time when it is the most limited resource they have?
Is there a question about workforce in general? Just lack of anesthesiologists and CRNAs?
No, it was on how do you leverage what what Meghan knows, these different modalities to address one of the biggest issues right now in the country. Male Roch, not immune to it. Again, we have our own systems that we're trying to leverage these big data, but we're not winning. So just wondering.
Yeah, I agree with you. And I think this is one of the central challenges of our time right now, is to figure out workforce. And some of it has to do with getting more people, but that's not the only answer. We have to fundamentally change the way that we do work. And so in implementation science, and really this is where I think the intersection of implementation science and human factors engineering shines, and I'm looking at Matt and I'm curious what he would say. We have to look at how people do work. And there are certain ways of doing work that we're used to, but it's possible to get those same tasks done in a different way, potentially with a smaller number of people, or to do task shifting. And you see that a lot when you look at the literature on implementation in primary care, because there's a million innovations that people want to implement in primary care and get the primary care providers to do another thing. They don't have time. There's no time. They have negative time right now. And so there's an increasing trend toward task shifting, where you don't need the provider, either the nurse practitioner or the physician, to do a thing. You can train up someone else to do it. And I think similarly, we need to look at task shifting and figuring out innovative ways of getting the work done with the staff that we have. I do think it's an opportunity for emerging technologies. I think that if you go to a set of clinicians, you go to a health system, you go to a payer, and you say, I'm going to make work easier. My innovation is going to make work easier. It's going to take work away from folks in a good way. That you're going to get people to listen to you. And even in our sort of very specific example of standardizing handoffs, when we tell people, hey, this is actually going to make your job easier because you're not going to have to field a lot of calls after the patient gets to the ICU. If you participate in a standardized handoff, then you're not going to have to dig through the medical record to find the information you need. You're not going to have to make a million phone calls to figure out what the right vital signs are postoperatively, and it'll actually make your job easier. People listen. So I do think that there are some things that we can learn about improving the workforce and making sure that we have rewarding environments and all of those things. So there's some evidence-based management I think we could apply. But aside from that, just rethinking the ways we do work, I think, is going to be crucial to making sure that we can continue to provide the care that we want to.
Fantastic. With that, can we just thank all of our speakers on this last panel? Thank you very much. I want to hand the mic over to Dr. Feldman just for some brief announcements to close out the day.
Just a quick closeout. Thank you, everybody, for your attention and engagement. Reminder, if you haven't forgotten, there's a reception tonight at 6 o'clock. It's our chance to marinate some of the day and share our thoughts and ideas. Tomorrow morning, we are going to start 7:30, pretty much on time. Breakfast starts at 6:30. So really look forward to meeting and talking this evening and in the morning, and enjoy your night.
I screwed up your whole jam. That's all right.
Yeah, you're good now, Mike.